हो गया सर, आ गया, रेडी है, गुड है।
टाइम टू कॉल अप। 10 बजने का है ना। टीम के पास कट करो।
Yeah. Hi, sir.
Hi, can you hear me?
Yeah, very clear, sir. Can you hear us?
Yes, yes, yes.
Thank
Thank
you.
you.
Hi, Aaron.
Hi,
You
hi,
there?
morning. I just need to add the background just a minute.
Hello. Arun,
Hi, good morning.
I don't know if you can see me. Sunil Dutt here.
Oh, right, okay. I can't see you
You
directly.
yeah, well, yeah, I'm somewhere in the audience in
Okay, hi,
Mumbai.
hey.
Yeah.
Morning.
Morning, and congrats on the presidentship of the endoscopic ear surgery group
It is actually not it's a British Society of Otology group.
or British Society of Photography.
Yes,
Very
yes.
nice. Very nice.
Thank
Yeah.
you. Thank you
Arun
very
and
much.
I trained together in the UK and passed our exams together. Arun's a consultant ENT at Glasgow, and his special forte is in endoscopic ear surgery. He's scaled crazy strides in that forte. Welcome, Arun.
Thank you, Sunil.
Good morning,
Good morning,
Dr.
everybody.
Ashok.
Good
Hello,
morning,
hi.
Arun.
Good
Good
morning.
morning,
Hi,
Ashok.
Sunil.
Dr. Ashok, Dr. Narayan here. Hi, good morning.
Hi, Narayan. Hi, how are you?
And Dr. Arun, I'm Dr. Narayan Jaishankar.
Hi.
Hi.
I know you very well.
Thank you.
Thank you.
Yeah.
Good
Hello,
morning,
Sunil. How are you?
Dr. Arun. Good morning, Ashok. How are you doing? This is Ashim.
Good, thank you.
Ashim
Hi,
Desai.
Ashim. Hi.
Hi, good
Happy
morning.
birthday, and such a privilege to have
Thank you very much indeed. This is all thanks to my dear friends Ashish, who's cooked up all of this stuff.
Okay.
Great. So normally when you talk of birthdays, you talk of partying, but here you have Ashish making sure that he puts me, make sure that I'm hard at work. And thank you, gentlemen, for joining so early in the morning from England. It's 5 in the morning. I'm well aware, and both of you are fully dressed and ready to go, and that's amazing. And Arun, congratulations for your being presidency for the British Academy of Otology, British Society of Otology, I think.
Yes, yes. Thank you very much, Ashim. Thank you. Good morning. It was nice to meet you all, and I'm glad to be part of this first ride by Ashok's Global Rhinology Forum, and so actually a privilege that he's invited me as the first person to be part of this. Thank you, Ashok.
You're most welcome. This is Ashim, Ashish, and Dr. Satish. This is serendipity at its best. It just the opportunity came, and it is such a privilege to have it on our GRN platform. So as you know, this platform exists for now more than 13 years, but we're quite focused on rhinology, the sinus surgery, and the anterior surgery. Narayan is probably aware of the platform. He has delivered the literature lounge event for us. And now this is the first time we had an opportunity to accommodate the otology on it. So it's a privilege. And it is a special occasion as well, Ashim, for you. And I hope Arun don't mind saying this to me. At the same time, it is Arun's birthday as well. So what a coincidence. So happy birthday to both of you.
Okay.
Really
Happy
happy
that
birthday,
earlier.
Arun.
Okay, happy birthday, Arun. Happy birthday.
Thank you, thank you. I think what a way to celebrate first thing in the morning. Meeting all of you guys, and I'm.
So we
I hear
decided to
that.
let Ashim not cut the cake, but make a fenestra in the foot plate.
Yes, I know
that was the
Ashim,
sentiment
Oh, yeah.
which started this. Cake
it's
cutting
your
is so
birthday as
boring.
well,
Although we'll
Ashim,
have it
isn't
at the
it?
end of the day. Yeah. Yeah.
I heard that it is your birthday as well,
Hello,
Ashim.
everyone.
No. It is
Yeah.
Ashim's. There's a lot of confusion between our names.
Okay.
Hello, everyone.
Arun, you are not alone in confusing the two of us. I mean, since 1993, we've been together, comrades in arms, brothers more than anything else. And more often than not, people confuse the two of us. to my
Abba and
benefit and
Kranti, are you
Ashish.
online? If you wish, they can say hello.
And
Yes, sir.
Yeah, 1 minute. Yeah, okay. Hi, Kranti.
Hello, sir.
Welcome.
Hello, sir. Hello. Good
Hi,
morning, sir.
Kranti. How are you?
I'm fine, sir. Happy
Abba,
birthday, sir, first of
unless
all.
you talk, you can't come on the screen. So please make some noise. Kranti,
Hello,
thank you so
everyone.
much.
Hello, sir.
Okay.
Yeah.
I would like to now place on record
Hello.
very formally my sincere thanks to my dear Ashish
Oh, come
for
on.
having
Hello. Shut
set up
up.
all of this. And I don't know how to express my brotherhood for both Ashish and Satish. I mean, they are my two dearest friends
Hi,
on
Abba. Hi.
the planet, I would say. And it's my
No,
joy
hello,
for
Ashim.
the
All
last
that
25
not
years.
required. Please shut up, please.
Shut up.
Hello. Hello.
That for the past
Hello.
25 years,
Okay.
we've done courses
In the
together.
auditorium, wishing Arun and Ashim a very happy birthday. Can you all please hold the placards?
Happy birthday,
There
sir.
you
Oh,
go.
that's so nice.
Happy birthday,
sir.
Happy birthday.
Happy birthday.
Bro, don't be shy. Okay. Okay,
Thanks,
so we
guys.
have a very stirring panel in the auditorium. We are at the Harvard Business School classroom at the Taj Land's End. So that is why it's a very special venue we've chosen, worthy of Ashim's academic
Head low.
brilliance.
Head low.
And we have Sunil Narayan and Dr. Vijayendra sir conducting from the auditorium. But as a respect to the women that we really admire for their academic brilliance and the balance that they achieve, we have an online panel of 10 very young but bright and already big achievers in life. So Kranti and Abha will start the first hour. We've divided into 5 hours. And we really respect for their knowledge and for how they navigate their life. They will be there. So you all please feel free to contribute and ask questions or make comments. Abha, I've not heard your voice. I hope you can say hello.
Yeah, hello, sir. I can hear clearly. A very happy birthday to Aseem, sir, and all the best for this session. Thank you for having us here.
Okay, so we'll get going. This is a very, very informal thing because we don't do any other way of doing things.
Ashish,
So there's
may I
some
say something?
background noise.
Hello, Ashish.
Yeah, sure.
Hello.
I think we will soon be going live when you make starts. Just
We are
let me
ready,
know
we are
when to
ready.
go live on the platform. and
Hello,
then
Dr. Ashok.
we'll have to
Ashim, get
coordinate
going.
our
Get going.
questions and our interaction.
Yeah.
Because we're having Ashim will be having two communication coming from two sources. So we will make it all live when we are ready.
Hello, hello everyone.
Hello, sir.
Satish,
Good
hi.
morning,
Good
sir.
morning, sir.
Hi,
Good
Ashish.
morning, sir.
Hi, Satish. We can't see you.
Hi everyone on the screen. Dr. Ashok, Dr. Arun, and the
Hello.
champion Ashim. What a great day for.
Get started,
what a-
Satish. Ashok wants
Yes.
us to start. They have gone live on their network. So, Ashim,
Yeah,
go
just
ahead, please.
1 minute.
Yeah.
1 minute.
Okay, so-
I like to
Take your time,
enumerate where we are today. Ashim Desai is, we have been together for years and learned so much of wisdom from him. If you talk of otology, believe me, I have seen around the world, he's on the top of the planet of otology.
You're too
Talk
kind, bro.
of otology, Ashim Desai is one unmatched in the world. This is not about what I'm talking on his face or on his birthday. This is something we have realized, we have seen, and there is no controversy over it. And today we are celebrating his birthday at his best. What we can expect from a master. You will see, you will witness during live surgery the pearls of wisdom from him in the Stapes surgery. We all know Stapes is one of the finest surgery, requires highest level of diligence, and you'll see how he'll maneuver with both the hands together on the piston. The man who has done more than 6,000 Stapes surgeries, the man who cannot tolerate a 5 dB hearing loss on the table after putting the piston, the man who will never ever think twice before doing an intraoperative audiometry after placing the piston. This is something next level we are going to witness him. So guys, we have a great day to celebrate the master. We are celebrating not his birthday, we are being friends, we are celebrating his beginning of the old days as well. So Ashim, let's go ahead.
Satish, you've given me a lot of performance
Ashim, get
anxiety.
started, please. Get started.
Yeah, you've given me a lot of performance anxiety. Good morning, everybody. Thank you for
Already
these
told you how
kind
to
words,
crimp the piston.
Satish. I think you have a picture there now.
Yes, sir. We
We
have.
are,
Use,
I think the
you know,
picture is
not-
inverted because I'm operating on the left ear and this is showing the right ear. Invert the picture, please. Picture invert karo, yeah.
It doesn't matter here. To us, it's looking good.
Anyway,
Go
so
ahead.
this lady
Yes, yes.
has been already operated upon on her right side and she has a residual conductive hearing loss. What we'll do is we'll just go over the CT scan and audiogram and everything a little bit later, as soon as I've scrubbed out. But suffice it to say that she has bilateral conductive hearing loss. She was operated upon on the right side in December last year, and she has about a 30 dB residual loss as far as her right operated ear is concerned. She was operated in Ahmedabad somewhere. So, as is my routine, I like to choose the unoperated ear first because there are higher chances of a better result. In spite of doing the CT scans and so on and so forth, it's always better to do the unoperated ear. We always do a speech discrimination of the ear to be operated as well as the unoperated ear to make sure that we are not operating on an only hearing ear. I do realize rely a lot on my Rene and Weber's. If the Rene is negative, then at 512 negative, then and only then would I consider surgery. If Rene is positive, whatever the audiogram will say, I would not choose to operate. I think most people in the audience will probably concur with me. If there are any doubts, or please direct the questions via either Arun, Ashok, or Ashish, please. Be more than happy to answer the questions. Coming to imaging, I like to perform a CT scan in 3 or 4 situations. I do not perform it regularly in each and every case. I perform it in cases where a surgery has already been done, previously operated patient, a patient with severe mixed hearing loss where I am suspecting some other pathology, cases where a patient has been has concerning vertigo along with the hearing loss, and these are the cases where I would normally always do imaging. Imaging 0.6 millimeter cuts as far as possible, just so that we have a good visualization of the oval window. And we always like to look for a patent or cochlear aqueduct because of the and as well as dehiscence of the superior semicircular canal, as well as prolapse of the facial nerve. I
May I
think
add
a lot.
unilateral conductive loss. When you suspect those also
Yes,
cases, I've started doing CTs just to make sure that I'm dealing with autosclerosis. Yeah.
Absolutely, absolutely.
Please.
So, Ashish, a question over
now-
here from me. Narayan here.
Yes. Hi, Narayan. Good
hi.
morning. Thank you for joining us. Right and
Pleasure,
sharp,
pleasure.
short and sweet.
So, Ashim, just a quick question. I have started doing CT scans in all patients of autosclerosis. Okay. Why
Yeah.
did you only select a few of these categories of patients? Why not all patients? It tells you the anatomy,
honestly,
it keeps you aware, and today there's no harm in doing an radiology.
No, there is no
before-
harm at all. There's no harm at all. But a lot of my patients come in from very, very long distances. They're there in a hurry, so on and so forth. So I like to filter out only for expediency. There is really no harm.
Yes.
I completely agree with you. And it's a good thing, in fact, to do scans in each and every case.
Yes.
But what I also need to tell you is that even with a CT scan showing prolapse of the facial nerve, so on and so forth, I have in 32 years, I've had to abandon the surgery in just once. So in cases where there's a familial history, where there's bilateral hearing loss, conductive loss, so on and so forth, I have not yet found in all these years a situation where, because initially I started scanning all patients, but I have not yet found a situation where I needed not to scan. I mean, I needed to back down from a patient. So that is why I use this.
Okay,
Now-
Ashim, sorry. Please, before you go ahead with this, can you do an action replay of that earlier stroke that you did? And what were you doing, if you explain us?
All right.
Where the chorda is getting attached, yeah.
Okay, so basically what happens is that I like to use a gouge and hammer, a very ancient instrument, to remove the posterior superior overhang. For me, it's the greater expediency and greater control. So here you see I'm taking a right angle instrument and scoring the bone so that I have a precise line on which the fracture will occur. So it's like scoring glass. When you want to break glass, you just score it with a diamond tool, and then it breaks exactly where you want it.
Yeah.
So
this is also to protect the chorda, or so that the bone chip doesn't get entangled?
you see, you try not to disturb the chorda as much as possible. This is a 1 millimeter gouge.
And then you're putting it in the groove. You're engaging it in the groove.
Yeah.
Okay.
Yeah, I engage it in the groove and a little bit behind. You can see how I make sure that it cracks but is not displaced.
Yes.
Number 5. Long curve, please.
So there are a lot of young people watching this. Word of caution: Ashim is a talented sculptor. He did that very beautifully. He first coded it and then he sort of used a gouge and hammer. But the gouge and hammer may not be very controlled in a younger hand. So what are the other ways, Ashim, that you would recommend for the younger people?
You can use the curette. Most people use curettes. I've grown up using a gouge and hammer, so I use a gouge and hammer. I will also use a curette to smoothen everything out. And remember, when you have a large removal of the posterior superior overhang, I will replace this bony chip back. Why would I want to replace the bony chip back? Because I've seen in cases done by my father 30 to 40 years down the road, there's a small little retraction that starts developing. It's not even a pocket, but it's a retraction which may lead to something worse. Gauge hammer, please. And therefore, I like to...
Yeah,
Hello?
I agree with that.
Yeah.
So even I have seen some cases there retraction pocket. So if too much of this
small
thing,
retraction.
replace the bone.
Very
That's a
small
very good
retraction.
idea.
So, Aseem sir, are you
Professor
able to
Vijendra,
preserve?
nice to hear you. Thank you for
Yeah.
coming. I'm really
Happy
happy.
birthday,
Lovely to see you.
Asim.
Thank you, Professor.
I didn't want to miss
Aseem,
this
sir?
occasion.
I'm honored. Thank you.
Hello.
Thank you, Sunil, also for coming in. Yeah, curate.
Hello.
Yeah, hi. Yeah, tell me. Abba.
Sir, Aseem sir, are you always able to preserve chorda with this goose and hammer method?
Far better than with your curate.
Okay.
Far better
But you're
than with the
using
curate.
curate right now.
Yeah, that's just to smooth it out. That's it.
Okay.
You saw that one tiny stroke just to smooth it out. So now let's talk about exposure.
We're seeing
When
a
I
gel
want to
foam in the middle
expose,
here that you've kept. What is that, Ashim?
this is a local xylocaine gel foam.
Okay.
Xylocaine with adrenaline just to, you see, the sensory supply of the mucosa of the promontory is different from the external auditory canal. So these are all done under local anesthesia, adrenaline gel foam. So we like to kind of see, this is not relevant for the guys over at the UK across in the UK because they will do all cases in GA. But here in India, most of us, we do it under local anesthetic, and this is to sort of anesthetize the medial wall of the promontory,
So
of
the
the ear.
4% xylocaine?
2% actually. I don't use 4%. For some obscure reason, I'm averse to it. And as you know, surgery is a curious mix of habits, passions, preferences, and prejudices. So what is going to happen now is that we need to decide what is appropriate exposure. To me, exposure is 80% of my surgery. For me, I should see enough of the facial nerve, as you can see here. I should be able to see the processus pyramidalis in its whole so that I can reach the posterior crus. I should be able to see incus, the long process, but not so much of the long process that I can see the body of the incus.
Yeah. So
There are some mucosal bands, so I'm just mobilizing the chorda.
Sir, one
Ashim,
question.
Yeah, just a comment. You've done it very well. The removal of the posterior canal with the curette, with your gouge. But as somebody correctly pointed out, most of the youngsters wouldn't have even seen a curette being used in the ear, and
A
that's an
gouge in it.
elegant technique. But how much of exposure would you need? The other thing is that you're right. In the UK, most of the cases are done under GA, primarily because our patients, they don't they're not used to having anything under local anesthetic. The other thing is that I find the ears are much more, the ear canals are much more narrower in the UK than, when I see people from India. I don't know what is the exact reason for this. Maybe it's the cold weather and everything, but we tend to have slightly nicer, wider ear canals especially when I see my Asian patients.
But honestly, I don't know. Maybe it's anecdotal, but I see that 50-50. I do see narrow canals very frequently in India also, especially from North India. From North India, the canals are way narrower than in the South. I don't know. This again is anecdotal. Don't quote me on this. So now I have a beautiful view of the posterior
Ashim,
crus.
can I make 2 comments very quickly? Sunil here. Hi.
Yes. Hi, Sunil.
There is one other way of removing the caudal crest. The overhang is with skeeter. If you're familiar with the use of the skeeter, and let's say you're making a fenestra with the skeeter also, the skeeter is
you can.
useful for the overhang.
Absolutely. You can use a burr, you can use a 3mm diamond, 2mm diamond, and make a
Keratinize the chorda and then unroof it with a right
And the other
angle.
thing I'm seeing what you're doing is how's your speculum being held, Ashim? You're using both your hands.
From the external, I kind of support it with my ring finger.
Now that's
the speculum.
that's
You can
skill,
use a
okay?
speculum holder.
That is
but show the external camera, please.
I mean, this is what I would call peak detailing. If you guys are familiar.
Yeah, but that I think is important.
Yes.
So can you see an external picture? No, there is no external picture.
We can see as a PIP.
Neat. Very
Okay,
neat.
so can you see that? Yeah, focus.
He's also stabilizing his hand. His hand is not floating.
You see this?
Yeah.
So this is how I'm holding it. All right.
There's a
now
trolley
I'm going to remove the posterior crus with a skeeter. And the direction of drilling is posterior to anterior. I have already used my long curved needle to make sure that the stapes is fixed. And again, if you see from the outside, I'm stabilizing my right hand with my left hand and using a 0.7mm burr.
You're using
from posterior to anterior.
Yeah, and he's just about touching it. No pressure. This is just a light.
No pressure.
Yeah. And you look at the amount.
The concept is sandpapering. This is a very thick crust, as you can see.
Yeah.
fracturing this thick crust can mobilize a foot plate.
Yeah, I will sort of.
But the most accurate way of doing this, and the most stable way of doing this, is from posterior to anterior, because that is in the axis of the most stable axis of the
long axis of the foot plate.
yeah, the long axis, the most stable axis, because of the natural inclination of the stapes.
And your intent here is a complete crudotomy, posterior crust?
Yes, my intent is a complete crudotomy. I do not do the fish reverse stapedotomy, and I'll tell you why also, Lande. The reason being that once you anchor the piston and then remove the superstructure, there will be a slight lateral movement of the incus. The long incus, the long process of the incus will settle slightly laterally.
Settle?
Yeah, because you see what happens is just now it's held in place by the stapedius as well as the superstructure, right?
Yeah.
The moment that is, there will be lateral forces acting on it. That's why when you see, when you cut
healing
the
forces,
stapedius,
you mean? It will heal after post-op in a fraction of a millimeter more laterally?
a fraction can lateralize, and I've seen that causing residual losses in quite a few cases.
So relatively short piston.
Yeah, it is.
Ashim, in some
It is not
cases,
short to start with, number two.
Ashim, in some cases, the fascia nerve will be touching the posterior crust. You'll not have space to drill the crust.
Then I would not use a
you
drill, sir. Then I would not use a drill. I would actually drill part of the posterior crust and then stuff gel foam. If time permits, if Ashish permits, I'll show how I handle a prolapse fascial nerve.
Okay. We hope the next one is that for you. No, just kidding. No, but he also does, then in those cases, he goes inferior to the stapedius tendon and tries to drill.
They can
from there
drill
to
from the
weaken it.
promontorial side.
Yes, from the promontorial.
Yeah, you can drill from the promontorial side.
So Ashim, I'm going to make a small comment at this point. We have a lot of great surgeons in India who are doing all these cases under local. Okay, for a lesser mortal like me, where we have, when I was doing this step once, and once again when I was doing a stapedotomy, for example, 2 occasions the patient moved, and that was disastrous for me. Disastrous in the sense that I didn't give a complete loss, but there was a drop in the hearing. So I have changed my technique and made it into a local, from local into GA. And I find that very useful because all these steps, the patient is absolutely steady. Your patient here is brilliant, but everyone may not have this sort of stability of the patient. Your hand is stable, but if the patient does move, then I think
But if you stabilize your hand not on the operation table but on the patient's head, then everything moves simultaneously.
Yeah, but yes, we have done it for local for long, as you know, Ashim. But you know those 2 cases which I'm talking about. Okay.
I know. It can be extremely traumatic.
Yeah, so change to GA because I think Ashim does intraoperative audiometries, and that's useful to keep the patient under local. We don't do intraoperative audiometries. We do hanging, bending test and so on and so forth, and just leave that.
Narayan.
Yes, Satish.
Narayan. Yeah, Narayan. Operating stapes in the local has so many advantages.
Yeah.
What Ashim does, the intraoperating thing is one of them. See, it warns you from going into the wrong area.
Your audibility is little not
The
good.
vestibule. If you go into the vestibule too deeper, if you try to touch your vestibule and organs with a piston or something else, it warns you the patient will develop invariably the vertigo. And that is something warns you that you are going deeper and deeper. So that is the biggest advantage besides the hearing.
Ashim, canal ko clean karo, please.
Yeah, 1 second. I'll just flush everything out.
Satish, if someone can do something to your volume, it's very muffled.
Really? I don't know, but I can hear you well.
Yeah, your voice is muffled. We can hear you, but it's a little muffled.
I can bring my mic closer. But one thing is for sure, the stapes should be done under local anesthesia for the distinct advantage, as I mentioned. Number 2, about the facial nerve you mentioned. See, this facial prolapse is very well predictable by a preoperative CT scan. A good HRCT scan in the coronal section can tell you how much the facial nerve is collapsing down. It is something which can prepare you for dealing with this situation. It helps you counseling your patient in case your patient is too dangerous, you may have to take a call intraoperative that either you may have to abandon or you may have to do some maneuver which have
Scissors.
its own disadvantages. So this is something important to pick up on a pre-op CT scan.
Okay. Now what is happening is that I'm unable, because the pyramidal process is extremely prominent, and you can see that the stapes is extremely short. I cannot cut through it. So I'm going to drill away a little bit of the promontory. You can see I've got an incision.
The pyramidal, yeah.
Drill away a little bit of the pyramid.
It's very safe. There's no need to be afraid of drilling the pyramid.
Exactly.
More than autosclerosis, it is in tympanosclerosis where this is a very important step to go down to the base or beyond the base of the posterior crus. So when a chance comes in, you must drill, because that's an overhang now.
Number 5.
Yeah.
Now, one of the...
Sir, can I ask a question?
Yes, please.
Please.
So all the steps which you have just shown it's really nice. Just wanted to know your experience with laser versus skeeter.
I've done hundreds and hundreds of laser stapedotomies.
Yeah.
But my problem is that I found that 8K gets hit with a laser.
Okay.
I don't
Why
know
do
what
you
the
think
other...
that would happen, sir? Is there any
It's,
specific reason for that?
Every patient has said that there's a loud explosive sound at the point of hitting the thing. I've seen people wince and flinch with a 24 or 25 watts that the AcuPulse using this. So seeing 8K dip,
this is in
I've
local
gone back to
anesthesia
my
which
drill.
you're talking about.
Yeah, I only do it on the local, and I've
Okay,
seen that
okay.
the patient's experience. That is not the deterrent. The deterrent is the 8K dip and the little loss in discrimination. I do SDS in every case.
Yes, true.
Every case.
Okay.
So they say they hear sharp sounds, but they understand us. Okay, now when we want to focus on the anterior crus, a lot of people bang it against the promontory like this, but that can destabilize the foot plate. So what I instead do is twist the posterior crus around on the axis of the anterior crus like this.
So you rotate it basically.
Yeah, it's a rotation.
Ah, right.
So what happens is that this way you are very sure of not destabilizing your foot plate.
Brilliant. Yeah.
Not yet got a floater with this technique, forceps. So, it's something those who've done a post in orthopedic, the Colz's fracture, the skier's fracture. It's a twist.
So you don't use skeeter or anything to weaken the posterior crura or something, sir?
No, he did use.
I use the skeeter completely to drill through the posterior crus. It's only the anterior crus, Jelfo.
Yeah.
Okay.
So have you had a chance to, or had a patient in which you had to drill the anterior crus, not the
Yes,
along with
often.
Okay.
Yeah.
That's very
So now
thick, and
here
then
you can see this is mobile.
Yeah.
I've already done the CT scan in this patient. I know that there is no anterior malleal fixation.
You can see it well on a CT scan, the anterior malleal fixation.
I'll show you the scan at the end of this procedure. I know we've sort of inverted the steps a little bit.
Yeah.
So, sir, Ashim.
Now, what is this
Yeah.
soaked in?
This is actually steroid.
Okay. So, DEXA.
Simple,
And so
plain
what
simple
local
DEXA.
infiltration preparation you use for all your patients, like for infiltration?
All are the classic 2% xylocaine with adrenaline 1 in 100,000.
Okay.
So, Ashim, I don't know whether you gave the answer. Why don't you do a reverse stapedotomy? You started saying
I told
I
you
don't know.
because it gets. I feel that there is a little difference in the length in the alignment of the long process. It moves little laterally, and if you are extremely accurate about the length, then it can allow the superstructure. I mean, the piston to come out over a period of time.
But I think the more important reason is because he does vein interposition. And you can't do a vein interposition in the reverse stapedotomy.
Yeah, that is true. Also true.
But what
You see, again, I have nothing against a direct piston. I will do a direct piston in a case where I'm very confident that there is obliterative autosclerosis, a very thick foot plate. So on.
Or a narrow
The
knee.
reason is that the vein tends to refix.
Yeah.
And so, what are your choice of equipments? Like, what speculum are you using? And do you use always
Speculum,
microscope?
this
Or
speculum is 55 years old. This is from my father's set. It's by a company
still
called
working?
Richards, which no longer exists. Microscope is a Zeiss Tivato. It's a brilliant, brilliant microscope. I have a Vario in my other OT and the Tivato in this OT.
So
Both
you
are excellent
always
microscopes.
use microscope, or have you tried with endoscope as well?
I do not want to do staples with endoscope. So this is my measuring jig. This is
Sir, if you
about
can
4.
explain
Right?
your measurement, how do you take measurements
So to the
show your
midpoint of
jig?
the
Yeah.
yeah, 1 second. Okay, so can you see this?
A bit blurred, but yes, yeah.
We can see this.
Let me make it clearer.
Any comment
Yes.
on the
You see
foot
that?
plate, Ashim? Any
Okay,
comment?
so this is 4, 425, 45.
Yeah.
I place it on the foot plate, from the foot plate to the midpoint of
Midpoint
the
of
incus.
the
Can you see
long
that?
process of
Long
incus.
process of incus.
Incus.
So this is between 4.25 and 4.5. Now I will take a final call on the length after I place my piston in it and do my hanging and bending tests. Now you can see, if you can see very carefully, there is a little difference
Yes,
in the
uneven.
color of the foot
Upper
plate. So it's
two-thirds.
partly
Yes.
Color of the
thickened.
foot plate,
Upper
yes.
is white and yeah.
Yeah.
This
Correct.
And
focus is
little,
very,
The focus
little
is there.
depression also we can see.
yes,
Little
it's sort of
blackish.
a,
Yeah.
you
So the
cannot.
first thing you have to do is saucerize it.
Blue
Yeah.
line. Yeah.
Blue lines also.
What
So
size burr you are
Ashim, what
using,
is
sir?
the
This is actually,
what
I
is this?
use the Osteostab, that is a BNR, and you
It's
can
just
see that this is way better than a Skeeter.
okay. What's the size of the burr, sir, in this case?
0.7.
Okay.
In a
So you
narrow
would
foot
rather
plate, I
saucerize
use
the whole thing and then
0.6.
take the final.
Absolutely,
Yeah,
absolutely.
that's very important.
Most
Sir,
important is to have a flat surface to work with.
work with. And so how do you take up cases of obliterative footplate, if you could explain? I've just seen one of your videos of obliterative footplate, and that was excellent. So if you could just put some points in cases in which you have these kind of cases,
See,
and
again, in an
how do you
obliterative foot
suspect
plate,
that the patient is having? Yeah,
high frequency hearing loss,
right,
4K dip, and so on and so forth. And
right.
the most important thing when you're dealing with an obliterative focus is that you have to saucerize it. Here also, you can see I'm saucerizing. I'm
Yeah,
continuously.
He's running his burr all around. There's no tunneling here. And
yeah.
actually, this now has an implication on remeasuring the length. So it's just quite a thick foot plate. See the amount of bone dust. You train your
Bone
eyes
dust
to
coming.
look at the amount of bone dust that is being generated and sort of make a correlation between the thickness there. And the actually a 0.7 burr also acts as a measuring device. How much from
You see
before to
the
lower it is going down. It is telling you in that fraction of a millimeter. See, more than half of the burr is now going from that surface he has drilled. So this is almost like 0.3 is added to the length.
Yeah,
I
you'll have
would,
to use
yeah.
a
So I
longer
will
piston.
start in this case. Ashish is 100% right. I mean, I don't know why Ashish is not demonstrating case, because
It's
he
your
also
birthday.
absolutely. So you have to celebrate it by doing something for me too now.
Okay, okay, bro. The
So
question from
Ashim,
Sandeep Naidu
just
was, is gel foam is serving what purpose?
Just mop
For
up my bone
purpose.
dust.
Hemostasis
Jhadu
and
pocha.
Hemostasis, mop up.
Jhadu pocha.
clearing the area vision, field of
Yeah, yeah. You have
vision.
to clean the area properly. And you can see it's extremely thick posteriorly and superiorly, while
Yes.
anteriorly is blue. All right.
Mm.
Yes, sir.
So I say that
hello, Ashim.
once you see the
I just
footplate,
just
that
wanted
is
to ask,
reality.
what is the what is the size of the prosthesis that you use, the diameter? If you're using
The
0.7
diameter,
millimeter
typically,
drill,
if I'm going to make a 0.8 millimeter hole and a vein, which I'm proposing for this patient, I will be using a 0.4 millimeter piston. My favorite technique is a COS technique. Both me and Robert Vessa use this technique all the time. That is our go-to technique. Again, it's something that we like to have an immediate oval window seal and not rely on nature.
Hello.
Yeah, Satish.
Yes.
Yes. So what Ashim doing on the oval window by drilling the autosclerotic foci is very, very important. Those who are
Satish
using
sir, your
laser,
voice is not that clear. Muffled aa raha hai.
really? Am I not audible?
You're
It's
audible,
a
but
bit,
clarity is a bit
clarity is not there.
Maybe
doubtful.
something with the internet. But
Speech
one
discrimination
thing
is
is
a
very
problem.
clear. So one thing is very clear to know.
Audiogram is good. Speech discrimination is bad, Satish.
So those who are using laser should note that they should not use laser right on the autosclerotic foci. They should drill it
Yes,
down
drill it
to
first.
make the foot
True.
plate very, very clear and then use laser.
Yes, yes.
Yes, yes.
Agreed, sir. Totally.
It is not a situation where you should not be using a laser directly on an obliterative or a very thick foot plate. You are only generating a lot of heat.
Yes. And actually, it gets charred if you do that. So better is to saucerize, make it blue lined, and take the final shot. The best thing what you're doing out here, sir, is using gel foam and not using suction directly.
No, see, until you make a fenestra, you can use a suction, but I would still, somehow I find that the gel foam is more elegant and better. See, now everything is becoming more or less even, as you can see.
Blue.
Bit of a deviation on the chorda from Prasad, his brilliant observation. It's not retracted inferiorly, but you have kept it more or less in the
superior.
Yeah, well, that would have stretched it too much,
And his next point is, although the burr is touching it, it doesn't matter, right?
Well, I have not had
Yeah,
much
the
of an
shaft
issue.
is not selected. It's a skeeter kind of.
Ashish,
Yeah.
we have seen you keeping your flap intact over the chorda by retracting it inferiorly.
Yes.
To nourish it all the time and retracting as well.
Yeah. Correct.
Can you
We
do
have a
exactly
strategy
how
for handling the chorda.
Now you can see it's just through.
Yes. The whole is done now.
All this brilliant drilling you're seeing is only because his posterior superior overhang is brilliant.
Yes.
So therefore, his
Yeah, you
visual
need to
axis is
remove more.
divergent from his action of surgical stroke. That I think is the secret. He said 80% of the success of a stepidotomy is good overhang removal and exposure. Thanks, Ashim. Go ahead.
Just through,
Brilliant.
as you can see.
Yeah.
So you are making a 0.7 mm
0.8.
stepidotomy. 0.8. Okay. Yeah.
With a 0.7 burr, he'll make a 0.8.
0.8.
Yeah. And he
And
has
use a 0.4.
and
No,
0.4
0.8.
piston on a 0.8
No,
extra
piston.
size. Then the vein will sort of take care of the 0.2 on all over.
Oh, okay.
And
Okay.
then it's a 0.4 piston.
0.4 piston, which
0.4
comes. Yeah.
piston.
Sir, any particular preference for why would you use 0.4? Because as per many studies, obviously not much difference, but 0.6 versus
I will
0.4,
explain.
your opinion?
I will explain.
Yes, sir.
You see, there are two things. One is the efficiency of the movement, and the second thing is the effective moving area of the perilymph.
Yes.
Now, the
True.
effective moving area of the perilymph is 0.8 millimeters, while the maximum safety can be achieved with a 0.4 millimeter because that is the furthest from the utricle and the saccule. So it is lovely for the sweet spot. It's a lovely sweet spot for both of these. So I like the maximum moving surface, which is given, as well as an immediate oval window seal, which is given by our. Now here you see I'm again mopping with a gel foam.
Yes.
Now no more suction.
What
Can you see
about
that?
direct piston method? So in direct piston method,
Direct
again,
piston,
we
I would
cannot.
use a 0.6 millimeter hole with a
6
0.5 millimeter piston.
Yeah. 0.1 is the difference.
0.1 on each side.
Yes, sir. So you're using a pick to
Remove the debris.
Yeah, got it.
0.6 millimeter disc. Now
with
I have measuring discs. I do not trust my
think about
eyes
that little bone
to
test
think
in the
of the
fenestra.
diameter. So this is a 0.6 millimeter.
What he did, the 0.2 mm pick, you have to very gently fish it out. It's very, very important. If that goes inside,
0.4
when you put the piston, sometime patient post-op will have giddiness. So you have to fish it out. You have to remove that. For that, you should have that
Yes.
0.2 mm pick. This is a very crucial instrument you must have when you are doing stapes. Without this instrument, I'll never do stapes. So this is very, very important
Correct.
instrument, particularly when this bone dust goes or sometimes part of the foot plate goes inside. We can
Yeah.
put this instrument and pull it from medial to lateral. This is a very, very crucial instrument in stapes
2.5.
surgery.
Yeah, it's called the fish
So
hook.
I'm
2.5
completely in agreement with Professor Vijendra. He's absolutely right on that point. Now here again, I'm mopping up everything. Remember, I'm first mopping up the surroundings before I put it in the oval window area. Can you tell me why? The reason is that if it's a totally dry gel foam, the perilymph will get sucked out. So
Yeah.
this is a 0.4 millimeter disc. I know
Very
that it is going
important point what Ashim said, that vestibule should not be dry. So you should not make it a dry vestibule. So that's why he was
2.5.
sucking that, putting the gel foam away from the vestibule. That's a very, very important point. And also he is not using suction. That's another key point. He's not using suction. Even if you want to use suction, you should suck away from the vestibule. You should not suck the vestibule, and you should have 25 gauge needle to suck that. All these things are very, very important.
26 actually I use.
Yeah,
Yeah,
26
sorry,
section.
26.
So now
Away
we
from the
have a
vestibule.
nice clean fenestra.
Yes.
What I'm going to now, where a lot of you have seen Robert Vincent, because he's the one who talks a lot about the vein also. A lot of you have seen that he uses the measuring gauge to put the piston in, and he puts the vein before he puts the piston. Now the thing here is that once you put the vein, the precision of the measurement may not be achieved. So what I like to do is first put the piston, do my hanging test, bending test, and once I am convinced that the length is correct, then and only then I'll put my vein. Then I'll widen the fenestra and then put the vein.
So you always use
Because
this
of this
Teflon
excessive
piston, Sashi?
drilling, I would like to start with a 4.5 millimeter burr, 4.5 millimeter long piston.
So Ashim, choice of piston?
This is a Grace Teflon. Here again, I diverge from my dearest friend on this planet, Dr. Satish, who uses a titanium. I'm very happy with this Grace thing. The reason I like to use Teflon is that I can tailor it to 1/8 of a millimeter. So sometimes you find that 0.25 millimeters is not what you want. So you cut it in between the two notches. So you can have a 0.
We also always use this Grace Teflon piston.
Yeah.
The reason is this we have been using from so many years. We don't have any problem. But in my center, I see a lot of revision cases. So I see where the titanium is being used. Many cases, the incus will get necrosed. I've seen so many cases. Probably in this year, last year, I must have seen about 4 or 5 cases done in my good center, titanium, where the incus is necrosed. So, but this we have been using for more than 30 years. My boss is using for more than 50 years. We don't have any problem. The message in Stapes surgery is when you don't have any problem, don't try to change. Stick to it. Never change the winning horse. So that's why always I use only Teflon piston, and these gyrus pistons are excellent because if you take this gyrus piston, the diameter if they give as 0.4, exactly it will be 0.4. If you take these local
And it's
pistons,
round. The Indian ones are
It's a,
occasionally
Indian ones will
octagonal.
have hexagonal. Yeah, if you see it in microscope,
it will be
I have seen
not round.
not round, and they are
regular.
like these sharp. If you see it carefully, it's almost like hexagon. The
Correct.
tip, so that becomes a problem. So Grace is one of the best, which
Correct.
I have used since years now.
Yeah, I
So
think
what is the
Teflon
size
is a
which you
very
cut,
good.
sir? What was the size you
This I
cut?
started with 4.5.
5, yeah.
4.5, and this is 0.4 millimeter piston.
Right.
Now I am again going to clean out the area of the oval window, and I will do my hanging test and bending test.
So how much was the measurement you did? with the measuring
Initially, I was
between.
4.25, probably a little more than 4.25.
So you added
And then I
0.25
drilled
to
and
it
drilled. Yeah,
Yeah,
so then I
because
added a little 0.25 to it to start with.
to begin
This
with.
is not my final length. This is just an andaz that I'm putting. Now, you can see
yeah,
I'm going to do the hanging test,
yeah,
So what is this
and it's a
hanging
bit too
test?
long. I'm
hanging and
pulling it
bending
out.
test. Yeah.
This is the hanging test. I'm trying to get the piston to hang on the edge of the foot plate, and it's not coming out. That means it's a little too long. So I will remove 0.125 millimeters.
He tries to lift up the incus and see if the lower end of the piston comes on the edge of the foot plate. That did not happen. So therefore, he's
Okay.
going to cut it a little bit short. That is his hanging test.
And what is bending
Because
test?
Bending
when you
is
push the piston against the edge of the foot plate, it should not jump out.
so if it is too
Okay.
short, then it will come out like a pendulum. No, it will come out. So
So
it
now
Okay.
this is what I was talking, exactly half of what was 4.25, 4.5. So this is
So what is the
4.375.
blade you are using, Sheep?
Shaving blade, Wilkinson shaving blade, what they use old time, this one.
Yeah, that
Okay.
is very important. That point you should tell. No,
Ah.
it's because it's sharply cut. If you use a 15 number blade, you'll not get that
Yeah.
sharp cut. So this is a
I,
very
you will get
important
frayed
point.
edges.
Even I use this Wilkinson blade only. You keep it parallel to the measuring gig and you cut it nicely. It slices exactly. The lower end will be very sharp. The
so
same
11
thing if you
number
cut
also
in
is good.
15 number
Okay.
blade, lower end will not be sharp. It will be little conical or some tip will be left behind. So this is a very important point to be noted. You should use a razor blade so that cuts the piston lower end very correctly.
At this point, I'd like to place on record my gratitude for my sister of 30 years, Rashmi. She's always been with me through thick and thin. My anesthetist, Dr. Sonal, who's been with us for almost 28 years or so. And my latest addition to my team, Dr. Priyank Talati, he is the one who's taken the incision and got the case ready, taken the vein, and so on and so forth. Very up and coming young guy, very sincere, very focused. And I'm grateful to all of them for having spared their Sunday and come to join us.
Thank you, Team
And
Desai.
I would like to acknowledge that Priyank has a good head on his shoulders. I think he will be good to uphold our principles. See now this again. Now can you see it's coming out?
Yeah.
Yeah.
Yes.
This is the perfect length.
Okay.
So this is not 425. This is not 4.5. This is 4.375. This
That's very
is the
accurate.
obsession with accuracy that I would want the juniors to learn.
And that's
So
why
can
So now,
you
not the titanium.
so can you once again demonstrate the jumping
Jig.
and back
Once
bending
give me a
test?
second. Let me prepare the way and I'll do it again.
Yes,
No
sir.
issues. Wait, please.
So now your piston is parked there or you got it out?
No. It's parked there.
It's parked there. Okay. On the edge.
It's occupying the old window.
Oh, okay.
Okay. Sir, if you can explain your vein harvest and how
Okay,
do
so
you
this is
do
from the
this?
dorsum of the hand.
Yeah.
And I am now threading it on my 0 point. It's on a blunt needle. I'll put it against, you get a green cloth, so you get a better contrast. 15. I want to remove the perivenous adventitia.
The head doesn't have too many things in it.
So it's gently removed.
No, you know the optics and the resolution. Yeah.
So what are the advantages of using vein over
Immediate
fat
oval
or
window seal. Immediate oval window seal. You don't have to pray for the endosteal membrane to form.
so you've always used
Again,
vein graft?
no, except in obliterative autosclerosis, I
Obliterative.
always. Yeah.
Okay.
There's a little kink in the vein
Mm-hmm.
there.
So if and when you need to revise your own case, or if you're the previously done vein interposition and you're revising, what is happening there? versus when you are revising a direct piston? Are we seeing anything different there?
Honestly, what happens is that most of the vein that is overlying the promontory has been absorbed. Okay?
What is happening to the one over the fenestra?
It remains as an endosteal blue membrane unless there is reobliteration for whatever reason. So whatever, when you see it, when you try and revise a vein vis-a-vis revising a direct piston,
Yeah.
on table you don't see too much of
The
a
fenestra
difference.
looks the same in both the cases.
Partly, not 100%, but partly. Scissors.
Have you seen
Sorry?
reobliteration, Ashim?
I have seen reobliteration in direct piston, in vein, in everything.
Mainly in obliterative.
But I have seen that if I use vein in obliterative autosclerosis, 15, there is a higher chance of reobliteration. Therefore, I do not use vein in obliterative autosclerosis. I think it's more of a mesenchymal reaction. Number 5, measuring gauge.
Your razor blade.
Again, I do not like to trust my eyes. I will use this. I want a 0.5. I want a 5 millimeter by 5 millimeter.
5 by 5, the size of the vein graft.
Okay.
For the vein. So you can see that this is 4.5 plus a little bit I'm
More.
adding. Yeah.
Which
So
side?
just this 5 by 5 is constant for all your cases?
Mostly, yes,
Mostly.
because you see the oval window is fairly constant in its size.
Constant. Mhm.
And I like to round off the edges.
Round off.
Why is that so?
You don't have, nature does not have sharp edges. So that is a very philosophic statement. The real reason is that you don't want the edge kind of invaginating into the oval window unrecognized. Measure. 1 second. This is around
This is
very
5.
artistic. It's a very artistic way of cutting the, I can see how you even move the knife. Very nice way of cutting it, as you can
Thank
see.
you.
Well trained in the kitchen.
So now we have a 5 by 5 millimeter.
Ashim, not everything we do with surgery has to be scientifically very valid. I mean, science is very important.
No.
But I
What was
think
my first
artistry,
statement of Sunil, my brother?
artistry is also important. You making it look beautiful and elegant. Yeah.
You are too kind, Sunil.
Clean.
That's very kind. But one thing that we have to say is habits, passions, preferences, and prejudices. Unfortunately,
This was such a nice line, sir.
I'll quote you on that. Please
Yeah,
put that
this
in
is a
Vanta.
very
Go
good
ahead.
quote.
Yes.
And
So
so very
now-
apt. Yeah. So this is the final size you will take even after the vein graft is put there?
That is correct. Absolutely. Now I will enlarge it to 0.8 millimeters.
Okay.
So Abha, for our direct piston, this is a short piston.
Okay.
Now the thickness of the vein is going to add to it.
Okay,
So-
sir.
No, Ashish, I'm sorry to digress. I'm sorry to differ. This is not a short
Acha.
piston even for a direct. I would do exactly the same for a direct piston.
Really?
Okay.
So with the hanging test, I thought it would be little.
So what do
Little
you
longer.
mean by direct piston here?
Then Abha, the thing
Without
like
the vein
the way
graft.
we use without the vein graft.
Without the vein
Okay,
graft.
okay,
The
okay.
one
The way
which we all do.
the superior Stapes
No.
surgeon do. This is for.
Okay.
The superior surgeon will not need a vein. I need a vein.
It's in vein, putting the vein. Sorry. No, just kidding.
For
Satish
those
sir
who
is
didn't-
telling something. Yeah.
So this was Sunil. For
Oh,
those
sorry,
who
sorry.
said, who didn't get who was Robert Vincent is how we know him.
Yeah.
Yeah. And how many times Ashim's been to the Cos clinic or even the fish clinic and I don't know who else, Portman's also, I think. I know because I've kind of grown with Ashim. Ashim was my 6-month senior in KM. He taught me the basics of ENT. He taught me my first tracheostomy. So Ashim has been one of those prodigious sons of a stalwart ENT surgeon, and how beautifully you picked up everything your dad has taught, and perhaps even excelled him. Dad would be proud.
True.
Sunil, coming from an
Just widen
accomplished
it.
surgeon like
You
yourself,
just
I consider this high praise. Thank you very much indeed. You're too kind.
so did you
Okay,
just
now,
widen the 0.4 to
yeah,
a
I did widen the
Yeah.
fenestra because that was a slightly smallish fenestra, 0.8 millimeter disc.
so earlier he had a disc with which he measured the diameter.
So this is 0.8 millimeters.
Yeah. So this is your
This is
final
exactly, this is my final. This is exactly so.
final. Okay.
Medium. Vein.
So this disc is just for measurement, or you just
Yeah.
use
No,
this
this is
disc?
this
Okay.
I have 0.4, 0.6, and 0.8 measurement discs because I
Okay.
don't trust my eyes to do the measurement of the fenestra.
Okay.
So now I will put my vein in.
Deepak's question to you, you all mention in the notes bubble not broken. So what's the
Yes.
champagne bubbles doing there?
The champagne bubble is, we have to, what happens is that the surface tension of the perineum should keep shining away at you. Rashmi, please.
And so where is the bubble?
The bubble, now bubble is when you are actually drilling the footplate and all that. Then you should not see that surface tension break, release. If you see that bubble surface tension break, you call it bubble broken.
So is that
Okay.
connected with the endosteal
So,
membrane?
so the side of the vein, which side, or do you mark it,
Okay,
or
the
either
alignment
of
of
the
the vein.
side?
The alignment of the
Yes.
vein is that the adventitia faces the oval window, the intima faces the surgeon. Please remember one thing, that the vein is the smoothest surface of the endothelium of the vein is the smoothest surface in the body. So it is the only thing that guarantees that no fixation and no adhesions will occur. Give me a barik one.
So, but when you're putting the vein at the stapes, no, at the Stapes hole, how do you ensure that the intima faces you up,
You saw
faces
that
upward?
little potly. You saw that little potly of gel foam that I had made.
Yes.
Yeah.
Oh, okay. Okay. Right.
Okay.
So you wrapped
Still
it
there.
beforehand and then put it down.
Yes, correct.
Got it. Yeah.
Any precautions while placing this vein graft? What you're doing here?
Well, you must make sure that you have you don't suck away the perilymph while you're putting it in, for sure.
That it's not
And
too
you must make sure that the intima is
Facing
facing the
you.
surgeon and the adventitia is facing the oval window.
Okay.
What happens if it's the other way around?
The chance of adhesions exist.
Adhesions between?
Between the long process of the incus, promontory, so on and so forth. Blockchain.
Ashish. Hello.
Yeah, Satish.
See, if you face the intima down,
Yeah.
it will not stick to the mucosal surface, raw area. But
Right.
if you leave the upper raw area laterally faced, if the vein, sometime bulges, it may stick to the incus or wherever it comes in contact with and make adhesion.
Okay.
So the intima should be facing laterally,
Laterally. Okay.
which is not a raw area, and it is not going to make any contact.
Okay. Got it. So it's now like
Absolutely
a
right.
nature silastic. Yeah.
For me, the intima is like silastic.
Yeah. So now we see that the vein is touching a bit of the undersurface of the long process. Does it matter?
I will spread it out once I
spread
put it in. You see, as the piston goes in, the vein will invaginate inwards, right?
Okay.
Then we'll spread it out.
Will you repeat your sentence about silastic?
No, it's like nature silastic. Yeah. About the
Ashish.
intima. The intima of the vein. Yeah, Satish.
Besides the distinct advantages what Ashim mentioned about the vein,
Yeah.
the biggest one I feel is This vein graft prevents you from putting an overlocked piston. If you
Overlock.
try to put an overlocked piston,
Hmm.
the vein will invaginate and give you the warning that your
Ah,
piston is longer
right.
than required.
Okay. Hashim, your
If you
comment
have
on
a
that?
vein,
I
if you have a
completely
vein at the
agree with
back,
that.
Hmm.
If you remember on my oration, there's a slide that does exactly that. So now what I'm going to do is use this
Yeah, yeah. Now
needle.
this is the crimping which Hashim, sorry, don't finish it too fast. Okay. This is what Satish was saying. The two-hand crimping. He's not using a crimping forceps, but fantastic.
I know I will again tighten it, but the advantage of using
Yeah.
this two-hand technique is that you allow the adaptation of the curve better around the incus, It's a
Yes.
better adaptation of the curve around the incus.
And
And the final tightening, of course, is with your forceps. And I don't use a crimping forceps actually. I just use a plain, simple there.
Crocodile. Yeah.
now he
Plain,
can't.
simple crocodile, yeah. So that is about it. Now, what
Excellent.
happens is that I will look for the round window reflex, long
Yes.
curved. This patient had obviously mucosal injury in the past. He must have had CSOM, couple of episodes. There are a lot of mucosal tags. Can you see them?
Yes,
Sir,
Yes,
during
sir.
this only, if I would like to ask your protocol for patients who would have middle ear infections and autosclerosis issue. So what's your
If
protocol for such patients?
Okay, one moment, please.
Yeah, sure.
Can you see the round
Yeah,
window
very
reflex?
nice.
Yeah,
Very
very
nice,
nice.
sir.
Yes.
Very nice.
Okay,
Beautiful.
so
Beautiful.
to answer your question, one is that scanning is a must, 100%.
Yes.
If you have clouding of the mastoid and so on and so forth, you have to treat that accordingly.
Mhm.
Second one, if you have a central perforation, I'm assuming your question is that if you have a central
Yes,
perforation.
exactly. Yes,
So
yes.
if it's a dry central perforation and clean mastoid, you can do both techniques at the same time.
Same
If you
time.
do
That is
not
what I
have a
was asking.
dry central perforation,
Yeah.
if you do not have a dry central perforation, of course, you do a tympanoplasty with or without a cortical mastoid, and then at a second stage, do this. And the way to predict this for the patient with a central perforation is to do a gel form patch test in the OPD.
Okay.
So if you're doing a gel
say
form
for a
patch
dry,
test in the OPD.
sorry, did you say for a dry perforation you can do tympanoplasty and
Yes,
stapes?
absolutely. If your
Together.
CT scan
Together.
is normal
It's
and you
one
just
stage.
have a hole, it's a one-stage procedure. You can close the hole as well as this.
But Ashim, what is
Now, the last step
now?
here.
What is dry now could be wet tomorrow.
No, but why is it becoming wet? Because it's open. If your mastoid shows no infection, then you can go ahead and do it at the same. That's why I said you have to scan the patient. So now if you
But
see, Ashish,
I'll never
we
do
have
it if perforation is there.
anterior to make sure
Because
that
if
we are
perforation is
visualizing the
there,
anterior malleol ligament.
middle ear is considered as unsterile. So Hugo Fish is very, very clear. He says never open the vestibule when it is unsterile. So perforation is there, better to close it. Don't take a chance in Stapes surgery. It is a one-go procedure. Something goes wrong is forever it goes. So always better
That
to
is true.
close the perforation and stage it and do
I'm
it.
with Vijendra on that. Yeah.
Yeah, when in doubt, do so. But if you have a 2 millimeter, 3 millimeter perforation, sir, and your mastoid is clear, there's no granulation, no edema, no mucosa thickening, then I think you can go ahead. But I'm not going to disagree that you can do it in 2 stages. So, lastly, what I had done is I placed the corda on top of the
Yes.
Of the prosthesis.
Piston, yeah.
prosthesis.
So you told you would be using that small bony chip there where you have gouged
Yeah,
it
I'll show
earlier.
you. I'll show you exactly.
Yeah,
I'll show
this
you
I
how
was
I'm going to
interested
do
in
it.
seeing that. Yeah.
You don't use any
Yeah.
gel forms here, sir?
No.
Do you
No,
prefer to
you
bring the
don't need
carda
to.
in front or rather they keep it over it?
Over it, sir, because
Over
sometimes
it.
what happens, these people end up with some sort of negative pressure in the middle ear. The piston then directly touches the drum, which makes me uncomfortable, maybe unfoundedly, but it makes me uncomfortable. Bone.
Keep it in front, it protects the piston slipping down.
By keeping corda
Again,
like this, it also stabilizes your piston.
well,
He's saying
again,
keep it
there's many
inferior to the
ways of
loop
skinning a
so the
cat.
loop does not
Many
slip
ways to
down.
skin a
Yeah.
cat. I have no problems with piston being kept anterior, I mean the chorda being kept anteriorly, but it all depends on how, whether now this lady had some mucosal injury in the past. She had those mucosal bands, some adhesions, so on and so forth. So she may be prone to frequent infection. I don't know. So I have tried to mitigate the risk by using a vein interposition and mitigate the posterior superior quadrant by using this bone chip and so on and so forth. I mean, I've done what I can to mitigate the issues.
So, Ashim, I tried this bone chip thing, but I had to revise my own case because this bone chip migrated and it fixed the incus. So
Oh,
I was just going to ask this question, that it's a free piece of bone.
never ever, yeah.
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 I have never yet had a
Depends upon
problem with
how you keep that. It should be more lateral, not medial. If it goes medial,
this
such
is,
things can
this is
happen. See
locked
here,
in place.
Yeah, there in your groove, you have sort of, yeah, like the cartilage.
Yeah, it kind
be
of so
nice.
that you saw me cut away a little bit, right?
Yeah.
Yeah, so that's it. You don't need to cut it away.
Prasad is asking, can that chip be extruded? Can it get extruded?
It's autologous bone. I have not seen it extrude ever. It can. I mean, anything can, but I have not seen it.
Asim sir, if you can tell us what are the audiological battery of tests you do in these cases, and if it's a bilateral disease, how do you decide which ear to operate upon?
Okay, give me one moment, please.
So you will be discussing the audiology and
you.
radiology for this patient again?
The other case ready?
Yeah, that's it.
Can I make a request, Ashish, as one of the seniors in the audience? I think the audience questions, interactions should be related to what is being just done, instead of generalizing audiological protocols and various other things that can be done at a free time later.
No, actually, we can do that once I come to the auditorium.
Once you come to the
Yeah.
auditorium, which is what I
Yeah.
thought.
Okay.
Yeah.
Yeah, sure.
Okay, so what I'm going to Ben જાગી જાઓ. કાનમાં પીપ પીપ કરીને અવાજ આવે ને, આપણે કાનમાં ટેસ્ટિંગનો અવાજ આવે ને તો હાથને પછાડજો. ઓકે, મશીનનો અવાજ
Now
આવશે.
the intraop audiogram
આપણે
that is
testing. So
demonstrated.
I will do the intraoperative audiogram. Open it fully.
Tivato. Long time back he bought.
Blue, no?
That is Dr. Sonal who just handed over the headphones to him. Hi, Sonal. Okay.
Check. બેન કાનમાં અવાજ આવે તો આ હાથને જોરથી પછાડજો.
શું કરે છે હાથથી જોડતી?
Ashish, your voice is going there.
Beep, beep.
અવાજ આવ્યો? Can you mute the... કાનમાં અવાજ આવે ને તો હાથને પછાડજો.
I think that vein is coming in the way of transmission. This is the big advantage of having the anesthetist with you for many years. She's doubled up as an audiologist. Yeah. So she's responding with her hand. You can see the hand movement, the left side.
Ashish, under local, that lady must be listening to all our shit over here.
Yeah, yeah. But we are not talking Gujarati, no? It's okay. That also some smart patient will tell you, but दूसरा कान बंद करो.
So I don't do up to 4K, only up to 2K. Just I need to know that I have improved the hearing to a greater or lesser extent.
I think when they have a thin drum, thin ear drum, then I have seen them reinforce it with the perichondrium, and you can get a 5 dB improvement. the old
आवाज
heel
आवे तो हाथ
perforation,
पछाड़ो.
intact drum, and you do a stepidotomy. And I was actually present in the OR when that was being done. And then they reinforced it and
Okay, so I have a 20, 20, 40, 40. So the previous, she has
Excellent.
the bone of 15, 25, 30, 45. So now that was, of course, a Carhart correction. So I'm quite happy with the way it's progressed. Everything's all right.
we are
And
happy that you
so
are
that's the
happy.
end of the
Nice.
surgery.
Excellent, sir.
Yes.
Excellent. So this is
Thank you. I'm sorry, I am an
audiogram.
exceedingly painfully slow surgeon. I'm not very, there's no showmanship about it. So I'm sorry for the slow procedure.
Is the patient happy, Ashim? Did you ask her if she is happy?
Yeah, she is delighted
Okay.
because the other one was bad after her surgery. કેમ છે બેન મજા આવી ગઈ ને? હા. She said મજા આવી ગઈ.
I didn't see her smile.
मजा भी गई.
Now she has to face the hard part, paying his bill.
And sir, in the canal, would you like to just keep gel foams on the
Yes, I
incision,
would.
or
I
do you
would
fill?
actually, I
Do
would.
you
I am
fill the
putting gel
canal
foam.
with gel foam or just the
No,
incision line?
never.
Never.
Just see, I'll show you.
Okay.
1 second. Yeah. So this is dipped in antibiotic and ointment. Antibiotic
As
ointment.
Vaishali Bafna
Which
and
antibiotic you use, sir?
Which
please say hi.
Simple Neosporin, Ciplox D, and Nuflucon.
Okay. And so post-op antibiotic and post-op
5
your
days,
students.
5 days oral antibiotic and steroids.
Okay.
Any
All of it
Stemitil,
oral.
Stemitils and all
Sedative?
that?
What?
Stemitil.
Vascular
Yes.
sedative?
No, not routinely. On
Not
demand.
routine.
Betnesol steroid, oral steroids? No.
Oral steroid, betnesol fort.
Okay.
1 kg for 4 days. Then, and of course, 1 shot of intraoperative steroid and 1 shot in the
Steroid.
evening.
1 shot?
Okay. 1 shot in the intraop and 1 shot in the evening.
Yeah,
IV.
dexamethasone.
Dexamethasone.
What's the dose?
And
See,
so,
I leave. This is all I do.
okay.
The canal is kept more or less open.
This is like a
Okay.
super wide canal, man.
You said why?
You could have operated without the microscope.
I could have. It was 7 millimeters actually. 7.
My.
It was not
7
enough for 8,
millimeter
but 7
speculum.
millimeters.
And sir, sodium fluoride, your protocol with sodium
No,
fluoride?
Risedronate.
No.
I've given up sodium
Okay,
fluoride.
you have started giving to Risedronate. Okay.
Risophos.
Risophos,
Risedronate,
yes,
35
yes.
mg once a week.
And for how
once a
long do
week.
you do that? How long, sir?
1 year, 1 year to start with. Then I reassess the bone conduction. If the bone conduction is stable, go on for some another year, and so on and so forth.
So
I do
once
annual
weekly for 1
bone
year.
conduction.
Okay. Okay.
Yeah, once a
And
week.
what post-op advice we will give to this patient, sir? Precautions?
No flight for 2 weeks, and
2 weeks.
they should not wet the ear for 3 weeks, and that's it.
Right.
I'll see them
Swimming?
after 3 weeks, between 3 weeks and a month.
Swimming and diving, sir? That's also some question people ask.
Scuba diving forbidden for life. Swimming,
Right.
after a month or so, they can swim if they like.
Ashim, just a quick
Yeah.
thing. I don't know whether you mentioned this. I generally tend to do a post-op bone conduction audiogram for the operated ear very next day.
Okay.
Do you do that?
I'm sorry, once again.
Post-op bone conduction audiogram the very next
Yeah.
day for the patient, just to make sure you're not.
Oh, you do that?
I do that.
Okay.
Just bone
Honestly,
conduction.
that's a very good thing. I don't do that, but that's a very
That
good
the next day
thing.
because I just want to make sure that I've not taken the nerve down for anything, medical, legally, and
That's
otherwise.
a very good point. Yeah,
Okay.
the point
Okay.
well taken. I think it's something
Suppose
that
if
one
you feel
can.
it is not improved next day, what are you going to do it?
Steroids.
Honestly, I give a shot of steroid on the day of the surgery, absolutely, in all cases. I mean, you're free to disagree with me on that, but I do believe that there is something called a membrane stabilizing factor of the steroids. And since you have insulted the perilymph, however carefully, it's something that you would want to look at.
So it has now been proven also.
Go, Ashim, go to the next case and then start talking. Please get started. You
He's
have
already
20
opened the
minutes-
next case,
20
so
minutes screen
that
time.
pain
Thank you,
is
sir.
taken care of.
Thank you
Okay.
so much,
Thank
sir.
you, Abba.
Thank you.
Thank you.
And
Thank you,
Thank you, sir.
Kranti.
thank you so
you
much
very
for
much.
this
Thank you.
opportunity.
You all,
And
you're most welcome
Next.
to stay back and comment.
yeah,
We
Yes,
have
sir. Thank you,
the
sir.
other pair, Vaishali Bhakna and Venus.
Ashim, Venus.
Right.
Venus is there. Hi.
Professor,
Hi.
hello, 1 minute. The professor, I work with Professor Hugo Fish. he used to give steroids just before making the fenestra. What he used to tell, there's a condition called vestibular shock.
Okay,
So
change karo.
when vestibular starts, sometimes they're going for shock and that can cause it. That's why to prevent vestibular shock, always he used to give steroid Quarlin
just a few
before
seconds or
making the
just-
fenestra.
just-
The same thing I've been continuing from last 30 years.
Oh, okay.
Yeah.
Because I was trained under a good fish. So the same technique what I learned from him, even today I'm doing the same.
It's interesting. He says that any window you do, either on the cochlea or on the vestibule. So if you're doing a cochleostomy, if you're doing a fenestra for a stepidotomy, if you're opening the posterior semicircular canal for a posterior canal occlusion, you would give a shot of steroid at that time. And I think that's a very good take-home message here.
Sunil, that's a very good, valid point. Also, the patient will be much more settled, and the nausea and vomiting is also much less if you give the steroids.
Yes.
Yeah. Intravenous we are giving. IV. This is IV it is even, not IM. Now we give Efcorlin intravenous.
We usually
Before
give
making the
hydrocort. We usually give hydrocort. For that shock effect, it is hydrocort that we give.
Dhanraj sir, what happened? You're not happy?
Nausea, nausea may be due to vestibular stimulation. Nausea vomiting, not because of the injection. Sometimes when you make the fenestra, some people they feel giddiness. I have seen nothing would have been happened. You're making the fenestra, they say I'm feeling giddy. The moment the vestibule, that perilymph is touched only, they get some people. So they very clearly they tell that I'm feeling giddy or nausea.
The beginning of surgery or just before surgery,
Just before.
at that time when the steroid injection is given, there is feeling of nausea and yes. You already gave it. Not with hydrocort. Not with hydrocort.
Okay.
Hydrocort is better, short acting, quick acting. Takes a little long acting. You cannot use the effects of taking.
Yeah, okay.
Hydrocort again.
Okay, we are watching.
It's working for you when you open bladder with that.
Is that Ashim or at Priyank?
Hydrocort, usually I do the fenestra at that time until there is a shot. Yeah, but if you've given a steroid shot at the beginning of surgery, then is it wise to give another shot of steroid within a time gap of 1 hour?
Why you want to give at the beginning of the surgery? Not necessary. Yeah, each one has got their own way of doing it. I don't deny that. This is how I do it.
Yeah, it should coincide. It should coincide. He's not talking.
Yeah, Ashim. Dinesh, I think he's in the other OT now. They probably are. Hello, Ashim. I think they did not give him the connection there.
If possible.
Everything is quite visible.
He's following NMC rules.
So
Ashim.
let's have some clarity on NMC guidelines and live surgical workshops. Okay, before Ashim gets hooked on to the mic. Now you can do it in your own setting or a setting that you're very familiar with, where the staffing you're happy with, where the technicians, the infrastructure, everything you're happy with. So preferably, like what Ashim is doing right now, it should be in your own setting. 2, you should be very comfortable that your interactions with the audience is not affecting the outcome or the surgical steps. So if he's very comfortable doing that, and even if he was totally focused and he was not being distracted, he's able to do the surgery exactly like how he would do without audience participation, then he's okay. Otherwise, there should be a moderator moderating the whole session, and the surgeon needs to be on mute. And I think this is exactly what the NMC is clearly saying, and I think we're following that here. Now, Satish Jain is a bad example in that count, because he's extremely comfortable operating anywhere in the world in whatever infrastructure is being given to him.
You read?
That is an exception to the rule. So I don't think we need to take home that point. But what Ashim is doing is absolutely perfect. He's doing it in his own setting with the comfort zone that he has, which will.
And the comfort. Am I audible?
That's what I said.
Yes,
So
Ashim,
he
you
is
are.
not
You are.
speaking.
Yeah. So along with that, I'm equally comfortable with the moderation, the moderators, all of whom, as you rightly said, we've spent decades together.
Yeah.
So I'm totally comfortable. I'm more than happy to continue this way. In fact, Satish, to add one more thing, I think Satish will be uncomfortable the way he's done so many workshops. He'd be uncomfortable without an audience.
Absolutely. Yeah, which is what I said.
But as far as I'm concerned, I'm sure as far as Sunil, Vijendra, Ashish, everybody are concerned, I don't think this is a distraction. In fact, it's a welcome addition.
See that you can notice the anterior autosclerotic focus. Start looking for it. Just between the malleus and incus, you can see that little whitish discoloration.
Even in fistula antefenestral, you can see.
Yeah.
That is a classic fenestral autosclerosis.
So that's the first thing. When the moment you lift the tympanomeatal flap, train yourself to look for that. Once you see that focus there, this is a relatively easy stepidotomy.
Now you can see an extremely thick posterior crus, Ashish.
Yes, almost 2/3 of it is superior to the stapedius.
Yeah. Now this kind of a thing, you try to crack it.
Yeah.
You're very sure, and it's a blue foot plate, as you can see.
Yes, we can see.
Again, in this case, I was able to retro displace the chorda posteriorly.
Yeah, it's looking like that's your technique, although it's not. But yeah.
You zoom from here, no? Let's see. Okay.
Yeah, perfect.
Guys, how's the picture?
Very nice, very nice. Let us see the foot plate, if you don't mind.
Now it's very
touch
nice.
it a little bit before you drill.
Can you see the foot plate?
Beautiful,
It's blue.
yeah, but there's little, if you can.
That little bone curate has been, I think it is coming in the way. So obscuring the
No, that is this I can't curate because this is the chorda right there.
Chorda is there.
This one.
Yeah,
right here.
Yes.
People keep this intact, the stapedius tendon, they don't cut. Is there any advantage?
Intact stapedius tendon, Ashim.
No, but I don't think I can preserve it because this is below the neck. Can you see?
No.
This is the
any physiological advantages as a principle, not in this particular case. That's
as a principle, of course. There is postulated reduction in the hyperacusis following surgery, but it's all postulation. That's we don't know.
John Bernard Koss Jr. has a huge series on that, right, Ashim? Of
I know.
Preserving.
Not preserving. He used to reconstruct.
Oh, reconstruct.
He used to reconstruct.
Correct.
Like a necklace.
Yes.
Which I think was. Yeah.
We used to see that because actually the vein interposition was started by my dad in 1986 after watching Jean Bernard Koss.
1986.
86 was the first time we went to see Jean Bernard Koss. As you all know, that I was literally conceived to be an ENT surgeon, so I was in second MBBS, but I was taken there.
Yeah.
Even I worked with John Bernard Koss for 4 months. I was with him.
Oh,
he's a lovely person.
Yeah, lovely person.
Never got to see him.
Yeah, he had come once to Bombay Hospital. There he gave an invitation. Whoever is interested to come. I wrote to him, immediately accepted. And for 4 months, I stayed with him. In 1984.
Very hard crust I'm dealing with here.
Thick, yes.
Ashim bhai,
It's not transparent at all.
Ashim bhai, Vikram here.
Hi, Vikram.
Yeah.
How are you?
Yeah, I'm good. Ashim bhai,
later, can you just elaborate that in case you had to do a intact stapedius muscle technique, here the stapedius muscle is attached quite below, but had it been attached up, then what would have been your technical steps? You can elaborate this later. How to do an intact stapedius muscle stapedotomy. Because the 6K, 8K dip that we see is usually not seen when the stapedius muscle is kept intact.
Yeah, we'll talk about that a little bit later.
Good morning, sir. Dr. Venus here.
Yeah, hi,
Hi,
Venus.
Venus, કેમ છે?
Well, fine. Birthday greetings for the day, especially to start with.
Thank you, thank you.
Sir, I would ask you for a newcomer, like not newcomer, a new surgeon, how would they start their stapes journey? What do you recommend? How they should start with?
We'll discuss that actually once I've come into the audience, because there are a lot of things I want to talk about stapes. But just now, let's focus on this case. Yeah, go ahead. Ek second, wait.
So what is the size of the bird that you're using?
0.7.
Skeeter?
No, this is not Skeeter. This is BNR, Osteostap.
So it's like a
ऐसी
Skeeter,
हाथ
but
पे
it's a
सुई
different
लगेगी, हिलना
brand,
मत.
and this is far more sturdier and more stable. So I also got this on Ashim's recommendation.
What is that? Can you
I'm
repeat it?
sure you're happy.
Say it again, Ashim. What's the name of the thing? I have it.
Osteostap. बहन जी 2 मिनट सुई लगेगी, आप हिलो मत.
Osteostap, no?
STAP,
It is
stap.
little stout. Actually, what I use is 0.6 mm diamond butt tip long one with a contraangle handpiece.
Yes, same with
The
me. Yeah.
whole thing is clear, straight away you can see that, but it is obscuring the view like a step ladder.
Yeah.
So, yeah, tip completely.
Except for marathon, about all other drill we have ENT, I think have contraangle handpieces and very thin burrs and low speed. So we have speeds from 500 or 1000 RPM right up to 60,000. So at a low speed, you can do a lot of work, not just cochleostomy, that I profess in, but also removing this posterior superior overhang, the caudal crest, crudotomies, removing the posterior crust, making a fenestra. I think if you don't have a Skeeter, get used to using low speed, thin bursts, diamond bursts with the contraangle handpiece.
So what are you doing,
Every
Ashim?
system has it.
Ashim, what are you doing?
I'm now drilling the anterior crust. It's extremely thick.
It's sort of blind. It is
Blind.
a tactile
Yeah.
feeling. And in such situations, it's a good idea to partially drill the posterior crust and then go to the anterior and then come back. Because you have the stability. Yeah.
Good point, Ashish.
Yeah, partially. That is important, not completely.
Yeah.
So partially drill the posterior crust. Don't drill through. That's what he did. Then you go to anterior crust. So this will be holding it.
Drill. Yeah, I still have to go through the posterior crust. See this, the last bit?
Yeah, I can.
Yeah, this
Good
one
idea.
here.
It's a very good idea.
Don't move me, Rashmi. You got it.
Sometimes
Just
you can
that last
see the
bit.
anterior crust very clearly
Right.
in two cases.
Yeah.
So there directly you can drill it.
Again, that rotation.
Twist. Ashim's twist. Birthday twist. Okay.
No, not done.
Not
It's too
done,
thick. I need to drill more.
But this is, yeah. Vivek is making a point that in the reverse epidotomy, you can't actually twist it as well. He has tried it. Yeah. Fantastic. Yeah.
Not be a rocking moment.
Yeah, that's what
Right.
Vivek is saying. See, now a little bit of the shaft is touching the long process. Doesn't matter.
Look, if it was going on and on, yes, it would matter. It would thin out the shaft.
Yeah.
Saw that twist?
Yes.
Yes.
Now your stapes suprastructure is hanging. Fantastic. So he's being very gentle because you don't want to subluxate the incus. So he's playing with it slowly. I once had
Maybe
an
around 5.
incompletely disarticulated joint.
So I'm just rotating around and around, kind of strangulating the fibrous adhesions and all that. One of the other ways, of course, to see how thick it is.
Sometimes it will be ankylosed. Have you come
Yeah,
across?
then
Yes.
you have to drill through.
Yeah, drill through.
You
Or
have to
in
drill the
these
anterior crust,
situations,
posterior crust.
no, this IS joint will be ankylosed. The joint will not be seen and it will be difficult. Have you come across
Yes.
such situation, Nashim?
Yeah, yes, I have, definitely.
In that
I
situation,
mean,
what I
rarely,
do
but it is
is
there.
I use the Crudotomy scissors. So that very nicely it cuts that.
Okay, so now you have a slightly deepish knee,
Beautiful foot plate. Nice.
but it's a beautiful blue foot plate.
Yeah, very wide.
The incus relatively short, no? The lower end is just at the posterior border. So the piston will
I'm
have
sorry, boss.
the incus is relatively short compared to the width of the foot plate. It's coming.
Correct. But I still don't need to go for a Robinson's prosthesis.
No, not at all. But I'm just saying, so the placement of the loop will be a little bit. You're making a fenestra already?
No. In this, I would never make a fenestra with so much blood.
Yeah. Okay. No, and first the length measurement. Yeah.
Are you able to get something?
Build the base of the posterior crest.
Yeah, I have to drill that out. That was what I was doing a few seconds ago because I want the vein to lie as flat as possible.
Sometimes while doing this, we encounter fracture of the foot plate, particularly with the posterior crust we are trying to drill. I have seen that I encounter fracture of the foot plate.
Yeah, that's why, the message for the juniors is that they should just use it like sandpaper, not like a drill.
So for the benefit of juniors, can you emphasize what you did is you drilled the posterior crust, then the anterior crust, and then you dislocated the IS joint. But very often, if you do it reverse way, what is the risk and why should it not be done?
The
If you
risk
can
is
reinforce.
the risk is that if you have a very thick crust, you can disarticulate fracture the foot plate. You can displace the foot plate. All of that. In my hands, this was the safest technique in my hands. Now, see again. Everybody should develop their own techniques.
This is now he's demucosifying. He tries to make a raw area because when you put the vein, you don't want the mucosa trapped underneath.
And also, you do not want to, while you are making the fenestra and all, you don't want it to bleed. Whatever bleeding needs to happen before you fenestrate.
Yeah, because this is a completely almost like no vascularity. When you do direct,
this is very good.
You really like to keep the mucosa because then the bony fragments, if at all, they don't sink into the vestibule. They remain attached to the mucosa.
Long curved.
What about using perforators, graded perforators? That's how all of us learned it.
Honestly, I agree. It can be used in this kind of a foot plate. Certainly, it can be used. I'm no longer used to perforator, in all honesty.
Hey, we did it exactly like that in KEM.
I've never used a perforator in my life. I used to use a very horrible pick because that's what I learned from. I used to crack the foot plate, not make a fenestra.
Measure.
Still, I'm very scared that I'm always afraid the perforator is going to slip from my hand and go into the vestibule because I don't.
But I always use perforators.
Yes, I've seen you.
Because that's how I learned from Hugo Fish.
Comment on that.
So, but we'll have a good control with your fingers.
Previous foot plate was not ideal for a perforator.
Yeah, there we make it thin and then use a perforator.
Yeah, now this one, you can easily use a perforator if you are used to it.
Correct.
Measuring.
So ideally, all foot plates should be drilled to this to make it look like this before you can use a perforator.
Yeah, you're perfect.
Okay, what
So
length?
this is slightly shorter than the previous one.
Yeah.
425, 0.4.
Here, even if you see, the incus is little medialized. That's why it looks shorter.
It's little medialized.
And also it will stick.
Yes, it's stout. Yes, that's right.
And also shorter.
With this classical technique, haven't you had a hypermobile long process and found it difficult to put a piston?
I'm sorry?
Has the incus ever been hypermobile? You've done 6,000 cases. With this classical technique of stepidotomy, where you remove the superstructure first. Have you had a hypermobile long process?
Very, very, very rarely. Not had a problem with them yet. But yes, in my very, very junior days, yes.
So how do you handle it?
When you use a vein,
see, at this stage, don't ask questions. See, he's doing so you should know when to ask questions.
Not when you doing the fenestration.
Fenestra is doing so concentrate.
How is the focus?
After this surgery is over, Ashim will come and join us. And Satish will then start his with the cochlear implant. First 15 minutes or so, he is going to be discussing the CT scan and the orientation of the...
Boss, if I am behind schedule or something, feel free to switch me off.
No, not at all. Not at all. In fact, we are going perfectly fine.
Right. 0.4 piston. 0.4 disc. Always be far away from the oval window when you're using a suction.
This is at 0.4 disc.
0.4 piston.
0.4.
You need to keep the gel foam also a little away, right? So it does not dry out the...
I'm sorry?
So you need to keep the gel foam also away from the open...
no, if right? So that's why I allow it to become wet and then bring it close to the oval window. First it becomes wet. Can I please have a piston?
It's such a wide footplate. Very rarely you get to see, no? Such a wide one.
Yeah. Very nice to demonstrate.
I'm lucky. I'm lucky.
I wanted the facial to be down. It became the other way around.
Yeah, correct.
नहीं जरूरत क्या है? So I'm going to do 4.25 out here. As you can see, this is the same blade I use. It's lovely, single use. You throw it away, it doesn't cost anything.
Thin incus.
You have to grip the piston loop tightly. It should completely.
Yeah, always. There's a very important point that
Vikram's question was: here you have a stout, long process of incus, but sometimes you have a very slender, normal but slender, long process of incus. How do you manage the loop of the piston at that time?
I will tighten. See, now that is where I will use an Eon piston because it has a slightly narrower loop, one. And the second thing is that I would also put the superstructure on top of it like a ghoda.
Chada do. So Vijayendra sir was talking. You see, overcrim.
Overcrim. Or else even you can use some soft tissue over the incus and then crimp it.
Yeah. So Medtronics has two loop sizes. Besides the length and diameter, they also have a loop option. But if you can't, then in this particular case, I would cut a little bit of the loop so that the diameter, so that when you the circumference becomes less, a little bit from both the ends, more from the upper end, and then that allows the circumference to become smaller.
It's a good idea. Very good idea.
Very good idea.
Yeah.
That's a very good point you brought up, Ashish.
Yeah, Vikram brought it up. I just had the answer, so I picked up the point.
We learned.
We all learned.
Yeah, ऐसा कैसा तुरंत जाता है यार तेरा piston?
No,
Hello, not allowed.
See, what I notice. No, that valid point, Ashish.
Yeah.
I think he uses this two instrument technique, and I think that is absolutely fabulous to watch because most of us are used to holding it with the
Yeah.
piston holding forceps or even a crocodile or
This
something.
is too long, guys. This is too long. Sorry to interrupt, but this is too long. It's not coming out.
Yes.
I will remove 0.25.
Actually, in 1992, John Sheehy had come to Chennai for ISOCON conference. So where first time I saw, he uses both the hands and nicely crimps the piston. That was really amazing to see that. So he uses two 45-degree picks and locks the piston. No.
So, when we sat with the measuring device, it was 425, but I'm seeing that was a bit too long practically.
Everyone wants to see how you cut the piston. Vikram sir wanted to ask. So please. Huh?
Just like this.
Like that.
We are not able to see.
No, that you have to
So this is-
manipulate with your finger. You push too much and then cut it, or that you can manipulate the finger.
Can you demonstrate?
He can't hear you.
What happens is that
So
today
my
I'm in
OT
the
manager
present.
Santosh on the disc that we cut the piston, he's with a laser got this 0.5 mm marks done. So I can then where you cut the piston length, that is where I have a reference scale already laser marked on the disc.
See, not all are blessed with Santosh. We mere mortals have to make do.
Also, I think the bone near the chorda that needs to go. Otherwise, the crimping becomes difficult. Sometimes the fenestra and all this is fine, but that area comes in the way and you can't then crimp. So where the instrument is now touching, where the suction is, there that. Okay. Thank you for taking time.
That point in the beginning only asked, he
Yeah.
said he wants to retain it because the chorda is coming there.
Yes. Yeah.
Probably under the microscope, he may be comfortable. For us, it may be
What
difficult.
happened?
Yeah. No. All good. All good.
Very nice.
That blood clot coming from the incudomalleus.
Saw that. It's perfect. I was able to hang it out.
Yeah. Okay.
But the piston
we are
shaft become little bent.
Yes, it's like a walking
I
stick.
know, because while I was cutting it, actually, there was a little excess pressure in that loop.
You can manipulate that with fingers and make it straight.
Yeah, you can just straighten it out.
Yeah, always
Number
better.
2.
Ashim, for us, the centralization is not at its best. We can't see the posterior edge of the fenestra.
Till the head of the
But
patient.
you may
goes.
carry on. Yeah. Okay. Perfect.
Okay.
Thank you.
Okay.
Thank you.
Now, give me the wind.
He almost makes it a double bit.
Double?
It was very easy for him.
Yeah. Yes, the width you're saying, yeah, right. Vandana
Now,
saying
this
you
is a
had
very, very, very thin vein.
yeah. So Vandana was saying you had a double bed as a footplate. Such a wide footplate you had.
I know, I know.
Yeah.
Priyank,
Yes, sir.
can you get me a better vein or no?
All veins are thin. All veins are thin. Thickest vein.
It won't even go zero. See, this is too thin.
The other way around, I guess.
We will try.
And if not, we shall do a direct piston.
Absolutely. But then I will change the diameter of the piston.
Ashim,
Beautiful.
Yeah.
I still do a direct piston and put fat around that area. A small piece of lobby.
That's fine. That's
Never had a
fine.
problem.
And in fact, if I can't do if I do a direct piston, as Professor Jean Marquet said, you don't even need to put anything around it.
You're a little off center, by the way.
Yeah, each one has got their own technique, how we have been trained.
Correct.
So if you don't have
Yeah,
any problem, stick on to that.
So,
but Hugo Fish is to put free areolar tissue, not the fat. Never put fat because the perilymph, it can float. So use areolar tissue and make it small bits and put it around the piston. That's what I have been doing from so many years. I don't have any problem. Each one has got their own way. So if you don't have any problem, stick on to that. So that's how Professor Hugo Fish used to do, used to take areolar tissue, not the fat, and seal
Tell
it.
me, he used to also put tissue glue.
No, never.
No. He used to put venous blood.
No,
Ashim,
he used to put blood.
Only areolar tissue.
Ashim, we were just discussing the reason for asking the question. We were just discussing how meticulous you are. For us mortals, we put the piston in and we are very happy and we leave it at that. Okay, we are happy to put fat and come out as fast as possible. Right? Yeah, we are happy.
Boss, you are a fabulous surgeon. And
enter the picture.
You're a fantastic surgeon. Now see, this is no use. I can't use this. Measure. Can I get away? Let me see. Measure.
Any other
So this
material you've tried? If you
actually
were not happy
can.
with the vein graft?
Ashish.
Yeah, it's 4.5.
This is 4 millimeters.
Yeah, चल जाएगा.
चल जाएगा. 15.
Tissue, like he said, he uses fat. So you can take the tissue from the raised tympanomeatal flap, bony side of the tympanomeatal flap. With the micro scissors, you can take bits of tissues and you can seal that. No need to give any incision for harvesting the fat.
Non-squamous thing is saying.
No, that under microscope.
Yeah.
Not skin. No skin. Correct. Oh,
This is a see-through
measure.
vein.
Yeah. It's your kind of vein, Ashish.
Yeah. Very fast. Designer vein.
Absolutely. Now, of course, this fenestra is too small for this for a vein interposition, all right? So we will expand it. .6 disc.
All the youngsters watching, there's a point to be noted that, Ashim is doing this, he's widening it, he's taking off the edges. All this is because he's a super expert guy, okay? For all of us, we are happy, like I said, not to meddle around too much with the fenestra. Once we have the fenestra, we have a good enough fenestra, we put in the piston, put a fat and come out. So all this has to be done very carefully because the amount of that perilymph and that perilymphatic area around the vestibule can be very, very sensitive
See
to
where
hearing
his
loss.
burr is parked on the edges, how he's
Exactly.
widening it. It's
Exactly.
not dipping into the fenestra.
Yeah.
Just
So-
watch. This is a beauty. How
So
he's widening
he's-
the 0.4 to a
Yeah.
0.8. Yeah. Wow. A shame. Brilliant.
So this area as left-handed as
Really
possible.
brilliant. Very nice.
Yeah. Yeah. Like I said, we avoid any trauma to the vestibule or to the perilymphatic fluid because that ear could be very sensitive to hearing losses. But he's doing it brilliantly.
Very fine control.
He's moving around the periphery.
You see that bubble of perilymph not broken
Yeah.
allows the bone dust to float outside. 0.4 disc.
Samir was just raising that point when you answered it. Yeah. Okay. 0.8. Distance card. So he's measuring and
.8.
so
Beautiful.
ABR sir has gifted me these discs, but I
Which
love them so
company
much that I have never
prepares-
used them. Preserved them.
You saw that this is now 0.8.
Yeah.
So absolutely perfect.
So which company makes this disc, sir?
The Desai company.
I'm sorry.
There is nowhere else.
Honestly, Ashish is actually more correct than he thinks he is, because the guy who used to make this for us is no longer there in this world. He, poor chap, expired. Regede karke tha ek.
Ashish,
Hmm.
Evixia.
Evixia.
Yeah, if it is sizing that you have to do, you get 0.6 burrs, diamond burrs, 0.8 diamond burrs. So you can use those to size also.
As a measure.
As
No,
a
but
measure.
boss, the thing is that if you put a 0.7 burr, it is dipping 0.35 millimeters into the vestibule. So you should never go inside.
Yeah. Fair enough.
Press me pinch fast.
You leave the bone dust like that only, which is on the periphery.
Is it the smallest? Huh? Give me a still smaller.
Ashim, what's the need to go beyond the oval window diameter with the vein graft? Because the oval window, in my opinion, the greatest diameter is about 3.5 millimeters.
Agreed. So
You're
you don't
taking
need
a
to.
5 millimeter.
See, in this case, you don't need to. But in cases where the incus is strongly angled, then you will need to do so. Because otherwise the edges of the footplate will touch the edge of the lenticular process and drag it downwards.
Edges of the vein.
Yeah, edges of the vein. Sorry. Yes, sorry. See, here I am seeing that is more or less okay. It's covering everything. I just spread it out a little bit. That's it.
Yeah.
Ashish?
Yeah.
You okay?
Yeah, good. All going good. Deepak wants to ask, can instead of vein, temporal fascia can be used?
It's too thick.
Too
And
thick.
it is too
Perichondrium
sticky.
even more thick.
So the false fascia, Fuller's fascia.
False fascia.
You can see, you can use it. I'll tell you, someone who used to use it regularly is Dr. P.G. Vishwanathan.
What he used to use?
Fascia.
Fascia.
Yeah, until later on, he and Dad had a long conversation. He moved to vein. And then Aruna uses vein. Oh
Like
my
a
God.
golf hole. Yeah.
Sorry?
Robert does that on a glass dish. He makes like a golf hole, no? Makes the vein dry and then he puts it. He does
Yeah,
it.
this actually the vein was dried, but this is so thin
Yeah.
and so atretic.
Yeah. So Prasad was mentioning that another way of doing it. So that thing goes into the fenestra. Suction. Yeah. Correct. Yeah.
Bone dust around the fenestra. It actually helps to anchor the vein graft and create small micro pockets in the physics of healing, so that the vein graft doesn't
Move. Okay.
So it is necessary to preserve that bone dust.
Okay. Vikram is
Can we
making a
reduce
point
the-
that the bone dust that during the fenestra, which happens around the fenestra, should ideally not be removed, and it actually helps anchor the vein graft.
We don't really remove all of it. I mean, we remove some of it. We remove it from the oval window itself. No, don't pinch. I'll tell you when to pinch. Open.
That fascia Vaishali was saying is called Schroeder's fascia. Temporal fascia जब निकालते हैं ना,
Words,
Okay, got it.
Yeah.
Full fascia.
When he is using suction, he is blocking the hole on the
See, on worst case scenario, if I choose not to use this, I can still use a 0.6 piston in this
In a 0.8 diameter, yeah.
with a 0.8 diameter fenestra as usual.
Yeah.
Like a 0.6 with a 0.4 piston, so on and so forth.
Yeah.
But I think we shall be all right, more or less, with this.
Your current piston is 0.6.
No, he's
0.4.
0.4.
Because he's put the vein now, and the
Fine,
fenestra
no?
is 0.8.
I still feel the shaft
Yes,
is little bent.
even I'm not happy with the shaft. Yeah.
I'll change the piston.
You can try
Give me another.
straightening it up.
Yes.
I'll change it now. What is there?
Okay, change it.
Change the apple pass. Take out a piston.
Yeah.
Am I
How
saying
much
anything?
do you get the grace piston for?
Sorry?
At
What's the
what price
cost
do you get? Because
of the
you are the
piston?
brand ambassador for Grace. He says Ashim
I
will at
don't
one
know
time
actually.
order minimum 500 or something. I don't know what, 200.
I ordered 200 at a time, so I'm not really sure.
Yeah.
I have to ask my
Yeah.
clinic manager actually.
Yeah.
Honestly, I don't know.
How much Prasad you get it for? 4,800.
No, I also get for 4,100.
4,100.
Huh?
But sir, I think you must be ordering 100, 500 at a time. Medium.
I'm sure they have some bulk discount and all that.
500 at a time order.
No, I'm not.
You're using your? I have just moved to Grace.
Centering, sir, centering.
Yeah.
Crucial point.
Centralize the field. Yeah.
Better?
Better.
Yes,
Fine.
yes,
Much
better. Very nice.
So you sort of get a feel of it's giving way, is it, when you're at the fenestra? Because now
Yes,
it's
you
going
don't
more by
see, we had already pre-measured it, correct?
Yeah.
Because, so then you know that you have to be in the fenestra, whatever happens.
Whatever, yeah.
That is the advantage of the pre-measuring.
Yeah, matlab the lower end doesn't move here and there and it goes straight there.
Go straight in. See?
Yes,
5 and
yes.
5.
Okay, beautiful. So it's the
This
hook
shows the
of the
bending and
right
hanging
hand.
twist again, sir.
This is
I'm
a
sorry.
two-hand technique of primary, the first part of the crimping. Yeah.
See, it's well positioned.
Should he be doing the
For such.
Super,
Ashish,
sir.
Yeah, yeah. Right. Yeah, yeah, Shin.
it's well positioned.
Yeah. Okay, lovely.
All right. So,
Yes.
you want to go on to Satish? Please go ahead.
No, go ahead. We want to see your flap back. Make sure you're not done any
Okay.
mistake there. No, just tell me whether the piston loop is touching the bony edge of the
Facial
canal.
now. Facial canal.
Facial canal, no, but there I think, yeah.
No, but it's not really, I mean, it's the bony facial canal. There's nothing really.
Bony canal, I don't think it matters, no, if the shaft touches. I'm thinking whether the loop is touching the posterior canal wall.
No, it is not because this is the chorda here.
Okay. If you can suck it.
Here's
Yeah,
the chorda.
okay,
See, it's
sorry.
far away.
Okay, far away.
Number 2.
That is when that two-hand technique is important. Chances of incus dislocation, not.
Not seen any, yaar.
In that situation, what you have to do in when that situation is there, don't open the loop of the piston too much. Accurately open it, but you have to manipulate in pushing that piston to the incus. So if you open it too widely, then you have to close. So on the table, you have to take a decision. You have to be careful. Don't open
And
the loop.
also the crimping forceps, keep the mobile blood, use it reverse. Use it reverse so that the mobile blade is posteriorly now. So you don't need to. So that's the.
Round window reflex.
किधर है?
आया ना.
अरे है ना.
Sorry, मजा आया.
There.
Yes.
Hey, don't do
Yeah.
it. Yeah. Okay, just kidding, man. Yeah.
बहुत हो गया. Long
Very
curve.
nice. Very nice.
Now I'm going to palpate the neck of the
Vikram had a
malleus.
point that should you be seeing the round window before you do the final crimping? But yeah, I mean, it technically it's
Honestly,
correct,
the
but you
round
can
window
always
reflex
undo a
is
crimp for piston also.
You know, a round window reflex can only happen with a vein interposition. It cannot happen because the
I
micromechanics
was
are
about to tell
distributed
the
at that.
same thing. So when you do direct piston, you cannot expect
You cannot have it.
And yes, and don't try to do it also.
Yeah, don't try to do it. You'll never see it.
Yes, you're right. Because of vein interposition,
It has leaked, so there's no.
correct. There should be seal, then only you get the round window reflex.
The mechanics should be sound, you know.
But
Show me.
depending upon the size of the fenestra what you have made with the perforators, if you have made with a 0.6 mm, 0.7 mm,
Silence कर दो.
0.4.
No sound from there. अर्जुन कैसे हो? सुनाई देता है? कैसे लग रहा है पहले से?
Vaishali, Venus, you have any closing remarks?
Yeah, very
मेरी आवाज
wonderful
सुनाई देती है?
demonstration.
Yeah.
अभी आपका नाम बताओ
It
कहाँ
is
रहती
a
हो?
treat to the eyes.
Okay, fine. Getting something?
So if you could tell us what happens if there is a hypomoral incus, and the same thing, suppose if you were not using the vein graft, then what would be the different thing? What would be the size of your piston?
Memory दबाओ.
So he's not heard your question. He's doing his intraop audiometry.
This question now goes to you because you are muted for the discovery.
नहीं जी, हम कान का टेस्टिंग करते हैं. कान में पीप पीप करके आवाज आएगी, ऐसे हाथ जोर से गिराना. ओके, कान में पीप पीप करके आवाज आएगी, ऐसे जोर से गिराना. हम कान का टेस्टिंग कर रहे हैं. ओके,
Point two.
How do you decide आपको 0.6 fenestra बनाना है या 0.8 बनाना है?
जोर से एक बार आवाज आई, एक बार गिराओ.
It's the width of the foot plate that decides. If it's narrow, so
Right? So you have 0.4, 0.6, 0.8.
50.
yeah.
So how do you decide?
ठीक है.
So I don't change the size of my fenestra depending upon that. For me, it is a 0.7 if it fits the foot plate, and then a 0.5 diameter piston. नहीं नहीं 0.5 ही आता है.
ठीक है. So suppose the wide footplate, you can do a 0.7 fenestra, you can do a 0.5 fenestra. So then how do you decide whether 0.7 or 0.5?
0.7 is my standard. If I can't do a 0.7, if it's a very narrow, then I will go to a 0.4, a 0.6. No, not for me.
Footplate determinant. So Vikram, thicker the footplate, the better is the airborne closure. But I'm not talking about airborne closure. I'm talking about the size of the fenestra.
See, standard what we make is routinely, I make 0.7. Okay, the standard. So that may be not possible in all the 100 cases. Sometimes there may be fractures the foot plate, posterior foot plate may
चालू
come
कर
out.
दो.
So when you make, what I do,
अच्छा हो गया है.
I always use the perforators, 0.4, 0.5, 0.6 and 0.7. So once if I make 0.7, that's it. In 95% of the cases, I do the same thing. In the 5%.
Am I audible?
Yeah, Ashim, yes, you are.
Yeah, okay. So everything is good. She's hearing well, and we did the audiogram. So I think you can switch me off now. All I'm going to do is put some gel foam, and that's it.
Very nice
Fabulous. Thank you.
demonstration. And
Brilliant,
greetings for your
Ashim.
birthday.
Thank you so much. It was a veritable feast.
Yeah, this is a gift for you. The
yeah, we
loud
gave you
applause is a
two
gift for your birthday.
Thank you. The gift for me is you people. You people have graced the occasion. Thank you. And you're the biggest gift that could happen. Thank you, guys.
Hope you join us
Ashim,
before lunch.
very,
We would
very
like
well
to have lunch with
demonstrated.
you, Ashim.
Yeah, he'll be
I'll
here
be
in
there.
20 minutes.
In 20 minutes.
Yeah.
I'll be there in about half an hour max.
The lunch is going to be served from 1 o'clock till I think 3:30. We are not going to have an official break, but the lunch is you have to go across. There's a restaurant called Vista, and there's an area which is reserved for us. So you just have to walk in, and there's a large buffet. And that coupon I think you have to just give so that the number of plate count doesn't go wrong with the hotels. Otherwise, we have 50 or 60 and then they will charge more.
So Ashim, once again, happy birthday to both of us. And I am just to say that I enjoyed your operations and fantastic. So enjoy the rest of the day, and nice to see you.
Thank you. Same to you. Same to you, boss. Very, very
Thank you.
many happy returns of the day.
Acha.
Thank you.
Okay. Ashim, Vikram has loved your OT cap. So he's saying if you can give him that as a gift on a return gift today, or if you have a spare one to give him.
You know where I got this from? Prasad Kerkar.
Okay. So he's sitting
I
right
got
next
this
to
from
Prasad.
Sholapur. It's a gift from Prasad.
So Prasad is declaring everybody will get it.
प्रसाद सबको दे दो.
प्रसाद ने तेरे को कभी दिया उधर?
टोपी पहना रहा था ना मेरे को.
Show that topi again. Somebody, external camera, please. Dinesh, can you get your team to show the cap that Ashim's wearing?
My God.
Okay.
We don't have to make otology great again one, because otology is already great. So we don't have to have a Moga one, I suppose. This is good.
Very nice.
Thank you, guys. Thank you. Thank you, Rashmi. Thank you, madam.
Rashmi, thank you so much. So now we have Satish coming in. He's Batwa. Okay. So Satish, if you are there, you can get going with your Dinesh.
Hello.
Satish,
Hello.
yeah. So Ashim has finished his case.
Yes. Amazing.
So you want to start anything? Yeah.
Hello.
Hello. Yeah, Satish, we can hear you.
Yeah. So Ashish, as you sent some of the questions you told me,
Yeah.
So I think we have got a lot of queries from online sources, and majority of the things we have discussed.
Yeah.
Some of the things some people want answers. Can I
Yeah.
take up few questions before I start?
Yeah. But let's welcome the other two lady stars. Chanel is here. Chanel and Sri Rao.
Yes, good afternoon, sir.
Hi, girl. Hello. These are moderators now for this cochlear implant session. Two very brilliant cochlear implant surgeons. Welcome. Let's see that smile, please.
Yeah, so thank
Okay,
you so
thank you.
much
Yeah.
for
Okay, Satish, go
appreciating.
on. So Satish is going to go through the CT scans first, and then he will start the surgery. Satish?
Hello.
Hello. Yeah, Satish.
So regarding few of the questions that you sent.
थोड़ा दिनेश सर सतीश सर का ऑडिबिलिटी का देखो ना जरा.
Hello.
Arun, if you would like to make some comments or.
Hello.
Yeah, Satish.
Can you hear me?
Yes, we can hear you.
Satish, your volume needs to go up.
Yeah, in 2 minutes, it is connected.
Your volume needs to go up. Your volume is.
Okay. I think he's reaching the place in 2 minutes.
Everybody look here. So, my comment is about the
Arun, yeah.
training the juniors how to do the Stapes surgery, and do you think it should be part of the curriculum for masters, or will have to be somebody dedicated to otology, or how does it work in India at the moment?
So Sunil can probably take that. He's a thinker and training for Stapes. Should it be a part of the curriculum for masters or?
The volumes, I think, determine how many can be trained. So I think the volumes in India, Arun, you and I know, compared to UK are pretty high. I think stepidotomies are generally done by most otology surgeons. So every department in a medical school has at least one good otologist who will be doing stepidotomies. So MS will definitely give you an overall idea of how to do stepidotomies. You may not become an expert. For example, I trained in KEM, and Dr. Kirtan and everybody else was doing stepidotomies, and we got to do in the 3 years, on average, at least 6 to 8 stepidotomies, independently ourselves. So I think that is very good. Unlike the UK had very specific centers who would do at least one stepidotomy a month. So there should have been at least 12 stepidotomies in a recognized center. So I think the volumes dictate how best the training can be. It's not as frequent as mastoid surgeries, but definitely pretty frequent. To top it, you would top it with the otology fellowship. There are plenty of otology and neuro-otology and implantation otology fellowships that we all do in the country. That would enhance your individual training in otology when you've declared a focus in otology.
But how I train my students is that to do a cadaveric dissection in a live bone, wet bone. So we give all the instruments, what we use for the surgery. That is the most important thing. We use fish perforators 0.3, 4, 5, 6, and 7. And we teach them to do on a cadaveric bone, reverse stapedectomy. Without removing the suprastructure, they have to do it. So if you try to remove suprastructure in a cadaver bone, most of the time the whole foot plate will come out. So they'll not have the feeling of having done stapedidotomy. So once if they make, most important thing is instruments. You have to give the perfect instruments. I give all the fish instruments. Once if they make 0.6 or 7 perforation, they have to insert the piston. So what they have to move in each bone 100 times. You believe it or not, one full day they do it, or 2 full days they do only Stapes surgery. that insert the piston, remove it, and reinsert it. They'll have a scoreboard. They have to keep marking it. So if they do like that, they will get coordination, hand and piston insertion coordination very well. So in each bone, if they do like that, and if they do about 10 or 12 bones, they will learn very clearly. And before doing the first surgery, they have to do one dissection and then they have to do it. That's how I train my students. They will do very well.
Do 5 dissections.
Yeah, I mean, temporal bone dissections, world over are part of medical college training, both MS and DNB and FRCS. So I think that includes a stepidotomy exercise, a posterior tympanotomy exercise, just about everything there is with the temporal bone. The more you do it, the better you get. So in addition to that, the clinical training, the hands-on training depends on the volumes also. So the more you do, the better you get. Today we have good fellowships across the globe in otology, in implants, in neurotology, in lateral skull base. So I think when you declare a focus, you could pursue these fellowships. Again,
Absolutely.
fellowships also include temporal bone dissections, right?
Yes.
Including endoscopic surgeries, right, Arun? And you've been part
I
of.
think I've been running this endoscopic ear course in Glasgow, but we are fortunate that we have a cadaver donation program, and we have fresh frozen bodies, which are not difficult to sort of keep. So they give you more lifelike sort of appearance when you're doing these things.
Yeah.
I do almost all my stapes these days with an endoscope, only because I started off by just exposing the ear, and but then later on I realized that I can get very close to the stapes. But one important thing there is that you must have the posterior canal wall should be curated. Otherwise, you can see things, you won't be able to access it. That is the problem with endoscopic approach.
How do you work with the caudal crest, the posterior overhang? You curate or you drill or?
I am fortunate that I have disposable curettes. In the UK, they're 8 pounds a shot, and they're always sharp, and so there's a wider and a smaller end. And endoscopic ear surgery will make you much better in curating. So I curate most of the time. Try to move the cauda superiorly, and that's what I do.
Hello.
Yeah. I honestly, Sunil, I believe the surgery for endoscopic ear surgery is a stepidotomy because it's a very linear surgery, bloodless surgery.
Correct.
If at all somebody has to do it, it should be that. And access to the anterior crust with the endoscope is far better. Yeah. Yeah, Satish, hi, master.
Hi, Ashish. Am I audible now?
Did you win the match or not? Plus tell us that.
Yes.
You win. Okay. Okay. How
So
much
hope
did you
I'm
score?
audible. I'm
Yes,
better
you're
now.
audible and visible both. Thank you.
Oh, great. What a great day to begin with. Ashim's excellence and amazing. Each and every time he proves to be something himself at a different level. And what an amazing dexterity he had shown at every point, right from drilling the fenestra till, putting the piston and crimping by both ends. It makes things so easy. So great day. And now, Ashish, you had sent me some questions. Can we take later after the surgery or now?
Now.
Now?
Now
Okay,
better to take them now.
until the Ashim is reaching. Okay.
Yeah, correct.
So the first one, there are a lot of questions. We have discussed a lot, many things. This one is from Dr. Rahul Tejankar from MP. So his question is about the utility of laser in stapes surgery, and which laser is more important.
Yeah.
So we all know amongst the various lasers, CO2 has proven to be best for inner ear functions as far as the preservation of the inner ear function is concerned, as far as the preservation of the vestibular end organ is concerned, because it is absorbed by the fluid. So once you open the vestibule, whatever laser disseminates, though it has to be calculated properly before firing, so as to adequately take the footplate thickness only. Melt the footplate adequately without passing too much of energy to the inner ear. And whatever still it goes, it is absorbed by the perilymph without heating the inner ear vestibule and organs. So CO2 is considered to be safest amongst all. Regarding the use, see, there are two steps in Stapes surgery which are crucial. Crucial in the sense, these patients come with conductive hearing loss and we have the best chance to give them improvement on the table. On the other hand, since we have to open the inner ear, there are chances of giving sensory neural loss as well. So this surgery is something sometimes proves to be all or none. So particularly at two steps which are crucial. One is the crudotomy. Fenestration is the second step where unwanted mobilization of the foot plate can be hazardous. See, it is such a calculated step. We have seen Ashim Desai, even without using laser, though Ashim uses laser sometime, he owns the CO2 laser, luminous laser. See, while crudotomy, if your foot plate is not adequately fixed, the smallest, high pressure on the crura can lead to a floater, can take the foot plate out of the vestibule even if the jerk is there. So the crudotomy is a very crucial step. We already discussed what Ashim had shown. During crudotomy, we can take some measures if you don't have a laser. We don't know about adequate fixation by any means. But yes, if you do a reverse stepidotomy by keeping the entire incudostipedal architecture intact and make a fenestra, the chances of making the footplate floater are minimized. Secondly, the posterior crust is little more thicker, more stouter than the anterior crust. And it is most of the time the posterior crust removal which makes the footplate thicker. So like Ashish had not shown today, we have seen from his teaching always, what it does, it thins the posterior crust by the micro drill. It makes sure the posterior crust becomes very, very flimsy, so you can break it easily without mobilizing the foot plate. So these are the measures by means of which you can prevent. Otherwise, laser is something beyond this. Without touching the stapes at all, you can vaporize the posterior crust. Since anterior crust is very thin, still you can use a fiber laser to reach out the anterior crust. Otherwise, most of the time, if you vaporize the posterior crust, you don't need to do anything with the anterior crust and you can easily fracture the entire suprastructure. That gives a sort of insurance that you are not going to mobilize the foot plate. And in case there is a floater, then nothing can work without a laser. If you don't have a laser, you have to leave it, put a vein graft and come out. You can put a piston over that also for the refixation. But yes, if you have a laser, that is the only tool by means of which you can still make a fenestra on a floating foot plate. On a floating foot plate, you can make a fenestra. That's the amazing advantage of laser. Number two, at the time of fenestration, again, like Ashim had shown, using the micro drill like a cover, using it on a cover slip, very, very thin bone, you're not exerting any pressure at all. Any pressure means no pressure. You're just revolving over the cover slip. And the thin foot plate gets weakened and weakened and weakened and it goes off to give a fenestra. A slightest pressure on the foot plate can make it floater or a submerged foot plate. Again, laser has the advantage that you vaporize. Nowadays with the CO2, one shot with a calculated power, you can vaporize in one shot. One shot fenestration is the key without transmitting any extra heat to the vestibule. In experienced hands, you can do in seconds without mobilizing the foot plate.
Satish, tell me when the foot plate is irregular, like Ashim's first case, where the upper 2/3 was very thick, and does the single shot work in those cases?
Not really. If we had already discussed Ashish, like an obliterated one, you have to flush the obliterating material by means of a micro drill. You have to bring out the foot plate proper and then make a fenestra with a laser. in such irregular footplate. Irregular means most of the time the autosclerotic foci covers the footplate. Or some irregular, bars on the footplate. Sometimes you have to flush with a micro drill, and then use a laser as a fenestra.
So you have to blue line it no matter what, and
Yes.
then a single
Yes.
shot.
Yes. Yes.
Not any footplate is single shot.
No. Then you have to make, the firing again and again. That is hazardous.
That is hazardous.
Too
yes.
much of thermal,
Trauma,
heat in the surrounding can even damage a
Facial.
micro-dehiscent facial nerve.
Yeah.
You never know when the facial nerve is dehiscent in some portions, some
At the
millimetric
under surface,
micro-dehiscence.
yeah. Mm.
And such thermal damage to the facial nerve is hazardous. So
Satish,
single
comment. Wait, after this, comment on the intact stapedius. There was a discussion here. What is the value of keeping the stapedius intact? Is there any value at all or not? Yeah.
Yes. See, keeping the stapedial tendon intact and carrying out the stapedectomy has always been a matter of debate. A lot of people had published. Even we had done earlier using a different piston with a bar behind to keep the tendon there. But you know what happens? This mechanics is completely disturbed once the fenestra is there. There is no point in keeping the tendon intact. Nowadays, it has been proven if you have done a stepedotomy. The reason being, I tell you, see how we hear in a normal situation, the footplate goes in and out. Entire 3.2 into 2 millimeter diameter footplate goes in and out.
Is it
with
rocking?
micro movements, nano movements. The maximum of footplate in a regular hearing goes down and down every time to the maximum of 270 nanometers.
270.
Nanometers.
Okay.
Now, how the physiology changes after fenestration?
Mm-hmm.
See, in the primary situation, in a normal situation, this 3.2 into 2 millimeter thing entirely moves in and out. After the fenestration, only 0.5 millimeter, thing moves in and out, piston. Yet we hear good. How? The reason is the amplitude of the piston covers the dimension of the footplate. Got my point?
Sorry. Say it again.
Normally, footplate goes in and out to 70 micromillimeters, nanometer. On the other end, when the piston comes in place, it moves in out in micromillimeters, in millimeters. A normal piston can move up to 0.5 millimeter, not nanometer, in and out. And that compensates for the displacement of the perilimb to give us good hearing. Rather than 3 into 2 millimeter size displacement of the entire footplate, even a 5 millimeter displacement compensates. And now, once the piston is in, the entire mechanics change because the annular ligament, the original annular ligament is of no use.
Yeah.
How the tendon works? The contraction of the tendon, it is a sort of, protective phenomena, I would say. The moment the tendon contracts, the stapes goes a little bit out and the annular ligament is stretched all around to prevent the excessive sound from going into the inner ear.
So the
Now the
stapedius
physiology
can work.
changed.
Stapedius can work only on the annular ligament.
Yes.
I conclude that way. Yeah,
Now
okay.
the piston is working, so the original annular ligament is no more in place. Now whatever endosteal forms that covers the underside of the piston and surrounding that, it works as an annular ligament. That's why the vein is the most chosen material, what Ashim had shown, because the architecture of the vein is closest. The elastic fibers are closest to the architecture of the normal annular ligament.
Yeah.
Got my point?
Got it.
So the preservation of the tendon is all theoretical now.
Yeah.
Number 2, the use we are talking about. I hope it answers your query.
Yes, Satish. Thank you.
Now the second part of the use of the laser I was talking about is in the revision surgery. Believe me, it is of utmost value to use in the revision stapes surgery. If I get a revision stapes case and not having the laser, I would never do it. The reason being, the work at the oval window, Ashish, we have seen, discussed in various workshops.
Mucosal
What happens
scars,
in the revision situation most of the time? Scarring at the oval window. The scarring in the oval window prevents you from visualizing the exact side of fenestra, visualizing the fibrosis holding the piston to the oval window and surroundings. And if you try to pull fibrosis, many times what happens, there are fibrosis at the under edge of the piston, under edge of the foot plate with the vestibular end organs. And pulling the fibrosis can be something which can lead to dead ear. So in revision surgery, the laser is of amazing use. You can vaporize all the fibrosis around the piston, and you can truly make out the Stapes foot plate and the fenestra where the piston is going inside. That is impossible without the laser, without vaporizing it. Otherwise, pulling anything can be deadly.
Yeah.
So in revision surgery, you can vaporize all adhesions around the piston, yet keeping the piston in place wherever it is.
Yeah.
Sometimes, we discussed about the incus necrosis earlier. Believe me, we have done so many revisions. Incus necrosis, this is a myth that it is because of the tight piston, metallic piston or anything. Incus is most often necrose because of the piston at the both ends issues.
Reverse micro.
The piston is too loose, too loosely crimped at the incus. A loose piston will keep on hitting the incus and ultimately necrose. Similarly, if your lower end of the incus piston is suppose stuck at the edge of the fenestra or somewhere, which makes it immobile, then it will keep on hitting the upper end with the incus, and that leads to necrosis. So most of the time, the incus necrosis is because of these piston-related issues. Not rarely because of the tight piston, because the blood supply of the long process of the incus is not in the mucosa. It traverses through the core of the bone, and the main vessel leading to the tip, to the lenticular process, runs in the core of the long process of the incus antero-inferiorly, where you leave the incus free of the piston. So it is rarely because of the tight piston that the incus necrosis happens. It is because of either the loose piston because of inadequate crimping, or the incus stuck at one of the edges on the foot plate. Majority in those situations.
Yeah.
So the other question, Ashish.
Yeah.
I'm ready with the case also.
Yeah,
I can take a few questions if you want until the Ashish comes.
You can
Until the Ashish comes.
no, you can do the CT scan of the cochlear implant, because we have these two great cochlear implant lady doctors.
Yeah.
Yeah. So Chanel and Sriram.
Okay. So we met earlier. Dr. Sunil Dutt, sir.
Yeah,
who
he's here.
has pioneered this science. We have heard many a times about his work, his surgical, his publications, his surgical work, and the kind of word he spread in the field of cochlear implant is amazing. We have Dr. Shenal Kothari. We have many implant surgeons. So, coming to the case of cochlear implant, this science is, expanded like anything. The indications of expanded. A cochlear implant has revolutionized the rehabilitation of the hearing loss. And in the present context, the indications have expanded like anything. If you ask me in one line, any patient of any age group, right from 4 months till 100 years of age, having bilateral sensorineural hearing loss to the extent which cannot be benefited by hearing aid is a candidate for cochlear implant. Whatsoever the audiological other findings, other scores, whatsoever the age criteria is a candidate for cochlear implant. Anybody having bilateral severe to profound hearing loss, not getting benefited with a hearing aid is a candidate for cochlear implant by and large. So this is because of the better understanding of
the anatomy of the cochlea, anatomy of the inner ear, entire hearing system, the better results of the cochlear implant, the better implants available, and the surgical, technology which has expanded its indication, we have now reached to the level that anybody having severe to profound hearing loss can be better with the cochlear implant. It doesn't replace the hearing aid. The first caveat is benefited with the cochlear implant or a hearing aid or not. Because hearing aid, whatever gives hearing, is more, I would say, dynamic than the cochlear implant. It doesn't replace, cochlear implant cannot replace the hearing aid. So the first is the hearing aid. If benefits, nothing like it. If doesn't, then the implant is the only answer. Now further, going into the indications, what we believe, there is a minimum criteria to pass the candidacy for the cochlear implant, and this is something you can pick up by the MRI. MRI can tell you whether this candidate is a good candidate for cochlear implant or right candidate for the cochlear implant or not. So the minimum criteria to look on the MRI is what you see. Are you getting something on the screen, MRI?
Yes, Satish, yes, we can see.
This is my heavily T2 weighted MRI to see the candidacy for cochlear implant. See, the role of imaging in terms of CT and MRI is different. The role of MRI is to justify the candidacy for the implant. See what you see on this T2 weighted MRI, fat suppressed T2 weighted MRI. See, first and the most important thing is a fluid filled cochlea with a hyper intensity on this T2 weighted MRI. Bright signal on this T2 weighted MRI signifies a fluid filled cochlea. This is the initial requirement. And the second thing is, can you see on MRI from the cochlear base, this cochlear nerve running towards the brain? Can you see this? This fluid filled intra-auditory meatus, this black signal are the nerves. This bright signal is the fluid. See this carefully. From the cochlear base, this cochlear nerve arising and going right towards the brain stem. So the fluid filled cochlea and intact cochlear nerve is the minimum basic requirement for a candidate to justify for the cochlear implantation. This is something to be seen on MRI. After that only we go further with other counseling, with I would say immunization and other workup. The candidate has to be justified for the cochlear implant only on the basis of MRI with this minimum functioning unit being intact. That is a fluid filled cochlea and the intact cochlear nerve. And for this, MRI is the key. If your cochlea is dry, if your cochlea is ossified, a candidate cannot be a good one for cochlear implant. Number one, you cannot thread the cochlea with the ossified one with a cochlear implant. If you have a thin nerve, absent nerve, thin nerve is a matter of debate, not a debate as far as the candidate is concerned. It is a candidate for cochlear implant still. But an absent nerve is absolutely a contraindication for cochlear implant. And in that scenario, the cochlear implant will never be able to transmit the sound to the brain without the nerve. And in that scenario, ABI comes in question, the decision making. And those are the right indications for a brainstem implant in that situation where you implant not in the cochlea, but since the nerve is absent, then this nerve emerges from the vestibulocochlear nerve, the cochlear nucleus. And in that scenario, you have to implant right in the cochlear nuclei in the brainstem. So, for candidacy of a cochlear implant, an intact cochlear nerve and a fluid filled cochlea is must. And this can only be seen on MRI, not on CT scan. So there are many times unnecessary, debates on whether the CT is needed alone or a MRI alone is sufficient or both, or they both are unnecessary. MRI, what information which MRI can give cannot be given up by CT scan or any other imaging tool. And without this information, if you are implanting, can be a disaster sometime. Number two, the thin nerve question. Let me tell you, thin nerve is something is a matter of debate. But let me tell you, first, how to see whether it is a thin nerve or not. That is very, very important. And this is where I am coming to. See this, I have the same MRI. I have taken the sagittal plane now, reconstructed to the sagittal one. And what you see, this is your intra-auditory meatus. This is your cochlea. This is your cochlea, and the various nerves come from the intra-auditory meatus, come out from the intra-auditory meatus to the hearing and the vestibular end organs. This lower one is the cochlear nerve, and the upper one is the facial nerve. Though this is not a very good MRI, in a good reconstructed MRI, you can actually measure in terms of micromillimeters. We do at our center. See this cochlear nerve should not be less than the diameter of the facial nerve. As simple as that. If the diameter of the cochlear nerve is less than the diameter of the facial nerve, you can assume as a thin cochlear nerve. But whatsoever it is thin or not, if there is nerve present, is a good indication for cochlear implant. As simple as that. So in that scenario, you have to implant. Implant is your first choice. You can give your patient guarded prognosis that your implant may not work the way we desire it to be, but still this is the first choice as a treatment plan to rehabilitate these patients. In spite of having a thin nerve, the implant is the best solution as compared to ABI or whatever. So what we can broadly understand, the worst result of the cochlear implant are still better with the best results of the ABI. So in whatever scenario, even if the thinnest bundle of nerve fibers you observe on MRI, still implant is the first choice as a part of your treatment, as part of your rehabilitation management. Coming to the cochlear implant now, once the candidate passes the candidacy for the cochlear implant, the guys is the best candidate for cochlear implant in terms of having a good cochlear nerve, in terms of having a good cochlea, fluid-filled cochlea, and we go ahead with the cochlear implantation, then the role of CT scan is again very, very important. Now, once it comes to surgery, CT is a sort of Google map for the cochlear implant surgeon, giving you lots of information. CT will tell you the anatomy in the area where we are going to operate, the anatomy of the temporal bone, which can have impact on your cochlear implantation. It can have impact on your surgical part. So what to look into the CT scan from cochlear implant point of view? Ashish, because of the shortage of time, we didn't look at the CT scan before autosclerosis.
Yes.
We always mention we get amazing information from the CT scan.
Yeah.
If you get before autosclerosis surgery, it has an additional advantage. It may not be mandatory, but it gives you certain useful information to prevent intraoperative surprises. If you have an information of a proliferation now on a CT scan, you can be better prepared yourself. You can counsel your patient better regarding the further course of action, or you can abandon before if the patient doesn't permit. There are lots of information which can prevent surprises during autosclerosis surgery if you have a pre-op CT scan. And in our, the Stapes carnival, we had 3 cases of such surprises: gushers, the artery, the persistent stapedial artery. We had 2 gushers, one by one. Both patients didn't have CT scan, and afterwards we got the CT scan and found something which would otherwise, had we got that information earlier, we would never keep that patient for the surgery. So something which is very, very useful, but it is, you get such relevant information which can be game changing in less than 5% scenarios. So 5% is again too much in a surgery where you can, which has a possibility of giving almost near close to 100% result in majority of the situation. So regarding autosclerosis, you have to look at the CT scan from different perspective. Only those angles you have to look at which can have an impact on autosclerosis surgery. Here in cochlear implant, I'll touch upon the CT scan from different angles, how it can have an impact on cochlear implant surgery. Number one, if I come from above, you can have a look at the semicircular canal, their morphology. See the lateral, the superior semicircular canal. It is good. It looks normal, though the dehiscence of the canal is seen better on the coronal section. Here it doesn't make much difference in the cochlear implant signs, whether the superior canal is dehiscent or not. Doesn't matter. Just in autosclerosis, a dehiscent superior semicircular canal patient can be misdiagnosed as a patient of autosclerosis. As dehiscent semicircular canal can give low, frequency hearing loss, similar to mimicking the autosclerosis. If you are clinically alert, you can still, diagnose that, but otherwise sometimes it can be a misdiagnosis. So here in this cochlear implant, it is not of much use, but yes, going down, what we see, the first structure to be seen always by a cochlear implant surgeon on CT scan, the morphology of the intraoperative meatus. See, there are certain abnormalities in the inner ear which makes the direct connection of the CSF space, subarachnoid space, with the inner ear space and can lead to a surprising gusher and make your life difficult. And if you know this preoperatively from the CT scan, can be a vital information in terms of managing that situation, counseling your patient, in terms of predicting the outcome, and in terms of changing the surgical approach as well. So there are certain conditions which can lead to gusher, intraoperative gusher, and you can very well pick up from the CT scan. Number one, the primary idea you can get with the dimension of the intraoperative meatus. See, the dimension of the intraoperative meatus here looks good. Good because of the, this is what I can see with my experience, but you can measure even on this software. 4.14 mm is the mid diameter of the intraoperative meatus, which looks normal. Sometimes it is too big, bulbous intraoperative meatus, more than 6 millimeter. You can imagine the kind of CSF pressure it is going to pressurize upon the inner ear, and the chances of gusher are more. If it is less than 2 millimeter, less than 2 millimeter, the chances of thin nerve or absent nerve are more. So you have to be careful in looking at the dimension of the inner ear in predicting such problems to those patients, otherwise you cannot pick up. Now, second thing, the cochlear aperture. This is very, very important. We always discuss during our cadaveric dissection of the anatomy of the cochlea. See this, what you say, this bony-like structure within the cochlea in the center. Anybody? This
Modulus.
is modulus.
Modulus.
Modulus is the porous bone. Modulus is the porous bone, and that prevents the connection, direct connection of the CSF space to the inner ear fluid spaces. And if you find this modulus, this porous modulus on CT scan, this hyperintensity, you can imagine that how this cochlear aperture is not going to transmit direct CSF as a gusher to the inner ear. So when the modulus is intact, your gusher is unlikely. Number one, this is such a vital information you can get from CT scan. Number two, the diameter of the aperture. See this, the cochlear aperture here, the diameter of aperture is more than 2 millimeters. It is adequate. Sometime in the situation of the thin nerve or something, this diameter is less than, 1.5 millimeter, less than 1.25 millimeter, and those are the situations where again that makes suspicious of a thin or absent cochlear nerve. So the dimension is very, very important to know, and to know whether there is a chances of any gusher in that particular patient. Though, in spite of this, you can still have a gusher, because the CT scan doesn't give you picture of the membranous labyrinth. If there is problem at the membranous level, which is not picked up by the CT scan, still there can lead to a gusher. Malformations of the cochlea, whatever gross malformation you can pick up on the CT scan, are not all. There are many membranous malformations, yet on CT scan cochlea looking like normal, and still you can have problem. But those are less and unlikely. What you can see grossly on CT scan should not be taken lightly and should be taken into consideration to prevent issues. Now the third important thing from cochlear implant point of view is the vestibule. See, the dimension of the vestibule is important. This is normal dimension. If the vestibule is bigger, dilated vestibule itself can be a problem, which can lead to a severe to profound sensorineural hearing loss. So dilated vestibule can be an issue, may not give gusher, but can give oozer to trouble you, and it is important to keep on CT scan an eye on this. Then the very important issue is the vestibular aqueduct. See, this is vestibule and this is giving the aqueduct. See this? Very thin aqueduct at the posterior edge of the petrous bone. Similarly on this side, this is vestibule and this is giving rise to the aqueduct here. Very, very thin aqueduct at the posterior edge of the petrous bone, which is not looking dilated in this scenario. A dilated aqueduct can again have an impact by means of, through the vestibular pressure, can lead to oozer. Then if you go below into the cochlea, see this is cochlea. What you see here at the round window level, just medial to the round window, a very thin canal emerges. In this scenario, very, very thin. See, this is jugular bulb, and just above the jugular bulb, this thin canal leads to the cochlea. This is cochlear aqueduct. This is normal. A balloon or a trumpet cochlear aqueduct, let me show you on this side. See, this is your cochlear aqueduct, the other end, the cerebral end, and other end open here into the cochlea here, just medial to the round window. Sometimes this is over dilated, but it has been proven now, even the most dilated cochlear aqueduct is never responsible for a gusher. The reason being, it is filled with the fibrous mesh, which prevents a gusher, which prevents the fluid pressure directly transmitting to the inner ear. But yes, it can lead to other problems. A dilated cochlear aqueduct can transmit easily the infections from the brain to the inner ear, and that is the most common source of cochlear obliteration in the pneumococcal meningitis. This is the biggest source of transmitting the infection from the CSF fluid to the inner ear, but never responsible directly for the gusher. I am touching upon only those areas to be seen from the cochlear implant perspective, not overall HRCT temporal bone or what we discuss otherwise. Then the facial nerve. See, abnormalities of the facial nerve can have impact. Other malformation can lead or can displace the facial nerve either laterally or medially, which can be dangerous. In cochlear implant, we have to preserve the facial nerve. In a regular posterior tympanotomy, the medial wall of the posterior tympanotomy is defined by the facial nerve itself. So, in any sort of cochlear malformation, vestibular malformation, the facial nerve can be medially or laterally placed, and we have to keep an eye on the facial nerve all the time to preserve it at any cost. So here, how you can look at the facial nerve? Intraoperative meatus. This is the labyrinthine portion of the facial nerve. This is the first genu. This is the horizontal facial nerve, the second genu, and this is the vertical portion of the facial nerve. If in any given situation, if this is abnormal, sometimes the malformation of the lateral canal make the facial nerve abnormal. Malformation of the cochlea can make the facial nerve abnormal because this runs immediately lateral to it. So we have to keep this in mind. Next important structure to be seen here is the carotid artery. See the carotid artery. This is the horizontal petrous carotid artery. Here the genu, and see the relationship with the cochlea. This is the basal turn of the cochlea and this is the carotid artery, and this bone separates the cochlea from the carotid. If this bone is absent, imagine what can happen, and this has been published in the literature couple of times. This cochleocarotid wall was dehiscent. Surgeon put the implant in the basal turn of the cochlea without realizing where it is going, without knowing whether the carotid canal is dehiscent, and ultimately the implant, went into the carotid canal. No responses made the surgeon look back and then realized the implant was by mistake went into the carotid canal, and that's a disaster. So this is something very, very important, and I will tell you intraoperatively how one can avoid this by simple maneuver, by bringing the cochlear, the basal turn of the entire basal turn of the cochlea in a single straight axis, by means of which you can push the implant very, very clearly into the lumen. Or you can take the help of, in the extreme condition, fluoroscopy to know where the implant exactly is going. So in the case of the dehiscent cochlear canal, you have to be extremely cautious to prevent the implant pushing into the cochlear, the carotid lumen. Then the most important again one, see this patient. This is at the level of the basal turn of the cochlea. At the level of the round window, we can see the, what is this?
Jugular bulb.
Jugular bulb. See, this is axial section. What you see anterior-posteriorly, this is the level of the round window, and your jugular bulb is coming so high to be visible at the level of the round window. This shows a high jugular bulb. Now, if I reconstruct to the coronal plane, let's see what happens. This is your jugular bulb here. See this? And see in the coronal plane where the jugular bulb is here, right above the level of the posterior canal. See, this the lowermost one is the posterior semicircular canal, and the jugular bulb is reaching right to the level of the posterior canal. See very clearly?
Yes.
And this is the level of the intraoperative meatus, but jugular bulb is not going above the level of the intraoperative meatus. That is how some people describe or define the high jugular bulb. Reaching up to the posterior canal, high jugular bulb, reaching up to the intraoperative canal little higher up, that means a very high jugular bulb, and crossing the level of the intraoperative canal, very jugular bulb, is extremely high jugular bulb. So, and you can imagine the difficulties one can encounter. But in this scenario today, this is the level of the, see the round window. This is the level of the round window. Jugular bulb is here, but there is a thick bone above it. So it is never a challenge for us to penetrate the jugular bulb easily or damage it. This is important to know. Now at this level, if you look at the sagittal plane, how the jugular bulb goes, see, going behind, and how the inner ear is left anteriorly. So it is not in our territory, you don't have to do anything. It has to be left behind without doing anything. So jugular bulb is one thing which we must see on the CT scan. Another thing is the pneumatization of the temporal bone. See, this is absolutely normal pneumatized temporal bone, normal in the scenes, no opacity. Suppose in this particular patient, all this pneumatization were opacified, completely opacified, and if you elucidate the history of the patient of having recurrent cold, with already otitis media setting in, if you do a direct implantation, a regular implantation, and imagine if an infection reappears after the implantation, or otitis media develops after the implantation, or the implant is a foreign body, with a foreign body in a place, with infection in the, mastoid in the middle ear, what can happen? Imagine how difficult would be to treat the infection in the presence of the foreign body. Majority of the time, even the best of the culture-directed antibiotics do not work. And in that scenario, anywhere in the body, with a foreign body in a place and infection develops, it leads to biofilm formation, which gives the most favorable, surface for the biofilms to form on the implant, on a foreign body surface, which are most resistant to be taken with any antibiotic. And in most those scenarios, still you can salvage the implant by extreme care and biofilm removal and all that, but doesn't guarantee the infection not coming back. And those scenario, most of the time it is the explantation which saves the patient. In an implant scenario where you have already opened the avenues for infection to spread to the inner ear by means of round window or through the cochleostomy and then to the subarachnoid space, the chances of spreading infection high up are more. You open the gateways and you can't take a chance of patient giving a meningitis. So in case of implant in place, otitis media, infection not coming under control, ultimately you may have to explant to save the patient. So that's a disaster. And a simple CT scan can tell you the patient getting recurrent cold, Eustache and tube issues, already opacified, pneumatized structures are opacified. There is these are the cases worth considering for subtotal petrojecmin implantation at the same stage, even for cochlear implantation, to take away ablate the middle ear. See, after the implant, the middle ear and mastoid doesn't participate in the hearing. But once you block off all sources of infection incoming to the temporal bone, what you do in subtotal petrojectomy? Remove all mucosa skin from the temporal bone anywhere. Remove the extraordinary canal along with the skin, tympanic membrane, all ossicles, all air cells containing mucosa if you ablate, and block off the incoming sources of infection, that is extraordinary canal by means of a cul-de-sac closure, and the Eustachian tube by means of a drilling of the Eustachian tube and obliterating it, preventing incoming sources, blocking all incoming sources to the temporal bone, and remove all skin and all mucosa and obliterate the cavity. You create a safe zone in the temporal bone to prevent future infection coming in and affecting your implant. So in those cases where already the infection is setting in, where the patient is a high-risk patient for getting infection to the temporal bone again and again, means like a cleft palate patient with a malfunction Eustachian tube, severely eosinophilic allergic patient, Eustachian issues getting recurrent otitis media, those are the high-risk patient, or patient who have had developed CSOM earlier operated. There is no guarantee for CSM not to come back. Those are the high-risk patients, and our approach in those patients is to do a subtotal petrojectomy implant and preventing future sources of infection without affecting the outcome of implant, because while after putting the implant, the middle ear and the mastoid doesn't come or to play any role in the implant function. So that is a wise strategy in those scenarios to do a subtotal petrojectomy implant and obliteration to prevent future infection coming in. So CT scan will again tell you if there is any severe source of infection, severe sinusitis behind. Look at the sinuses, if they are affected badly, severe Eustachian tube issues, any other condition affecting the implant outcome, you can pick up, and accordingly you can choose the different technique. Similarly, round window is the principal area through which we enter into the cochlea. Or rather, I would say round window is the backdoor entry to the cochlea. And we, in a conventional technique, we expose the round window through the posterior tympanotomy. Sometimes the cochlea might be rotated congenitally or whatever. or the anatomy of the extraordinary canal will make it life difficult. So how you can see the favorability of the round window visualization? Again, simply, there are many people have brought different strategy to know the favorability of round window visualization. Simplest, let me tell you, what you see through the posterior tympanotomy. What is posterior tympanotomy? Posterior tympanotomy is nothing but a window lateral to the facial nerve. This is the facial nerve. This is the genu of the facial nerve. This is the vertical portion of the facial nerve. So the posterior tympanotomy is a window lateral to the facial nerve, but medial to the annulus, so you don't enter into the extraordinary canal. And to take the reference of the annular, we can take the reference of the chorda tympani, which is running immediately medial to the annulus. So if we make a window between the chorda and the facial and directly get an entry into the retrotympanum where the round window is, without entering into an infectious field of extraordinary canal. That is a simple philosophy. So how we can do it favorably or not, you can pick up by the same means. See, this is your facial now. See this. This is horizontal facial now. This is vertical facial now. This is vertical facial now I am looking at. And from this vertical facial now, if you go below, this is the chorda tympani which arises. See, this chorda arises and go to the annulus. So, and that is the level of the annulus at the medial end of the posterior canal wall. Now, this is my facial now. This is my round window level. Where I look through the posterior tympanotomy, let me draw two lines. See my one line, I am my lateral limit, that is chorda. Can you see this? This is my lateral limit and this is my facial now. The other line parallel, let me draw parallel to the facial now. See this. From here, from laterally here, I have to drill the mastoid, go medially until I reach the chorda tympani medially and the facial nerve laterally. And in between these two, if I draw these two lines, these two lines, if the round window is falling in the way, in your visualization, there cannot be a better favorable condition than this. Got my point? So this is the, in my opinion, a favorable round window falling in between two lines. Relate clinically while doing I will show surgically as well. While drilling the mastoid, my lateral limit of visualization I'll keep in the chorda tympani medially facial now. In between, I have to drill the bone to look at the round window. And if the round window falls in that between these two lines, means it looks favorable. So this is something you can have an idea. Though it doesn't mean it is in a contraindication. There are many ways. Suppose the cochlea is rotated medially, your tilt may not give you a good visualization of the round window. In that situation, you may have to mobilize the canal wall. Make two vertical cuts on the canal wall, keeping the tympanomeatal flap intact without piercing the flap, and you can mobilize the canal anteriorly. And you can have a wide space. In whatever rotation, you can still see everything open to you. So these are the fine points. Quickly, I could see from the cochlear.
Ready? Case. Hello.
Final. Oh. Yeah. So this is how we can make out the anatomy which is related to the cochlear implant better before implanting the patient. Now I have a full idea in this patient where how the anatomy is going to be. Any further questions? Anybody on the radiology part?
I think.
Ashish?
Yeah.
Has Ashim come?
No, it's
Satish Vikram here.
Satish.
Yes.
There's another line that we were discussing here that we draw along the posterior canal wall like you did for the chorda, and another line exactly there going through the anterior edge of the sigmoid sinus. the two need to bisect. And if you go back to that basal turn,
that is another
axis.
criteria. Yes,
Correct.
what you're trying to say, I got your point.
Yeah, yeah.
But see what I'm pointing here, in a very simplest manner, what we follow in posterior tympanotomy, two landmarks.
Yes.
We follow these two landmarks, the chorda and the
And the
facial,
facial.
and come laterally from here, watching in between these two.
We are not able to see your laptop image.
Yeah.
Not
So
really?
Yeah.
Can you,
They've just switched, I think.
Dinesh, place the CT scan picture there.
So that corridor, we call it
Yes.
the.
So what I'm see practically, I am going to drill through this bone
Yes.
and see the chorda anteriorly, facial behind, and in between further go anteriorly.
Correct.
And round windows there in between. That means it is not unfavorable. You can rule out.
Correct. So there's no rotation of the cochlea, and this is the facial recess corridor, and surgically it translates to a sniper shot trajectory is what we call it when you have to open up the facial recess. So beautifully demonstrated, Satish. I think there's so much more we can do with radiology, but I think we want to see you in action. Let's go for the surgery.
Two quick questions.
Thank you. Anybody, any question? Regarding this facial recess, what Sunil Das sir mentioned, let me tell you, this space between the, this facial now between the facial now and the chorda tympani, this remains same in the adult or the same size what it is at the time of birth. This never changes. See, there are certain facts we must know, and this is important here in the cochlear implant science. The size of the cochlea is of same dimension in the adult what it is at the time of birth. It never changes. Size of the middle ear never changes. Size of the facial recess never changes. What all changes is the development of the mastoid. Mastoid is not developed at the time of birth. Development of the posterior canal wall. The posterior wall of the axonotary canal, it changes its dimension, its curvature, and makes your life difficult, but not the facial recess. And that is the basis of implanting even the youngest of children. So you can implant the youngest of children considering the facial recesses of same size. It never changes. You can further, if you really want, let me tell you, we really want to know the size of the facial recess in any patient. If you really want to calculate in millimeters, you can. Let me put you on this sagittal scan. Sorry, first I will apprise you with the coronal and then sagittal. See this coronal scan. You see how the chorda leaves from the facial now. That is something you need to see. See this. This is your facial canal here. Right? This is your vertical facial canal. This is your vertical facial canal. And now I will take you to the sagittal plane. You can see actually the chorda emerging from the facial now, the angle and the space between the chorda and the facial now. See, this is your facial now. This is your facial now. In a good CT scan, you can pick up. Can you see the facial canal very clear? Number one. Everybody.
Yeah.
Can you see the facial canal?
Yes.
How it is horizontal, then genu and the vertical one. Very clear?
Yes.
And from here, this is the emergence of the chorda. This one going laterally. Yeah. This is the chorda tympani if you see. That's the chorda tympani if you see. And this space is the facial recess. So you can actually make out the size of the facial recess, but whatever, it never changes after birth. This is very important as a fact. Anything more on radiology?
Sir, Satish, Vikram here. In the two parallel.
Can you raise your volume, boss? It is not audible here.
the two parallel lines you showed for the posterior tympanotomy, can you get back to that image?
Yes. Here.
Yeah.
See this? This is your facial now. And you
Oh, the
can
one
see
you
your
showed
facial.
going through the chorda and then going through the facial, the two parallel lines you said that is a, if the
Yes.
round window comes, yeah. So
See,
in,
parallel line is to show you to understand.
yeah.
But what
So-
you understand here, why parallel line? See, this is your chorda tympani and this is your facial now.
Correct.
Again, let me get back to you. This is your horizontal facial.
Yes.
This is genu.
Yes.
This is your facial now. You all can see. Can you see the facial
Yeah.
now here? Very clear?
Yes.
This is your facial now. And this was the chorda.
Yeah.
See the chorda, how it emerges from the facial now.
So my
Chorda
question is,
emerges from the lowermost part of the facial now here
correct.
and goes like this. Goes
Fantastic.
like this above.
Yeah, clearly
So
see.
here is the level of the medial end of the canal wall, the medial part of
Correct.
the exodontary canal. That is the level of the chorda.
Yeah. So my question was in the image that you had put the parallel lines,
Yeah.
the round, yeah, this, no, the one after this. One, yeah. So, no, before, yeah, this one. So the round window membrane, I presume it is that edge, and there's a slight bony overhang, which
This
is
is-
appears on the
this
CT
is-
scan. So
Yeah.
you said it will be straight, but don't we have to remove that overhang before puncturing the?
Yes, yes.
Yeah.
See, this is the
How
round
much of
window
it can we,
overhang.
up to what level we can drill it out? That is what,
Yeah,
that was
you can overhang, you can drill any.
my second
it is of
question
no
was,
importance.
yeah, my
This
second
hides
question.
this hides the round window from visualization, and you can
Yeah.
drill it very well. It doesn't contain any vital structure for that matter.
Yeah, so in this particular scan, it is not a sniper shot as Dr. Sunil that pointed out, because unless you drill that out.
Yes. So
Correct.
that's what I am going to show you, how
Yeah.
this bony overhang hides the round window.
Yeah. My second
You
question
can
was,
pick up very well from an axial CT scan like this.
my second question was, you gave the example where the bone between the carotid and the basal turn was absent. And you said
Yes.
the surgeon went in, got no response. Now, what I want to know is, once he
Yes.
withdraws the implant, there will be bleeding from the carotid. Because
No.
yes, no?
No. See,
Acha.
this is the area of the carotid canal where the bony canal is dehiscent. And here carotid is surrounded by the thick periosteum as well.
Okay, thank
So
you.
your implant is a soft structure.
Okay.
Soft structure if goes straight in the same, see the axis of the cochlea. See the axis of the cochlea and axis of the carotid.
Hmm.
It can pass in the bony canal, very soft cochlea, yet without damaging the periosteum. It is too soft to damage.
Okay. My next.
Now it has electrodes all around. Now what happens? Once you realize on radiology that the implant is misplaced in the carotid canal,
Hello, Satish. Chalo.
I would never request it to pull it out.
Yeah, got it. See, it doesn't puncture the carotid. It goes into the canal.
Yeah, it is so soft. It goes in the bony canal. That's it.
जाने छोड़ यार होता नहीं है साल में कितना केस रिपोर्टेड है ऐसा
many
now the imaging is such that I don't think anybody will operate.
Yes, that's what the
There's no
role of
question.
imaging is.
Yeah, correct.
That's
So
what.
that situation
That's
cannot
why.
happen now.
That's why you have to see the CT scan yourself.
Yeah,
See
Satish,
the
please-
kind of
please
dynamic.
start. अभी सर्जरी शुरू कर बाबा 1.25 घंटा हो गया.
Let's go.
Please.
So that's why you need to look at the CT scan yourself. Such kind of dynamic information will never be or can never be furnished by radiologists.
Yeah. Okay.
So
I
you
got
need to
Chanel and
know-
Shreera अभी वो बेचारे कुछ comment ही नहीं कर सके. Hello, are you all there?
Yes, sir, very much.
Please make some comment.
We are here, sir.
So
Yeah.
this is the best image to understand
Yeah.
how the facial nerve is medial and
Yeah.
the chorda is the lateral part of the facial recess. How these two boundaries become the lateral and the medial boundary. We can see it best in this image that is being displaced.
Okay.
ये जो
Shri,
image-
you want to make some comment?
No, sir, I was learning many things.
Okay, you all can please be around for the cochlear implant thing, and we'll invite Nitika and Ashima. They are there for actually supposed to be there for the allergic part of the fest. Because
Yes, sir.
both do a lot of work on allergy, but you can continue because now Satish will. So we can have all four of you all making your observations and comments.
Yes.
Yes, sir.
Thanks.
Okay, birthday boy is here. All of
Boy is
you
here, yes.
wish happy birthday. Happy birthday.
Lights on, please.
Lights on, please.
One more time.
One more time. In presence.
Hello. Udo.
Happy birthday, Ashim.
Happy birthday.
May God bless you. Wish you all the best.
Thank you. सुभाष अभी टाइम है तो कर दे. So the cake cutting is not allowed here and we're not doing it now. It'll be at the end of the session in the outside. You're not allowed to bring any food items here. So that will be, although Ashim said no, Satish insisted, no, we have to do it. Welcome to the old age is his message. We have to embarrass him, he said.
Senior citizens. You have to get a card, Ashim.
Citizen card.
Card.
Are you eligible? Is it 60 or more?
60.
60? 60. 20 for 25%.
Line begins at 60 and the first grade is fine.
Fine, okay. Thank you very much. So while Ashim is there, Rucha, bulao, sabko bulao. Come there. Just a little token, extending our Sunil. Can you please come? Narayan. उसको जरा शाल पहनाएंगे in the Indian traditional thing, but it is a Tiranga shawl. No, it's okay. No, you do it. You all are the guests of honor today. Vijendra has gone to the bathroom. 1 minute. So while Satish is getting ready with us, we'll utilize this time. No, it's okay. It's okay. Where's Vijendra?
Lights.
Yeah. Lights लगाओ.
Asked Ashish to go OTP, way OTP.
Subhash knows only how to put off the lights. He doesn't know how to put them on. Subhash, happily married guy. Okay.
That is oxymoron, happily married.
Who said that? Okay, where's Vijendra? He's not here. Should we go there? Catch him there while he's catching. So this is the Sunil, आप पहनाओ सर को. इसको भी हमारा इंडिया ग्रुप we are extending. Here, hold this. With taking this. Hitesh sir, आ जाओ. Please come. Subhash, अपना पूरा गैंग आ सकता है आपके. Please come. Thank you. We have a gold-plated tuning fork. You can gift him this. And there's one more which will be
negative.
Next candidate. Oh, Vijendra किधर है? Pick it up. Maruti, ये come. अपना hello. Our esteemed faculty, please come for the India group. All the creation that you see here is courtesy Subhash Lila Vansali we call. Directed by Hitesh sir and Rajeshri, our coordinator. She's the one who's been declining many people. Sir, isko lene ka hai kya nahi lene ka hai? Vikram, she was the villain. विजेंद्र सर आने देना उसके हाथ से. किधर गया? I think उसको कॉकलियर इम्प्लांट में इंटरेस्ट नहीं है, भाग गया वो. On the phone? Okay, then maybe I gift you this.
Thank you.
Okay, bro. Thank you everybody, and I hope it is going well. Yeah. A word, yes.
Guys, this is beyond overwhelming. If I shed a tear, don't laugh, okay? Because this guy is beyond, I mean, more than a brother. We share secrets that even siblings don't share probably. And Satish, me and him go back a long way. Sunil was my classmate, my roommate, and my batchmate, and I've learned so much from him too.
Yeah, I mean, that was a time when he created that angiofibroma thing. The angiofibroma thing was the Bible for juvenile nasopharyngeal angiofibromas when we were students, created by this man. He is quite the genius, you know. Very humble guy, but quite the genius. But, oh man, the biggest applause should be for Dr. Bunkar here. He's your friend. His biggest claim to fame is that he's my friend.
I want to say something. Sunil is here for a very special reason because I think he's doing a great work for academics of ENT by running that Venta WhatsApp group. Besides all his personal, but this is a great contribution that he's doing to facilitate ENT education of a very high caliber. And the way you structure the day and the program is really incredible. It speaks of your brilliance and a commitment as a teacher. You have an insight into what is needed and therefore you evoke the best. And it is to salute that master teacher in you that you are here as the guest of honor.
Superb. Hello. Can you hear me? Hello.
Yes. Yeah. Okay, Satish.
Hello. Ashim, can you hear me?
Yes, brother, I can hear you.
Hello,
But
everyone.
we don't want to hear you. No, hello.
Hello, everyone.
I can hear you very well.
Was to continue that, let me tell something about our master, Ashish. If people do not know him much, let me tell you something, how it has, he has made us proud at a different level. What Ashim had shown was a middle ear surgery. We all know middle ear is an integral part of our ENT science. What I'm going to show is something beyond to the inner ear. What Ashish is doing is something exceptional. He started with a certain issue which ENTs would not touch or ENTs would not impinge upon. The external ear part, the pinna and the external canal and the reconstruction of their deformities. And it was originally, it has been considered as a baby of plastic surgeons, we all know. What Ashish has done, not only went into this field and revolutionized the science of reconstruction of the external ear and the pinna, what plastic surgeon has been doing the same thing. He has gone beyond now to reconstruct the hearing at the same time, at the same time of reconstruction of the external ear, which plastic surgeon would never do. They would never understand the ABCD of the hearing science. And this is something exceptionally beneficial to the patient, where he gets reconstruction of the external ear, his pinna, deformity, external canal, at the same time the hearing as well. And we salute him, and he is in the world level, in the world circuit, in the most prominent surgeons, in the list of most prominent surgeons doing this work, and probably the only one who is doing the hearing reconstruction at the same time. And now at his center, not only from the pinna to the middle ear to now to the cochlear implant and beyond, he is giving the complete hearing or the ear solution to the ear problems at one stance. So salute to you, Ashish.
Thank you, Satish. Thank you.
Sir,
And
am
we
I
hope
allowed
some,
to?
we hope some, if you can enlighten us in brief for
Later,
in 10-15 minutes after
if,
this surgery,
if
in
time
between the
permits,
cases, to know what exactly the kind of work you are doing.
No, thank you, Satish. Thank you for all that. But your camera is, I think, 5x down. Very blurred vision.
Yeah. So I'm focusing the camera now.
Yeah.
And let me tell you, I'm operating from one of our best friends' place in Agra at Dr. Rajiv Pachori's place from his own theater. So Dr. Pachori has been, the integral part of our academic activities for long. You have seen during the COVID times, the webinars and in other activities. And he has been a fantastic cochlear implant surgeon, has done hundreds of implant, and probably in this region has done maximum in the youngest of children. He owns his own center, and I am operating from his center live today from Agra. I am in Agra today. So thanks to Pachori boss again.
Yes, thank you, Rajiv. Thank you for everything.
So are you getting the picture there now?
Yes, yes. Beautiful pinna. We can see a little bit.
Better now?
Yeah. Yeah.
So now coming to the surgical part, we have seen the radiological part, the workup. But once it comes to surgery, I'll go by the conventional approach for the distinct advantages. So in conventional approach, what
So
you
this
need
is a
to go.
2-year-old child, Satish?
Pardon?
This is a 2-year-old child?
It's 2.5 years.
2.5. Okay. Yeah.
So younger the child, you can take more advantage of neural plasticity and modulate it and give better hearing and speech. It is the speech development which is critical. That's why younger you operate, better it is. The youngest we have operated at our center is 8 months old.
Okay.
That too bilateral. So here, now coming to the surgical part, the incision, we all know in otology, retroauricular incision is a most popular one. For the reasons I tell you, the same here, because it respects or it doesn't compromise the vascularity of the ear all around. Ear is by and large supplied inferiorly by the, majorly by the occipital artery, which runs underneath the, the digastric ridge. The posterior auricular artery, anteriorly the superficial temporal and its branches going behind, the middle temporal and other branches. So this region is richly supplied by all around vessels. And our retroauricular incision doesn't go across any major vessel. So my incision is basically a retroauricular one, a little behind the groove and a little extension superiorly for our comfort, where we place the implant. A simple incision. Can you see?
Lazy S incision.
Lazy S, you can say. Inferiorly, I am not going much because that is not our area of interest. And here I am going through the thickness of the soft tissues. Thickness of the soft tissues, not right to the bone. So I will, simple. See, this is the superficial soft tissue I am going through. See this one? And this plane I will continue forward. See, we have infiltrated at least 15 minutes before and you can see the result. The reason being, I don't want to use too much of cautery. See, here in this surgery particularly, we are going to use a foreign body implant. We want to respect the tissues to the maximum to prevent infection, to respect the vascularity to prevent necrosis or infection, the dissection, preservation of the tissues more and more to prevent tight closure and give way, and more importantly, not keeping the incision lines over each other to prevent dehiscences. So all this is important. See why I am using cautery minimal, so I don't ultimately lose the tissue. The tissue loss is minimal. I can use the minimal cautery to take care of my vessels. The bipolar here I am going to use.
We don't use monopolar at all for any cochlear implant. There's no plate fixed at all. If at all you use bipolar.
This is to prevent the tissue shrinkage.
See the small vessel. And see, so far I have not used any cautery. Bipolar on.
This incision would give us a good coverage and space for processor also.
Yes.
Yeah.
Is this the same incision you do, Chanel?
Yes, sir, exactly.
All of us.
Please feel free to interrupt me for any query or anything you do differently.
Satish, you didn't show us any markings for the template and all that. You don't do that.
Yeah, I will show, sir. Right now, I have just see my anterior level is the extraorbital canal, which we are not supposed to penetrate. See this? This is the cartilage of the pinna, the lower cartilage.
Concha.
Yes. And see, this is the canal. So my first incision, and give you this kind of exposure. This is the musculoperiosteal tissue behind. Now,
I will do some undermining to expose more periosteal, more area behind to make my flap. That is what I am going to show you. See this? Undermining. More and more undermining to expose the cortex behind.
And also this will help us in easier mobilization of the tissue later on when we close.
Yes, yes. Exactly. See this? And see the whole cortex is exposed nicely now. This is the area of the mastoid tip, the lower bipolar.
Yeah, there are about 15 steps, surgical steps that you have to meticulously do with the cochlear implantation.
Yeah.
Incision, skin flaps, and then the musculoperiosteal flap.
Now see, the entire cortex is exposed. Now my area of interest is here, not much inferiorly, and superiorly I am going to place my processor underneath this tissue. So now I will make a superiorly based flap, a wide random flap. Wide random means my base would be wider than the tip to maintain the vascularity. For a random flap, a 2:1 ratio keeps it safer. See, that is the mastoid part, and now going like this to make it wide and wide. Sometime you may come across some emissary vein that you have to deal with it.
So in fact, with the soft tissue that is lying above this musculoperiosteal flap, we also create a small layer which will help us a second layer of closure before we do the skin.
Now see, I am cutting the periosteum deep here. This periosteum is tightly tethered on the bone. This is tightly tethered on the bone, which I am elevating off.
So, Ashish, is there a laser pointer here that we can use from here? Dinesh?
See, that is the flap. This is musculoperiosteal flap, vital flap.
Yeah.
To expose the cortex. Now, as I go up, I'll make this wider and wider because there's a random flap.
So as he says, this is a posterior-superiorly based musculoperiosteal flap. So the receiver stimulator package should be completely covered with this flap. So
yes,
he will make sure if he's doing the well or putting a tight subperiosteal pocket, it will cover the receiver stimulator package completely.
Yeah.
And you can see the incisions that he's taken for the musculoperiosteal flap do not cross the skin incision. So no incisions of the 2 or 3 layers that we will get here are overlapping. So I think that's very crucial. These are strict principles of surgery that we adhere to in CA.
See this, I have a wide flap. Now
so
look at the incision lines.
Tissue later on?
Look at the incision lines. My 2 lines are here, and this incision line doesn't overlap. Can you see?
Very good. Very nice.
So this is something important to prevent dehiscences. Minimal use of cautery.
Chanel, you were saying?
Wide flap.
Yeah, so we take soft tissue, the fatty globules that you get immediately after we give the skin incision. So I was just wondering that when would that is what the way we do it for the closing the cochleostomy.
I don't know what Satish does. Well, what we do is we take it from the temporalis. So both a small square of temporalis and a bit of the temporalis muscle too. So I use the muscle for the posterior tympanotomy, and I use the temporalis fascia, small bits of it for the seal, like the periosteal seal of the cochleostomy. Yes.
Yes.
Now we've stopped doing laser. Yes. So you have a point there. So we've become as minimally invasive as possible. We just do a C. My flap is a little more postero superior. That's why I asked him about the skin markings right up front, which he didn't do. You would mark the Frankfurt's plane, okay? And then 45 degrees to 60 degrees would be the angle of the receiver stimulator
Of the
package.
receiver, yes.
Yeah. So if the RS package is marked here, so there are templates by each company given. So if you mark the RS package here, you can actually tattoo the middle point of the implanted electronics of the RS package so that you get this angle perfectly fitted. So the musculoperiosteal flap also will be in that direction, like this.
Yeah, the
So I do
marking on the bone will be there.
absolutely. So you need to find the tattooed methylene blue tattooed periosteum right up there, and that's exactly where you want to put the well. And this is more crucial when you're doing bilateral implants, because if you marked it properly even before you start the surgery on both sides, you will maintain that symmetry in bilateral implantation.
That is more important in bilateral implant to maintain the symmetry.
Yes.
So now I have not marked anything yet and will tell you how do we do. Knife. So by and large, what I have done so far is made the incision and this periosteal flap, which are not falling on each other. Knife. और थ्री दादा ये चालू है क्या अलग अलग करना पड़ता है क्या यार
That's true. Deepak Dalmia is saying, Satish, there's a small injury possible to the mastoid emissary vein with this flap, and how do you handle that?
Yes. You can. So if there is an emissary vein like this, suppose comes over here, you can try to clog that with a monopolar cautery, with a bipolar, or in a difficult situation, finding difficulty, don't think twice and put a bone wax. That's it.
Put bone wax.
Bone wax will close it immediately without any problem.
Yeah.
Now, what happens at the end of the surgery during closure? Now, what happens during closure? Because this tissue retracts a little bit. At closure time, if this tissue retracts, the closure becomes tense. Can you see like this? A tensile closure is dangerous because it can give way. See this? Because the tissue has a tendency to retract everywhere a little bit. So what we do at this time, in
Not
the
just the
beginning, not later
retraction,
on.
Satish, not just the retraction of the tissue, it's also the fact that you're putting a big receiver stimulator package. There's a foreign body intervening, correct?
Yes.
So that would definitely bring it down. So what are your tricks to
So
help
what I'm doing now, see this tissue happens to retract. So what I'm doing, undermining.
release incisions? Yeah.
Releasing the tissue.
Very good.
Releasing the tissue in the beginning of the surgery now. See, for the closure, my tissue.
Correct.
Because at the end of the surgery, when the implant is placed, I don't want any additional bleeding.
Yep. Perfect.
So I can do a little bit undermining here and release the tissue. See this now, the closure will be absolutely good.
Yeah, after you've taken the implant out, there is no cautery at all. Absolutely. Not even bipolar.
So you can do this anticipating this fact.
Correct.
See now, my closure will be much tension free. No tight closure.
This is a very important step.
Tight closure can give way. See this? I have taken this additional tissue, just undermining little bit, not much. See this? Tissue is coming, getting pulled easily.
Yes.
A little bit of the undermining. can prevent from a problem, because if this tissue contracts and if you do a tight closure, it can give way and your implant get exposed, and that's a disaster. See, if your patient develops infection afterwards, the implant company is not going to replace the implant in case if it is explanted. Infection is not their fault. Anteriorly also, see this?
Yes.
Little bit of undermining.
It's such a crucial step. The surgeons are in a hurry to get to the next step, do a cortical, get on with implantation, and they want to be the fastest cochlear implant surgeon. So I think speed is doesn't make any sense to this child.
You know, everywhere I have a loose tissue to suture it easily. See this?
Yes.
Yeah.
So this undermining is crucial and should be done bipolar.
Nicely done.
So this is all soft tissue work so far. Our next work will be to approach the cochlea, and that is where the bony work starts.
You have to balance.
We have to approach the cochlea as is said by the conventional approach from behind. And in order to reach the retrotympanum where the round window is, we have to go through the facial recess. This is all because of this soft tissue.
Do you use Kirtane's retractor, Satish?
I generally don't use any retractor in this surgery, sir. I'll use my threads to keep the area open.
So you take some stay sutures.
Yeah, even the retractors can damage the tissue.
Right, right.
What is special about that retractor?
Kirtane's retractor, as I was saying, there's a posterior superior flap, right? And Satish's flap is a little superiorly based. So like I said, if we did the posterior superiorly based flap, Kirtane's retractor goes under that. And then the subperiosteal tight pocket that you can create is just the right dimension with Dr. Kirtane's retractor. It's very nicely done. He's done it with Kalelkar. There's also a suction port attached to it. There's a light attached to it.
And also it's
Maybe it's
concave
very
inferiorly.
Yes, and most of us have it in our CI set.
Sir, can you see now?
Very good. Yeah, now you're doing it.
This is my template.
Yes.
This is a metal implant I'm putting today.
This is a metal implant with this is the ear level processor. This is the template.
So my processor should not overlie the implant.
Correct. Also, if you can show us the receiver stimulator template also, Satish, it must be there. Put that with it. Yeah. So the idea is the edge of the speech processor and the edge of the receiver stimulator package, like he's showing here, should have a slight gap between the two. In fact, there's debate about how much should be the gap, 1 centimeter, 2 centimeters, but there should be a significant...
Doesn't make any difference. Even if it is very close, doesn't make, because simply your external mic processor should not overlie that.
That's all. Yeah. So this much space is important. It should not overlap.
Yeah.
That's all. That's all. Very good.
See now. So now what I'm going to do, this is my template. What I'm going to make sure this, my well is going to above this template. So like sir said that you may use the methylene blue dye across the skin to even paint the cortical bone. What I'm going to do is, I am going to use my thin diamond drill.
Correct.
And make my mark. See this?
Yeah, that's a good idea.
And I will keep my processor posterior superior to it. That's it.
Perfect.
This will keep reminding me that where my external processor is going to come.
Yes.
In any given situation, my processor will always be above this. See this?
Very good. Yes.
Fine?
Yep.
So would you maintain an angle of 45 degree or that does not matter much?
Doesn't matter.
For the
See, it
procedure.
matters when you do bilateral same stage. Then really like what Dr. Sunil Dutt mentioned, you have to maintain the symmetry and then it should be exactly at the same level.
Because what the
So what are the
parents
precautions?
notice is the asymmetry. एक ऊपर है,
हाँ.
एक नीचे है, ऐसा क्यों है, doctor?
So what are the precautions that you take, sir, to maintain that symmetry, that spatial symmetry?
That
Any
is what,
templates?
yeah, that is what Dr. Sunil Dutt mentioned. Take the level of the Frankfurt plane.
So if you stick to that in every case, so you're unlikely to go asymmetrical.
Fair enough.
Yes.
But it is something that the parents notice. So so the question
Height of the receiver,
absolutely.
the receiver stimulator.
Yeah. Why is this coil below? Why is that coil above? Or forward or backward?
It's the aesthetics, not the physiology.
Aesthetics.
Yes.
45 degrees. Sunil, what makes the decision about which implants they use?
Yeah.
Okay,
In India?
sorry, 1 minute. Those who
Yes.
not interested in cochlear implant, now is a good time to do your lunch because after this is going to be FES and the master is going to go berserk with
And
the
one
CT scan.
inverted papilloma.
And inverted papilloma. So this is the best window for those who are not into cochlear implants. The Vista is the name of the restaurant. Dr. Subhash and Hitesh can guide you. There's a special section reserved for us there. So those who wish to go. Okay, thank you. Sorry Satish and sorry Sunil. Yes.
So Arun was asking a question, which implant, how do you decide on which implant? So there's private practice, there's government practice, Arun, in this country. So in the government schemes, including the national government and the state government schemes, the implants are decided by the government on a tender basis or a rate contract basis. So we don't have a choice in what implant or which company implant. But in private practice, most parents want to know what is the latest technology. For example, there's a big talk about Nexa. We discussed that in Venta too. So there's every slab that is possible from 5.5 lakhs to 21 lakhs today with the Nexa implant. And we need to discuss with the parents what it means to have a 5.5 lakh implant to a 21 lakh rupees implant. And what are the features with each of these?
See, it is the features and technology which makes the difference.
Yeah. So once they decide on that, we go with that. So private practice, there's an informed consent approach. Total counseling, we take 2-3 sessions with it, with all the available commercially available. But in government practice, it's already decided. So I hope I've answered your question, Arun.
Yeah, absolutely. Yeah. As you know, here in the UK, most of them are done in the NHS, and in the whole of Scotland, there is only one unit, so they do all the implants, no matter where they live. And they use almost all sorts of implants. They don't stick to one company's implant, but
no. But how do they decide? Because it's on the NHS. How do they decide?
I think they discuss. I think they show the implants and the attachments and everything to the parents, and then they make a joint decision. That's what we do. But I do only mainly middle ear implants and whole ankle hearing aids.
Okay.
So even for that, there is a process of discussing with these days. Patients are given a lot of autonomy.
Right.
Hello.
Yeah, Satish, go ahead.
So now what I have done, see this, no retractors. My simple threads.
Stay sutures.
Keep my field, good. Without
You're using what, 30 Mersilk or something like
that? Yes.
Yeah. Very
So
good.
no retractors at all.
Very nice.
See now, my first access to the cochlea now we are talking about. So we have to go through the mastoid.
Yeah.
Obviously.
Yes.
We are not supposed to do a classical mastoidectomy. Mastoidectomy is not our goal. We are drilling the mastoid as an access to reach out cochlea. I'm doing just a crude mastoidectomy cortical. A crude cortical mastoidectomy. This is my canal wall.
You're thinning the posterior canal wall.
That is my canal wall, which is my focus.
Yeah.
And if I go down, you can see the lateral canal. Can you see?
Yeah, very
Hope the
clearly.
picture is good there.
Yeah. And
You
and
see
the
that?
and the good thing with children, don't you agree, Satish, is that it's so well pneumatized in a 2-year-old or a 3-year-old, and you get to straight down to the antrum, master antrum straight away.
See this, I am just thinning out my canal wall.
Yes.
So it doesn't come my way in deeper, visualization.
Yeah.
Just thinning it, thinning it, thinning it. That's
Mm.
it. Now see, the first thing to be seen for your orientation is the lateral canal. The second thing I intend to see here is the incus. I've seen the glimpse of it and will show you better the short process of the incus.
Yes.
That is a great landmark for my facial nerve.
Yeah.
Greatest landmark for the facial nerve is incus. Never beats. See this incus, short process?
Very clear. Very clear.
The facial nerve, you see the glimpse of facial nerve deep to it. The horizontal canal.
Yeah.
The facial nerve is always medial to the incus.
Children.
So now, as I said, we have to go by the posterior tympanotomy.
Do you want to increase the magnification a little?
I will just deepen the canal laterally.
And then
Flush it. See this laterally, I am very safe. And now I will go parallel to the incus down.
Yeah.
Yeah.
So
So the
we-
fossa
Facial
incudis,
recess is a cell. See now, I am parallel to the incus. Let me increase the magnification one step.
Yes.
If it is better.
Very good.
I hope it is better.
Very good. And we can see the
Can you see the
sentinel
incus
cell.
clearly?
Incus,
And see
Yeah.
this cell parallel to the incus.
the sentinel
the
cell.
Herald cells.
Yeah,
Herald
this
or
is the
sentinel.
access to the this thing, facial recess.
Recess.
My facial nerve is always medial to the plane of the incus. See
And
this.
fossa incudis will point the center point of the superior edge of the fossa, the facial
Fossa
recess.
incudis is a little bit bone which we are going to leave to protect unnecessarily the incus movement. See now. See now. This is my level of the cell. Can you see?
Very clear. Very clear.
And this is the change of color they see behind.
Correct.
So can you just discuss the role of incus pointer here, how it helps to identify the facial nerve?
See now, very
Like,
clear.
yeah.
This is my facial now. Here it is, the change of color behind. Can you see?
Yep.
This is facial now.
So this
Facial
is exactly
canal.
in line. Yeah, exactly in line with the line of the short process of the incus.
See this. Again, give me a pointer. 3 landmarks to be seen here, what I am trying to show you. The level of the fossa incudis, the incus.
Yeah.
The facial nerve is medial to it. See this?
Correct. Correct. So
This is level of the lateral canal. The facial nerve is anteromedial to it. See it immediately.
very clear.
This is the prominence, highest prominence, lateral prominence, and it is immediately medial to it.
Yeah.
And see this cell itself is a guide
Correct.
leading to the retrotympanum. Now, as I mentioned, this is we have to open this space medial to the annulus. So
What size diamond burr have you taken now? Yeah.
diamond I have taken, but I want a
3.
cutting at this time still. It's
Hmm.
6 I chose. So I am
this looks
as
like
I am
No, I
going
was happy
deeper,
with the diamond.
as I am going deeper, I will keep reducing the size of the burr.
Yeah. So I was going to say, give us a chance to speak, Satish. So this is the fossa incudis. So
Yes.
the depth of the fossa incudis, this is the fossa. The depth of the fossa incudis, that is between the short process of the incus
Yeah.
and the lateral canal here, the ampulla of the lateral canal will be there. So this depth continues down as the facial recess. That is
Yes.
a superb way of identifying the facial recess. So
Yes.
everything else that Satish said is true. We leave a short incus buttress. So don't
Yes.
drill away the incus buttress, incus bridge.
You can see like this. See the fossa incudis and the facial nerve.
Very nice.
Now, I mentioned about entry into this space through the staying medial to the canal, medial to the extraordinary canal. How do you find medial to the extraordinary canal or medial to the annulus? By identifying the
Chorda.
Chorda.
chorda. Chorda is the nerve which we need to keep in mind and stay medial to it so that you don't accidentally violate the field with the extraordinary canal.
And we feel betadine in the external auditory canal if at all.
Now we have a guide.
discover.
See, now we have to stay lateral to the facial. Now we have a amazing guide.
Yeah,
And see, that is the chorda.
that is the chorda. So what Chanel was saying is what at least some textbooks describe as the dreaded betadine sign. Nothing to be dreaded about, but we fill the external auditory canal with betadine, and if by chance you have reached the annulus and you've damaged the annulus or even the posterior bony canal of the EAC, you would have betadine dripping in. So you just have to be extra careful there.
So in case you damage the annulus, suppose,
Yeah,
what you do generally, we keep povidone iodine in the canal.
correct.
At this time, I have some povidone iodine in the canal. So moment you breach the canal, you will find the povidone iodine coming.
Yes.
The betadine test. In case you develop this, you just keep elevating the posterior canal flap. This is the canal flap. See this?
Yeah,
Elevate the canal flap and place the graft medially. That's it.
correct.
To segregate again.
Yeah.
That's it. Immediately.
But as of now, it looks a very favorable situation.
Yes.
A nice tooth here.
Yes, yes. No, it's छोटा दे दो.
Chorda there.
See my level of the
Even
facial
that,
now,
don't have
and
to-
I have kept a thin bone over it.
The chorda. I don't know.
See this?
Vertical.
I have kept a thin bone over the facial now. This is facial now.
Yeah.
And see the cell. Now I will enter into this cell. This is my level of the chorda tympani there. See this. Now I will open up this cell better. And see what I intend to see as a first structure. My
The
first
eyes, right?
structure, I intend to see the tendon of
Stapedius.
stapedius. This is my upper limit to be visualized. The moment I see the tendon, I would never go above this level in the regular cochlear implant scenario. This is my upper limit. See this, my upper limit is always in view now. Can you see?
Very clear.
The moment you see the tendon, stop yourself from going up above that level.
Yeah.
This is very, very important. And now I am widening my tympanotomy below.
Correct. So the landmarks start showing up. IS joint, head of stapes, stapedius tendon, and then the
See the IS joint.
yeah.
See the IS joint from here.
Very clear.
Now this tendon is my upper limit. This is very important. My round window would always be below the level of the tendon.
Yeah.
See the tendon and where it is emerging from.
From the pyramid. So that's
That's
the
the
apex
pyramid.
of the pyramid. And your
And
posterior.
now see, just below, inferior to the tendon, can you see the ridge of bone?
Can
Yeah,
you
we
go
can already
one
see that.
magnification higher, Satish?
Yes, I am coming.
Yeah,
See now. See below the tendon what is there. See the ridge of bone.
Yeah. Can see the round window niche.
Yes, round window niche. And the round window, if you see, it is visible if I see from below. Can you see?
Yeah.
So that is the round window. See, so for first of all, look at the tendon and stay below. That's a very important thing. I will open it more and more inferiorly until you go close to the nerves.
So as
And
we go
my
closer to the
thin
nerve,
shell of bone is intact over the nerve. See, the thin shell of bone is intact.
And as we will go closer to the nerve, more oozing will be seen. So we can be careful there.
Yeah. Still outside the canal. See this.
Yes.
2/3 of the upper column exposed. So upper column drill करोगे तो
See, if you carefully follow the landmarks, you will realize how big this space is accordingly. This facial recess. See how big the space is. See this?
So what is the size of the burr that we are using right
Still
now?
it is 2 millimeters.
two
So
diamond.
that much of space is there.
Yes.
So can I ask a question, sir?
Please.
So very recently, I had a case of Chad syndrome for a baby, and the facial nerve was very anomalous. I couldn't find any space. Can you just tell us how to proceed in such scenarios where the nerve
Yeah.
anatomy is
First of
complete?
all, go through the radiology thoroughly.
Sir.
That's what we discuss in CT scan, to know the anatomy beforehand rather than getting surprises. Now
I
see.
understood that the space was very less, but
Yeah.
when we entered, I was not able to pass any birth through also to
Yeah.
access
So what
the.
happens in case? See, it is not the space which is less. The round window visibility may not be good through that space, and then you have to tell because of the curvature of the extraordinary canal. Sometimes it doesn't allow. In that scenario, what you can do, as I mentioned, suppose I have a very narrow space and a very difficult complex anatomy stage. What I will do, I will elevate my this flap without puncturing it, tympanometal flap. Make two cuts on the canal, one here, and transpose the canal anteriorly. Mobilize it, and you have ample of space then behind that. You do whatever you want to and refix the canal back and flap back. That will take care of your all problems with the narrow space.
Canal transposition.
Nice.
Now see, I am drilling a little bit of the pyramid to show you some good access. See what I am doing? I am thinning the anterior thinning of the facial canal. See my facial canal. See here where I am running my burr, anterior thinning of the facial canal.
And something anterior to the pyramid would have been the caudal crest that you just drilled out before, if I am right.
Yes. Yes. So that was lateral to it.
Yes.
Caudal eminence is a better terminology rather than the crest. It's the place where it's a part of the styloid complex bone where the cauda tympani emerge from this into the middle ear.
Right.
Now see what I was showing. This is my, see this niche, round window niche.
Yeah.
So now it can be confused with a cell below, no? That's a hypotympanic cell.
Yes. So I am just drilling a little bit of a niche to uncover the round window. Can you see the round window better?
Yes. So it has to be within 2 millimeters in relation
and see
to
my
the
burr, what I
stapes.
am using is a tapering shaft. Tapering shaft so it doesn't hit the facial nerve in the way. It maintains the visualization because of the tapering shaft. See that? And see the full view of the round window now. This is the round window niche we observed during CT scan, if you remember. Can you see?
Yes.
A full-blown picture of the round window.
Yeah.
Very nice.
So
I hope it is visible.
Satish, can you just stop there and give me a minute? I'll explain the anatomy here for the audience here in the
Yes,
hall.
please.
Can you go one magnification higher? Just go
Higher.
one magnification higher.
Yes.
Just to show that. Yeah, beautiful. And keep it stable so that I can. We lost the picture here. We lost the picture. Dinesh. can still be there. That's why we don't take PTA, we are left hand. Not big crime, but the aperture is still fully gone. Yes, so on paper, तो फिर हमने चांस दिया और हमको टेबल कुछ अब भी जाके मैं भी बोला 3 ही लगा
Scheme निकली boss.
Satish, I got the picture. Just give me a minute.
Yes.
If you can just focus on the stapedius there, I'll just talk to delegates here. अरे क्या हो रहा है यार? The moment I start speaking, it goes off. So, yeah. So,
better?
Yeah. अरे बार जा रहा है यार. I don't know.
Maybe you should start talking, sir, and then it'll stay.
Can I keep talking?
Yeah.
I don't know. We need a picture there, right? So I was trying to say how beautiful the middle ear anatomy through the posterior tympanotomy is. And we have a lot of landmarks there that I would just quickly like to take you through. But
We have a mental picture in mind. Maybe you can continue talking.
can I? Oh,
Yeah.
the Shri Rao and Chanel Kothari and Hetal and Deepak here will obviously connect with me. I don't know about the others. We need a picture. But before that, I want to welcome Hetal Marfatia Patel here, who's a fabulous ENT surgeon and HOD of KEM ENT. She and I trained together. We were all Ashim Desai's contemporaries. We're celebrating Ashim's 60th birthday, Hetal, as you know. And Hetal's also done phenomenal work in the field of implantation otology, including cochlear implants and bone conduction implants, Bahas, Osseous. And Hetal is associated with the Salman Khan Foundation, kya naam hai iska? Being Human Foundation by Salman Khan, and raised a lot of funding for these children. And let's have a big round of applause for Hetal Mafatia. I will not talk till it stays. So I was going to say that is the incudostapedial joint. That is the stapedius.
I hope the focus is good where you want.
I want it on the stapedius or even the round window niche. So
see now?
Yeah. So
this is on the stapedius, I suppose.
Okay, that's good enough. Just stay there. Don't keep shaking. Stapedius, pyramid has the apex. Pyramid has the superior edge, the inferior edge, and the pyramid has a base. It is at the base of the pyramid that you have the vertical facial, from the second genu going down as the vertical facial. So your posterior limit of the posterior tympanotomy can go right up to the base of the pyramid. But then you don't have to do that. If by exposing the apex of the pyramid, you already see the subiculum, you already see the round window niche, you already see the operculum, that is the bony overhang over the round window niche, you don't have to go further back. Please don't go further back, because the risk of damaging the vertical facial is high, okay, in an untrained hand. And the moment you've seen roughly about half to 2/3 of the operculum, this is the bony overhang on the round window niche, you don't have to see any more. So if you drill the operculum, if you drill the operculum, antero-superior in that round window niche is the normal round window membrane. In this area is the round window membrane. Roughly corresponds to just below the apex of the pyramid in most non-rotated cochlears. The round window niche has the operculum, the anterior pillar, the posterior pillar, and inferiorly it opens up into the hypotympanum. What divides the round window niche and hence the posterior mesotympanum from the hypotympanum is the ponticulus. Ponticulus is what carries the Jacobson's nerve. So that's your limit. Beyond the ponticulus is the subcochlear canalicularis. Well, like Deepak was telling me earlier, the subcochlear canalicularis is sometimes mistaken by the novice as the round window niche itself, which is so wrong. See that? You can actually see that. Satish is just pointing that out.
This is subcochlear canalicularis.
Canalicularis.
Yes.
See that? So people have looked for the round window membrane there and then got into the carotid canal that Satish talked earlier. Now, the floor of the round window niche is called the fustis. Just below the anterior pillar is the fustis.
This is flat area. This flat area is fustis.
Absolutely. And the fustis leads to the round window membrane and hence into the scala tympani of the basal turn of the cochlea. Now we know this is the basal turn because that causes the promontory. The most prominent part of the basal turn is the promontory, which is anterior to the anterior pillar. So fustis, operculum, anterior pillar, posterior pillar, subcochlear canalicularis, funiculus, subiculum, IS joint,
What bad words you're using, Sunil?
Pyramid. Now, another very nice one, which you probably haven't heard. I don't know, Satish would know this very well, is the stapedius itself. It has three components: the stapedius tendon, the stapedius muscle within the pyramid, where we think it arises from, and there is a component of the stapedius in the vertical facial. So very often you saw Satish drilling the inferior edge. So if you go a little further back, you'll have a little bit of muscle bleed. Now that's not the facial nerve bleeding. That's the muscle bleeding from that component of the stapedius within the vertical facial. The point to remember here is the moment you've seen the apex and a bit of the pyramid, don't go further back. That's your limit.
Yes.
Okay.
Super. Now see the anatomy, what I said in the beginning.
Yeah, the jugular.
Just keep an eye on the tendon. Ashish, remember?
Yeah.
And stay inferior to it. Our area of interest starts inferior to it.
Inferior, yeah.
So that limits your superior visualization, superior working. Now this is the round window. You can see very clear.
Yes, very nicely.
The niche I have already drilled off.
Yeah.
Now this is all basal turn of the cochlea. See this entire.
Yeah.
And round window is a backdoor entry to it. See this? Now the question is, in this cochlea, how and where the implant should ideally be placed
The
to
direction.
maximize the gain and minimize the damage. This is what we need to understand. And if you don't understand this and just open the round window and push the implant, it is not going to give the desirable effect, because otherwise it is going to hit the inner ear structure and ultimately go in the scala vestibuli. The implant should lie in the scala tympani, which is closest to the modulus. In the modulus are the nerve endings. In order to stimulate the nerve endings with minimal current, your implant should lie in the scala tympani, not in the scala vestibuli, which is farther from the modulus. So now, see, I will show a picture, draw a picture and show you what I am trying to say. See this. This is your cochlea, what you see. And this behind is the round window, you could see. Could you see? Hello?
Yeah, Satish, yeah.
Now this round window is the back door of the scala tympani. This scala tympani is running in this, like this. The cochlear coil. The entire cochlear coil is running in this 2.5 turns, 2 and 3/4 turns, whatever.
Yeah.
Now, in the scala, in the medial wall of this round window, when you open, is this tunnel, and the medial wall of the tunnel directly there behind is the modulus. See this?
Yes, Satish.
Now the modulus is there, scala tympani is there. Now from this modulus, a bony lamella comes towards the outer wall of the cochlea. From this modulus, the bony lamella comes, this is scala tympani. From the modulus, this scala is divided into 3 portions. By what? This bony lamella arises from the modulus to run towards the outer wall of the promontory The wall of the promontory you just saw, the outer wall, towards the outer wall.
Yeah.
And ends just before the outer wall. It ends just before the outer wall. And where it ends just before the outer wall, see this ends just before the outer wall here. From here, the two membranes arise at the edge of the osseous spiral. This is osseous spiral lamella, arising from the modulus. One membrane going anteriorly, this is Reisner's membrane, to divide into upper compartment. This is lower compartment. And another membrane from here goes towards the lower compartment to enclose a small middle compartment that is closest to the outer wall of the promontory.
Yeah.
See this?
Yeah.
This is how the cochlear lumen is divided. And this osseous spiral lamella runs in the entire length of the cochlea like this. So in the entire length of the cochlea, the lower story is scala tympani, the upper story is scala vestibuli, and the middle one very, very close to the promontory outer wall, a very small, enclosed by membranes on both sides, is the scala media. Is that clear?
Yes, sir.
Beautiful.
And this is the modulus in the center. This is the modulus. This is the modulus in the center. From here, all spiral lamella run like this. All along, say this like this. So what happens now, if I make the diagram of this triangular area? This triangular area, this is the outer wall. This contains lot of outer hair cells in scala media and one inner hair cells. And above is the tectorial membrane. So now the current generated in the outer hair cells mobilize the tectorial membrane, and then this current mobilizes the inner hair cell, and that inner hair cell axon run through the osseous spiral lamella through this. That axon comes and end in the modulus. That is the body of the axon here in the outer wall of the modulus, in the lateral part of the modulus. So from 35,000 fibers all along the length of the cochlea, the fibers end in the lateral wall of the modulus like this. 35,000 fibers are arranged from different parts of the cochlea. From the basal tongue like this, the middle tongue vertically partially, and the apical tongue partially down this. So all fibers converge in the modular canal. See this? In the lateral part of the modular canal containing axons, and this canal in the modulus is known as spiral canal of Rosenthal's, where all the axons are placed. And from here the second body axons arise, and they again aggregate in the core of the modulus to form the cochlear nerve. So this is how from the scala media inner hair cell fiber travel to the osseous spiral lamella to enter in the modulus. So now the bottom line is, in order to stimulate this modulus, this outer axon hair cells, these cell bodies, your implant should lie in the lower story, that is scala tympani. This is closest to the modulus. This is divided from the upper story by the osseous spiral lamella. If your implant hits the osseous spiral lamella, this is so flimsy, so thin, it can fracture easily. Once the lamella fractures, the endolymph in the scala media mixes with the paralymph all around, and the hearing loss is, imminent. So in order to save the hearing, whatever residual, protect it, whatever residual, you have to stay all the way in the lower story without hitting the upper story. So now how can you do? Now what happens? This was round window, this is the inside of the cochlea. If you go through the round window like this, it may hit the modulus. Once it hits the modulus, your implant is going to curl. The curl implant is going to hit the upper story, that is the osseous spiral lamella, and once it is damaged, whenever you push the implant, will keep on curling and going into the scala vestibuli. Still it will stimulate, but that is not optimum. The optimum results you will get with the minimum current, without draining the battery maximum,
when the implant lies in the scala tympani. And it is why I'm showing this, so that it is the time for the surgeon to understand that you have to make sure that your implant lies in the scala tympani. It should not hit here and there on the walls while inserting. It is that time only you can have a control. It is that time if you ensure that your implant is going in the straight axis of the scala tympani for some distance, then it will thread itself into the lumen without hitting here and there. Now, if you push through the implant directly like this, it is going to hit and then curl. So what our philosophy is, well, I'm going to show you now. We have shown in dissections always. The direction of the cochlea is like this, antero-inferiorly. This turn of the cochlea. So what we will do, we are not going to put the implant like this. I am going to drill the lower window, the wall of this bone inferior to the round window. The moment I remove this bone inferior to the round window, I will have a straight axis into this tunnel like this. I will see the entire tunnel till it turns there at the level of the inferior part of the cochlea. Till then, if it goes in the lower story straight, it is going to loop inside on its own without hitting here and there. At the beginning, if it hits, it starts curling and damaging everything. So now, what I'm trying to show is, in implant, there should not be there's a useless discussion to go by tympanotomy or, through the round window or through the cochlear. We don't want to fall into all this. I want to make a straight tunnel. I want to make sure my implant goes straight in the tunnel of the scala tympani. So what I'm going to do now, see this. I am going to drill this bone inferior to the round window. See this. See this bone. Never go medial to the round window. I showed in the beginning, medial to the round window is the cochlear aqueduct. Inferior cochlear veins. Medial means in this direction, medial to it. We don't want to. We want to go inferior to it. I am not doing a separate cochleostomy. Separate cochleostomy take you into the canaliculus, cochlear canaliculus, what Dr. Sunil Dutt mentioned. So don't lose the landmark. Don't miss the landmark of the round window. See, I am just extending it inferiorly. Just extending to make sure that my tunnel is visible straight away.
Its floor itself is the prosthesis.
That's what.
Inferior to crystal.
Now give me over there. Wash with it, no? Wash there. See now what I have achieved. Now the rest of the round window I am removing. Can you see my tunnel? Let me push. See the long axis of this tunnel now. I just put some steroid to wash it off.
So what you've done is the extended round window approach, correct?
Yeah, extended inferiorly. Now see what we have achieved. See the lower story all the way. See this? All the way. See the tunnel? My upper story is left above there. And this is the lower story. And see all the tunnel all the way. Can you see the entire tunnel now?
Yeah, Satish, can be seen very well.
See inside. Now in the medial wall, this medial wall there, that is promontory, that is modulus. My implant will not hit the modulus. Here is the modulus. And see the inside of the tunnel and how it is turning anteriorly. I always show with a small scope, that is a endoscope. See the tunnel where the fluid is coming. See now?
Yeah.
So this is a straight tunnel now for a couple of millimeters. Directed inferiorly. See this?
Yeah.
And once I push my implant, it is going to follow the lumen without hitting here and there. So I can make sure my implant, while at the time of beginning of insertion, is not going to hit the modulus. Modulus is there medially. See that? And see the full lumen
all the way. See where my needle is going? Full lumen all the way. Can you see?
Yeah. Yes, seen very well, Satish. Yeah.
This is the most definite way of ensuring that your implant is not hitting the upper story. Now, where is the upper story? If I turn my microscope, had I been having endoscope, I would show here in the roof arching, that is osseous spiral lamella arching in the roof, there. And we are below that. See that? So, people who are recommending antero-inferior cochleostomy, they go right there and damage, the first structure they damage is osseous spiral lamella. Never ever try to attempt that. Go inferior to the round window, remove that wall to ensure that you get a straight tunnel. Now I have a straight tunnel and my implantation, pushing the implant will be a child's, work, child's play, nothing else. Just I have to push the implant in the lumen state without getting any resistance. See my lumen all the way. So I leave it here for a while.
Now this is what I call the sniper shot trajectory.
Yes.
Right, Satish?
Straight shot.
Yeah, straight shot.
Does it make a difference if you put hyaluronic acid or corticosteroid?
Steroid is the best, time tested. See, once you open the cochlea, you change the environment of the cochlea, the response of the hair cells to the new environment, and hearing loss is likely, and the only thing which can protect
is
the
steroid. Yeah. So well said.
There is no harm in doing.
Chanel, the way we all look at it is we used to use Hyalase in the past, where profound losses didn't really, there was no hearing preservation surgery. We were able to put the electrode with the Hyalase in there. But right now, with hearing preservation surgeries, it is best to use steroid as a lake, steroid as a pond, then insert the electrode in the steroid.
So now, the recipient cochlea is ready to take the implant. I have to make some.
You've taken some tissue to seal the cochleostomy, Satish?
Pardon?
You took some muscle or periosteum or...
yeah, I will.
To seal the cochleostomy.
Yeah. Now, this is my template, from the medal. See this?
Yeah.
Let me reduce. Yeah. Oh, tracker. Are you there? Now see, this is my template.
Yeah.
And see my markings. Can you see the markings?
Yeah, that you had drilled and marked before. Correct.
Periosteum. And see the periosteum. See the periosteum. See this?
Yes.
See this? My implant is going to come underneath this periosteum. See like this. This is the edge which I am going to keep over it. Okay, fine. This is how I am going to place my implant.
So,
and drill the well.
ये उल्टा हो गया. So the exit is
Yeah.
That
So
way.
my well is going to be like this.
Like this. Yeah.
And this is where the cable is going to come into the mastoid.
Yes.
So roughly this size well I am going to make.
Yeah. And if you see the edge of his cortical and the edge of this receiver stimulator package is quite a distance, about 1.5 centimeters. So 1.5 to 2 maybe.
Yes. That's it. Now I am going to make my well and make sure my implant doesn't project above the bone dust lower. Now at this point, I will collect first some bone dust.
I will tell you the use of the bone dust at the end of the surgery to further prevent mobilization of the implant post-operatively. If your implant gets mobilized, electrode array gets mobilized, it's a disaster. So I will take some bone dust. I will never take bone dust from the cortical area here because it may get infected sometime because of the previous otitis media. So I will harvest some bone dust in the same region where we halka. Oh, see this bone dust I have collected.
So by the way, the next CGCon is in Agra. Satish, you're aware of that. And Rajiv Pachori is the organizing chairperson.
Yeah. How do I know?
This is just the rehearsal going on here.
Pardon. इधर लगा. Now see my site of the he is a young child, so we don't expect a very thick cortex.
And there'll be a lot of diploic space and bleed from that.
Yeah.
You can, straight away see the dura there. Yeah. 2.5.
Ashish sleeping?
No, watching the master. We're just talking about ossia and bone bridge. Hital is here. So Hital, Ashim and Hital are
Welcome,
having
Ethel.
Yeah.
Hi सतीश.
बहुत तारीफ कर दी तुम्हारी सुनील सर ने.
अरे तू इतना ऑपरेटर है कौन क्या सीख सकता है? नहीं बराबर की कि नहीं की?
So, Sunil, I'm going to sign out now as I have some other things to do. So, it's been very nice, excellent surgery, Satish. So, enjoy the rest of the day, and I'll see you all guys when I possibly visit India.
Thank you, Arun, and happy birthday once again from all of us here.
Thank you. Bye.
All right. Bye-bye.
So this is 10-15 minutes mechanical exercise to make this snugly fitting well into the skull. Snugly fitting means it should not be too big so implant gets mobilized. It should be deep enough to ensure that implant doesn't project above the surface. Snugly fitting.
And the device should not rock inside this what you've created. The device should not rock into this trough. It should be like fitting.
Earlier, medal used to have a lateral exit. I think the template that you, Satish sir, used showed the marking as a lateral exit, but now I think all of their exits are midline. And fantail is probably the most delicate area where all the microfractures happen. So we don't do a well, we just do an anterior ledge, but we make sure we have a deep enough area trough for the fantail and a tight subperiosteal pocket. And as for Tarif for Hetal ma'am, I think it's not enough.
You can use the periosteum pocket also without making this well. But what I believe, you're right, you can give the same results. But what I believe, the fixation of the implant is something I would never like to take a chance. If your implant gets mobilized, it's a disaster, and you can something which is something surely you can prevent. And I believe the strongest fixation
we do can be done with like the fixation sutures by after making the well. Why to take a chance? This is something traditionally we have been doing and don't want to take a chance. Otherwise, other methods also are not bad, I would say.
Absolutely, sir. I think it's what helps the surgeon sleep better at night. So earlier in Maulana Azad, we used to do tie down. Then with Manoj sir and Monish sir, they stopped doing. And then in the West, they don't do the tie down and they don't even do a well. They don't even do the anterior ledge. They just do a subperiosteal pocket. So when you see volumes and you see confidence, then I think you start to change your practice if you like it. And if you don't, then you continue with what makes you sleep better.
Yeah, Shima, we all did the tie down before, but then if you write down to Dura like Satish is showing here, and it's the well is nicely done, I don't think we need the tie down. But if you're not sure, it's better safe than sorry. So at least antero superior tie down, and through muscle stitch posteriorly. I think the reason for that is it's in the first 2 to 3 weeks that the capsule is being formed around the RS package, and that is the time something needs to be in place for that. After that, it's irrelevant. So,
template.
Ashima, but this literally becomes a well done cochlear implant, no?
well
Well
done.
done.
It's fixed
Yeah.
really well. And Shenal ma'am was talking about that 45 degrees. That is a brilliant hack actually, because that's the flattest part. So, it's very easy to get the implant in without rocking, and you will almost always ensure symmetry. On Venta, Manoj sir had shared, how you stay between both sutures, and that's one of the most consistent ways to put symmetrical implants. And he always makes you think that you always have to do bilaterals only. So he will never let you do quadri. He will always make sure that you're really fast. Although Sunil sir had said, we should not worry about time, but he's always making us think that you have to do bilaterals. So you should always be under 4 hours if it's a really small child. So
बता
I
कैसा है?
think those are
नहीं
some
यार
of
ये
the
बड़ा है,
principles
उसमें साइज में फर्क है।
good when you're looking at it.
हाँ, साइज में फर्क है उसमें तो।
So while
बड़ा
the
है,
well is done, can I just want to
बड़ा है यार वो।
talk something about Bhumkar sir. Am I allowed to?
No, not at all. We've
I'm not asking you. So I just want to give
क्या
2
लग रहा है?
lines, sir.
Yeah, please go ahead.
Bolo, bolo.
Yeah, it was only your exceptional guidance and support that made me professionally survive, and I have been able to stand here today. It's incredible to be taught by someone who sees competence and talent regardless of the gender. When in this field, also like others, there are subtle biases. But you have appreciated and recognized skills, authority, and dedication of female
Canal
doctors.
Kothari. Okay. Oh,
Yeah,
we didn't know
and
this story.
yeah, and this is created safe and empowering environment for all of us as female doctors. Thank you, sir.
Oh, very nice. Good round of applause for Ashish for
There are
mentoring.
no gender. There are only people and persons here in professions.
So this was the well. I have, I can press it down.
We usually leave a small island of bone, Bill's Island in the middle.
There's a thin bone everywhere. See this?
There is. There is.
There is.
Huh?
So I can compress it a little bit to the extent that my implant doesn't project over the surface.
Yeah.
See, the implant projecting over the surface can invite infection by eroding the skin. And that's a disaster.
Well done, durable cochlear implant.
Now, I will fix with the tie-down holes. So what I will do, another 2 minutes, and Ashish, in next 10 minutes, we'll be through with this patient.
Yes, it is 240, just to let you know.
And before we start the next one,
so do you want to do the inverted papilloma or the polyposis? What do you want to do next?
Papilloma first.
I think better to do papilloma.
See this. And what I would like to do in next 10 minutes in changeover, to throw some light on the kind of pinna work you do.
quickly.
नहीं, छोड़ो अभी, no time. Okay,
10
everybody
minutes.
knows. Everybody
10
knows.
minutes.
It's okay, यार. It's okay, Satish. जाने दो, आप करो अभी. Because you have to go
See
by
now.
what time?
See
We'll
now
organize another birthday workshop for Ashish.
You are celebrating his birthday. I'm celebrating his beginning of the old age.
There are many who will think otherwise, my friend.
See now?
He's the youngest of the three, so he can.
Yes.
For a few more years. Satish, how far are you from your 60?
5 years.
5 years? Yeah. Yes.
Yes.
Thank you.
Which dye do you use?
No hairs.
Which dye?
Never say die.
See, these are the tie down holes. There are various ways to make these holes also, but this we found to be the simplest one. See this, taking the help of the periosteum elevator, we can make holes quickly and now udal. And now before knife. Here at this time I will take some periosteum. The fresh periosteum I am going to harvest now. A little bit to seal our cochlear opening. This one. Is the periosteum or is the tracker? Which one? This is the periosteum I want. This periosteum I will use to seal my see right from the bone, tethered on the bone. This has a best tensile strength as compared to other tissues. इसको शेप वो हटाना फालतू का ऊपर का. Now is the time, monopolar देना, is to ensure that hemostasis. I'll make sure if there is any bleeding or something we can tackle now. Absolutely dry. No bleeding. So wash. Give me a wash to take away all bone dust and everything. Cochlear area we have already protected with the gel foam. So we have harvested harvested periosteum, we have harvested bone dust. We have opened the cochlear tunnel. Now fixing the implant and push the electrode. That's it.
Which implant, Satish? Concerto 2 or Synchrony 2?
Implant निकालना boss.
कौन सा implant है?
वो डिब्बा दिखाना इसका यार. इसको लगाओ ना यार, 5 बार खुल चुका है.
Rajiv Pachori there?
Yes. कौन सा है? Concerto 2.
Concerto 2. Yeah.
रिट्रैक्ट करो. वॉश लो, वॉश. अरे रिट्रैक्ट कर यार, बहुत बड़ा काम थोड़ी
Picture
बोल
is
दिया.
flicking Dinesh and team. The picture's
वॉश दे.
flickering too much.
वॉश तो भर.
Stroboscopy हो रही है इधर.
ज्यादा मत की, ज्यादा मत.
Yeah, but
See my area now.
Yeah.
I hope the picture is good.
Very good.
Flickering.
Now,
this
now
bo-
it stopped. It stopped.
all this bone store, bone dust, everything, I am washing it off. ज़्यादा मत खींच रहे भाई, दुष्ट मत बन, नीचे रख, छोड़। हाँ, बस।
And what's the electrode also, Satish? Flex 28.
Electrode medium.
Medium. Standard medium.
Yeah.
Okay. So that's about 26 millimeters, I think.
Yeah. It should not be beyond that. We don't want
anything beyond.
electrode bigger than 24 millimeter.
24 to 26. Yeah.
See, beyond 24, the cochlear lumen is very narrow. This is going to give more damage than benefit.
Yeah.
Moreover, the axons from the apical turn, they are projected down. Their cell bodies project down towards the middle turn. So when you thread your electrode in the middle turn, it stimulates the cell bodies of the apical turn as well. So you don't need to go beyond 450 degree in any given situation. That is giving more damage than benefit. So our philosophy is to insert electrode up to 24 millimeter till 450 degree. Beyond that, automatically the apical cell bodies are stimulated by the electrode in the middle turn because their cell bodies project down.
Yeah.
So there is no point in threading the entire cochlea. Now, see this, I will pass my thread to fix. Ajare. हो गया, बस निकाल, रुक जा, निडल दे, निडल दे, निडल दे। अरे हट यार, तो कहाँ गया? कहाँ आ गया था मैं यहाँ पे, तो क्यों मजाक कर रहा?
You need the fish hook.
So we are just fixing the implant first.
Yeah.
And then we'll put last 5-7 minutes. So now placement of the implant is a child's game. Child's play, because we have a straight tunnel. You have to push the implant there and close the opening. That's it. So fixing the implant is just a child's play. The important thing was to make the straight tunnel. This all is what being done is mechanical work to fix the implant. Earlier, we did couple of implants which didn't require any drilling, very slim. You just screw them on the head. And we did couple of, but didn't get the desirable results. And that implant architecture was such in a way that fixing the screws on the one side would keep elevated the implant on the other side.
Seesaw.
And that would invite infection. So many of such implants would get infected. I think it is not available now, as far as I know. Gone? Finished now? So we'll just use this figure of 8 stitch to fix the implant.
Is Nitika online?
This is Proline.
Yes, sir.
Yeah, hi. Sorry, you're still in the implant. I don't know whether you do implants.
Husband does.
Husband does? Okay.
गलत डालिए.
With Satish, nobody has the control of his time. No, not even himself. Yeah.
Nitika from Jammu.
Implant खोल देना, implant खोलो.
Yeah.
Rohan's wife.
Yeah.
Yeah. Hi, Nitika. Dr. Sunil Dutt here.
Hi, sir. Good afternoon, rather.
Good
So she
afternoon.
does a lot of allergy work. So I thought nasal polyposis, she and Ashima. Ashima also, I think, is setting up a allergy.
Implant. Can somebody open the implant? Implant. See now, I have opened the implant and now intend to fix it. Uthana, periosteum. This is going to go like this underneath the periosteum. See this? Absolutely snugly fitting.
Yeah.
See the edge of the implant and the edge of the window, bony window. Be fitting. Now fix. Suture mano. See, this is the strongest fixation what we can think of.
What suture material you
This
use
is
for
proline.
Looks like a 3-0.
And proline can be dangerous sometime if it comes in contact with the skin. So you have to invert it. We'll show you.
Yeah, that's the thing. So we used to use Proline, Satish, in the past, but that pokey thing after 2 or 3 knots can cause trouble. So I use Ethibond these days.
Yeah.
I use 2030 Ethibond.
So what I'm going to show you now,
Yeah.
this proline should not evert and enter into the skin.
Correct.
That's a disaster. That will invite infection.
Yeah.
And that's a big problem then.
So he will
See,
bury it in that hole.
see the kind of fixation now.
Mm.
Now, now see, this
you push
this
it in.
knot, I will push in the
tie down hole.
Yes.
Yeah, very clever. Oh, with the surgery
I will invert it and fix with the surgical.
Surgical.
That's it.
Good one.
This will fibrose.
Mhm.
Now this will not allow this to come out. See this?
Yeah.
Lovely.
Yeah.
Good Raksha Bandhan for the.
See now, all set for the implantation.
Yes, sir.
The simplest part is coming now, that is implant. Insertion. कोई पतला दे section. पतला section.
And do it at a slightly higher magnification.
Just a minute, sir.
Mm.
We'll see. Yeah.
Yeah. Perfect.
Better?
Yeah.
And see my tunnel.
Yes.
Wash. Straight tunnel. On that. See the straight tunnel.
Yeah, very clear.
And this is inferior tunnel in the inferior compartment. Now what I have to do is just insert straight shot. See this implant?
Yeah.
Going straight.
But the direction should be more
See
inferior.
the direction going inferiorly
Yeah.
and straight.
It is going in the lumen. There is no resistance at all. Not hitting on any wall because straight it is in the lumen.
Slithering in.
It cannot go anywhere else but into the lumen. See this? Without any resistance. Then us. Action there. Pick there.
Okay.
See my implant?
Yes, Satish.
Implant has already gone in. See my electrode array well within the cochlea. See this? Can you see very clear?
Yes, Satish, very nicely.
See this? Straight short insertion. Straight short without doing anything. So this is not going to go anywhere. This is the implant. No resistance, nothing, just go straight and insert it. Because you are following the tunnel straight rather than hitting here and there. It simplifies. Now I'll go all around this implant with this and snugly fit this periosteum at the bony margins. Snugly fit all around this and snugly fit at the bony margins. Simple. See this?
Yeah.
Who have food? You said wait for fun. When is your flight back? Mine's at 8:30.
This is snugly fitting. See this? No question of leaking any fluid. The cable is going through the middle of this all around and just pressing on this soft tissue with the gel foam. Gel foam absorbs water more than its weight and gives a good pressure for some time to the periosteum. That's it. See this? Now, this cable is going to expand into the mastoid later on.
Yeah.
So my cable is tucked underneath here.
Middle, na? ART is
Other end into the mastoid.
this is ART.
See this?
And, advanced
So
one.
this is not going to get displaced. Now what I'm trying to do is
Because they have to label it.
this implant. This is important.
आप आ सकते हैं लंच को 3:30 तक है
हाँ 5 मिनट रुकने को बोला
See, the distance between, see the very important point. The distance between the round window and the edge of the cochleostomy, this posterior tympanotomy, doesn't change because it's a part of the middle ear and middle ear size doesn't change after the birth. Now this cable is going to expand because of the expansion of the mastoid. Outside we have fixed the implant from where this cable is rising. Inside I am going to fix this implant, this cable at this phase here because the inside is not changing at all. So here I am going to use my bone dust to make sure my implant cable is not pulled off. This bone dust I use strategically here only, here at this age. Because once it translates into a true bone, my cable is not going to be pulled from inside at all. Whatever outside expansion happens doesn't make any difference. My inside cable is never going to mobilize. It translates into pure bone. What I want, the fixation of this cable at this posterior tympanotomy site, beyond which the middle ear is never going to expand. So my cable doesn't need to be mobilized. See this? Rest of the cable is free to expand. The rest of the cable is free to expand. I hope it is clear. Hello?
Yes, sir.
Hello?
Yeah. Beautiful.
Yeah, Satish. Sorry, the mic went off, not we.
So, wo there? लेना है वो? So we'll just take the impedance now. Impedance ही होगा इसमें. So I'll connect this with the cable to the software. So the surgical part, you have to insert this implant into the right scala tympani. That's our goal. In the straight tunnel. Fixing in such a way it doesn't get exposed because of the incisions. It is going to be well covered underneath the flap. Now I have connected. So we'll take the impedance. All good. Very nice. Can somebody show with the external camera? Okay, further take the NRT. So the impedance is good. Impedance is very important to know your electrodes are functioning. It is the test to assess the integrity of the electrodes. That is important. That's why you should have a standby implant always in hand in case your implant is not functioning. So impedance is a great measure of integrity of electrode functions. And then NRT to stimulate. If your implant is close to the scala, promontory in the scala tympani, you will get the stimulation at the lowest current. Initially, when the physiology of the cochlea is changed, sometimes some air bubble, some bone dust, some, blood clot, whatever, it may not give the desired, stimulation. But if your implant is right in the cochlea, this is going to come after a couple of days. So, coming. पहले इम्पीडेंस दिखाओ तो कॉइल टूट गई और कॉइल निकल गया वापस करो वापस नहीं वो इम्पीडेंस लो पहले तो yes, so impedance is good, all electrodes good. Optimize कर लो optimize किया
He had to wake up so early. Yeah.
hello
Yeah.
yes
Yeah.
any comments, any
Yes.
question, anything we can take always.
Yeah. Okay.
Sir, I
It
had a
is-
question, sir.
yes please.
So how we had a case of IP3 deformity. So you were closing the entire round window opening with a seal. Can we go ahead in the same manner for IP3 cases also, sir?
In IP3, I would always optimize. I would always optimize. In IP3, I would always do a subtotal petrojectomy and then implantation. In IP3 is almost always a gusher. In order to control a gusher and prevent further infections, you need to have a strategy to prevent that. And in that scenario, we need to do a subtotal petrojectomy, the best answer, what you believe, to prevent all infection sources, block all infection sources coming to the temporal bone. What's my
What
point?
if the perilymph, like how you did, sir, right now, you seal the round window and once again you place the bone bed. And in case if we put a surgical glue or fibrin glue, everything is stopped. After that, it heals with fibrosis. Then
See, that's a
will there
gusher.
be any need, sir?
Yeah. So in IP3, it is not only the defect of the, giving rise to the gusher once you open the cochlea. Entire cochlea is deformed. That's an endosteal anomaly of the entire cochlea. So cochlea is never well formed. Secondly, once you have a gusher, you can't have a foolproof technology to prevent the CSF leak unless you obliterate the cavity. Obliteration of the cavity, prevents the chances of CSF coming out of it, wherever it cannot spread anywhere. So, and anyway, the middle ear and mastoid are not going to participate in the in the hearing. So that is the best strategy.
And which electrode array, sir? Lateral wall only, right?
Yes. Straight arrays, in all malformations, straight arrays.
Straight arrays.
Pardon? Yeah.
Sir, you are a very fast surgeon. But when we are like for treating all cases as hearing preservation, we always do very slow insertion. And the other thing is that probably when we insert very slowly, then even the ARTs come better.
Doesn't make any difference. See, if you are in the right tunnel, it's going to work. Why? See the threshold coming at a lower current. And this physiology will still, be better later on. So some of the electrode may show, some may not, but it will stabilize. Or implant is right in the planes. You have seen at the end, it was right in the cochlea. Though for any doubts, radiology is the final answer, not NRT. Radiology will tell you where the cochlea is, the implant is right in the cochlea. So it doesn't make it gives you initial sense of relief that your implant is stimulating the nerve endings. So the final picture of the stimulation you can get in next 48 hours, you can repeat it. But when we are sure, see the implant is stimulating cells. Partially it is coming, not coming, doesn't matter. It is going to come in next reading. So this is all about the implant. Any questions about anything?
No, perfect. Thank you, bro. Go to the inverted papilloma, please. We are running against time.
Oh,
great,
yes, sure.
great job. Yeah. Thank you, Satish. Thank you so much.
Thank you, boss.
Thank you.
Thank you.
So can I request Sunil,
Thank you, sir.
Narayan, and Vijendra sir, please come. The birthday boy has some token of affection and love for you.
Satish, it was a wonderful dissection. I enjoyed. Thank you very much.
Thank you, sir.
Yeah,
Your
Vijendra
presence is always encouraging.
Yeah, he has to leave at 3:30. He has a 5 o'clock flight.
किधर है papilloma?
Please, hello.
अच्छा ये प्राइमरी है papilloma? प्राइमरी
तेरे को किया नहीं ना तभी.
नहीं बस
फिर चल with the उनको book दिया है. Thank you so much, Vijendra. A very suitable gift. Thank you. Thank you. Yeah, that's okay. Your presence is the gift. अरे senior man. Sunil, thank you so much, man. Thank you so much. And Narayan. Can we now invite Hetal, Vandana, and our AOI office bearer, Pratibha, please come. Also some, Hetal, we've been missing you in the morning, but thank you for coming, yeah. She got caught with an implant program only. So it goes this way, seniority wise. Thank you, Hetal.
Same colleagues, same institution, they had a great time together.
Vandana, our very dear friend. And she's doing, besides ENT, she's doing incredible work on tobacco prevention. Very, very big, big movement she's set up. And Pratibha, our Thane AOI. Thank you, Pratibha, for everything. Thank you so much. Yeah. Thanks. Okay. One photo.
Just happy to mention that our PACE group Pune has done over 103 shows in this academic year in schools and colleges.
Yeah, they say don't smoke, don't eat. Yeah.
Hello.
Yeah.
I feel happy that was talking.
Thank you so much. I was looking at the book there.
So that book is a biography of Deshbandhu Gupta, who's the founder of Lupin Pharma. And we have some more copies. Yeah.
Each case.
Yeah.
Yes, to show.
ऐसे दिखने वाले हम लोग. इधर आओ. We go off.
Hello. Hello, Ashish.
Yeah, Satish.
Yeah. So, can I show you something on screen?
CT scan?
Yes. Oh, now I can see all the superstars.
Hey, Swati, I was trying to see you. Hello, call. और एक है क्या? I couldn't see you at all. Please come. No, Narayan. Please. We got one for you. Come on. No. अरे अमित तू मला सांगितलं तू निघून गेला. हॅलो द्या अमितला द्या आणि स्वातीला द्या प्लीज. They told me you left. Huh? Yeah. Narayan, please order your student to come here. Amit, please come. Sorry, I didn't know. They told me you left. Master? Yes. No, this is for your wife, okay? Not for you. Or your girlfriend, whoever you, it's up to you. Yeah. Thank you so much. और किधर है? Swati, come please. Now you are in the senior bracket. Sorry. I don't want to be, but yes. Can Ashim give or you would like to give? So Swati is the most sportiest ENT surgeon we know. इतना openly मैं line मारता हूँ उस पे and she takes it like, okay, no problem. करते रहो. Yeah. Thanks, Swati. She's been a colleague of Arvind Patil and he describes her as a very great surgeon. Arvind को देखा? Okay, he's gone. Yeah. So very good. Arvind? Yeah. All the good words you told about Swati, about her surgical skills. For a long time, they were collaborating and practicing together. Now she's on her own. Yeah, and she's been an Narayan student.
So I like to encourage my students. She's one of the students during the residency time. She gave the approach for pituitary. And she's done total thyroidectomy and various other surgeries all by herself with me just standing in the background.
मेरा phone कहाँ है?
And that is the only reason you are felicitated here, okay?
मेरा phone देखा था क्या?
Because he says such a good thing. Amol and Arvind are the silent movie types. त्यांना मी हातात mic देणार होतो, but maybe I should give them that mic now. Greatest of surgeons, the biggest fans and followers of Satish Jain. And everything that if Satish is not available on the phone, you have to call Amol or Arvind. Satish काय करणार आहे बाबतीत? From A to Z, they will tell you all the protocols. So great. and all our team here. Maruti, of course, very, very skilled. So very happy to be a part of that group. Sandeep is the emerging star. Absolutely, he is going to be the Satish Jain of South sometime soon, in 5 years.
I'm hoping
And Vivek is our
on the mental.
that you already mentioned. That you already mentioned. Big responsibility. Yeah.
Okay.
Yeah, for us also. Niranjan, master, where is he? Yes. Niranjan is leaving us, going to Canada. He's got a second wife in Canada. I mean, sorry, his wife has gone to Canada. Yeah, sorry. Sorry. So, so he's setting up. She's doing fabulous. She's an infertility specialist. Tasween, his college sweetheart, and she's doing very well.
Sanjeev, implant.
Yes, against Tasween's family wishes. So it was in Thane only that we got them a temple marriage. So great thing, and it's going great. अजून कोण राहिला धनराज विवेक तर सुपरस्टार हमारा सलमान खान as he calls, but great surgeon, doing fabulous work in Bhandup and the whole area actually, Thane and all. And Dhanraj, the super successful man, absolutely, I think now he's got a institute with all kinds of departments, all ENT departments in sub. He's like following the model, the Bangalore model of Haldipur in a different way, in a more generous way. I think so. Yeah, yeah. Okay, thank you, and thank you everybody for being here. We should get going with the inverted papilloma, and Satish is going to make draft seem simple. Thank you, Vijay.
Wow.
Okay, Satish, we are with you.
Yes, Ashish.
Yeah. And I think now for the last session, we have Bini.
Yes. So we have probably 1 hour's time.
Yeah. So we are a little more than 1 hour. Bini and Tanu. Tanu from Sholapur. Again, an emerging star. Tremendous cerebral knowledge and brilliant surgical skills. And Bini, of course, we know from Kochi Amrita. So Bini and Tanu, welcome. We are at inverted papilloma. This probably is going to be the
Hello.
last case. Yeah, hi.
I've been listening from the morning. Fantastic program, and birthday wishes to Ashim from my side. Yeah.
Thank you. Thank you.
Welcome
Sorry, I
all.
forgot to mention Srini here in the group. Sorry, Srini. Thank you. Thank you. He's doing also great work. Sorry.
Where is Srini sleeping?
Srini is here only, but he's the quiet types. So he's sitting there.
So this patient, are you getting some scan picture?
Yeah,
on the
we're
screen?
getting the scan picture. Yeah.
See, patient with a polypoidon kind of a picture inside the nose. Obviously we get a plain CT scan done first. And a plain CT scan, how old is this patient? How old is this? See this unilateral polypoidal thing in a elderly patient with this kind of a plain CT scan. This is plain CT scan, which is showing entire ballooning of the, middle meatus, and see the widening of the medial wall of the maxilla. Everything in continuity from the maxilla to the nasal cavity cannot be a simple polyp. This is something which makes you fishy that on a plain CT scan that it cannot be a simple polyp. Isn't that?
Yes.
See, simple polyp doesn't present like this. Now, what additional information we can have from the radiology is from MRI. MRI tells you a lot of information. Number one, see in the CT scan, it is all opacity. You cannot determine where the tumor is. See this? You cannot differentiate where the tumor is and where the secretion is. All is opacity. Can you see?
Yes.
Now look at the MRI on the other side. What it differentiates? This bright opacity is fluid. This in the maxillary sinus is fluid, And this maxillary sinus is, rest of the maxillary sinus is compressed by this mass lesion, which on CT scan looks like the same opacity. Because CT scan cannot give you soft tissue details. So in this picture, what you see is a well circumscribed lesion eroding the medial wall of the maxilla completely and bulging into the maxillary sinus. See, narrowing the sinus lumen, which is filled with this pent-up secretions, turning up as bright shadows on T2 weighted. So it differentiates the lesion, the tumor from the secretions very well. Beyond that, if you see the relationship with the closed structures, number one, the septum, it looks like it is also compressed. See, there is a thin line demarcation which is separating from the surroundings. So it doesn't look like invading anywhere. It looks
but
like
maybe slightly pushed
giving
to the other side.
compression. Compression. See, destructive lesion invades. The frank malignancy invades anything coming in contact with. And here it is ballooning, compressing, everywhere the margins are intact. See this, but not eroding anywhere. So it looks like some benign thing. Now the relationship with the orbit. See the orbital distinction. This orbital periosteum, this is the intraorbital muscles. All the muscles and periosteum is pretty intact, this black. Can you see very clear?
Yes, very clear.
It is not invading into the orbit. These are pent-up secretions, sinusitis in the ethmoids, adjoining ethmoids. See this sphenoid, see the frontal, all very clear. So it is the lesion in the nasal cavity. It is going behind right into the nasopharynx. See, maintaining all around the limits, maintaining all the way. See this? It is not eroding anywhere, but it has eroded the medial wall of the maxilla by means of compression. I think the picture is very clear.
Yes, Satish, yeah.
Now what it can be? There could be n number of pathologies which can give rise to such lesions, but we don't know what exactly it is. So to differentiate, we need to bring out certain more. See, beauty of the MRI is its versatility in terms of giving number of sequences, which differentiate the soft tissues differently. See, this is T1 weighted imaging. Now in T1, what you see in the orbit is bright is all fat. This is T2 weighted fat suppressed, the fat is suppressed. Now you see the fat is intact all over and see the distinct line of this lesion separating from the fat plane. Can you see very clear?
Yes.
Very clear.
This gives you a more insight about the orbital invasion, that it is truly not invading at all. You can see the surrounding fat and the periosteum separately from the lesion. I hope it is clear.
Yes, very clear.
See these secretions on T1 appearing little bright is because of the proteinaceous material. This is more a thicker material inside it. Now the tumor and the secretions you have seen. Now let's see on the contrast how it looks like. Now see on contrast. See the tumor is showing heterogeneous ecotexture. Heterogeneous, not very clear. It looks like somewhere attached here and giving some not a classical inverted papilloma architecture, but they're giving some heterogeneous architecture inside. I'm seeing it for the first time, and this heterogeneous architecture looks like attached here on the ethmoidal lamella somewhere. It could be inverted papilloma because of these laminations.
Attached to middle turbinate, is it? Or
Pardon?
attached to middle turbinate? Medial
The
attachment.
medial, it's more the lamella, middle turbinate, somewhere. But truly it is not invading the lateral wall of the maxilla, not invading the orbit, not going up anywhere, and it looks like very well separated from the septum as well. See this? See the distinction of the septum. Can you see all the way?
Yes, yes.
So it is not invading anywhere. So it looks like a cakewalk.
Yes.
Whatever it is, it can be easily excised. We may have to, looking at the situation of the medial wall of the maxilla, will take a call to go by Danker or not. So it's a straightforward cakewalk. The lesion obliterating the right nasal cavity, medial wall of the maxilla, heterogeneous architecture, not invading the septum, lateral wall, or the orbit or the skull base anywhere.
सतीश विवेक ने बोल दिया है तो 10 मिनट में खत्म करेगा अभी.
I can.
Does it show the classical features, inverted papilloma, that cerebriform pattern and all are not
Yeah,
seen?
sometimes doesn't show classical because of the necrosis starts, because of the, at the time of MRI, the patient doesn't move, so many things.
Yeah.
And the scan, how you scan the MRI.
But then how do you decide where to then drill the bone if it turns out to be inverted?
Yeah, we will see now intraoperatively where it is attached to.
Okay.
Sir,
See,
an
if it
intra-
is inverted papilloma, let me tell you the fact. If it is inverted papilloma, MRI, if you pick up very well on MRI, it is game changing. Because inverted papilloma has a tendency to convert to malignancy in certain percentage of patients, up to 10-15%. Now, if suppose this has turned into malignancy, had this been there, this would show central necrosis completely. On contrast, central necrosis, and that's a great sign that it has turned into malignancy, and you can take intraoperative frozen section specimen for frozen section to prove it. If it is malignant, you have to, still you can give oncologically sound resection by endoscopy itself. Now imagine in the final specimen you don't get a frozen, you don't have a suspicion, you don't have a suspicion of papilloma, and resected and turns out to be papilloma, which has converted to malignancy. Now you have to sit back and reassess that was it an oncologically sound procedure, because if maxillary wall is involved, you can remove negative, resection with the wall involvement. Histopathology negative resection is must in an oncologically sound procedure, whether it is piecemeal or en bloc, but the final margin should be negative. That is the story behind the good oncology sound resection. And if you have a previous suspicion on a malignancy, you can accordingly deal with it. To me, this is most favorable kind of a papilloma if it is. Now, what are the most difficult papillomas? See, these are benign tumors. Benign tumor, like any other benign tumor in the body, you resect completely, it's not going to come back. We call sometimes papilloma tend to recur. Practically it doesn't recur. Practically it was a lesion which was left behind during initial resection, which was overlooked, and it has regrown. So it is the residual which has regrown, and all these repeated resection residual tumors ultimately turn into malignant. So in order to resect it completely.
Sir, any role of radiotherapy?
Pardon?
Role of radiotherapy.
Radiotherapy is for
post-op.
Yes, if it is a proven malignancy, invading the bone, T4, invading critical structures, yes, it should be followed by any other squamous cell carcinoma of the head and neck, followed by radiation.
Sir, if it is there in frontal sinus in a little far lateral regions which we are not able to access, should we leave it and go for radiotherapy?
No. Malignancy cannot be. Squamous cell carcinoma cannot be treated.
अगर excision वो possible नहीं होना.
Malignancy in this situation. See, in those situations, you have to access that area of attachment, whether it is in the frontal sinus or anywhere. if you can, if you are well versed with the draft procedure and can access the site of attachment, it is the site of attachment which matters.
Yes.
So if you can access the site of attachment by the draft procedure, you can go endoscopic. If you cannot, you go by open approach, but the complete resection is must.
Yes, sir.
If you think of a cure. Now, that's why this is a favorable papilloma. The most difficult are which are located in the challenging locations, which are difficult to access, difficult to follow up in the post-operative period, and difficult to remove because of the critical structures in surroundings. And those are the frontal sinus, practically all those attached on the anterior wall or on the posterior table on the skull base are always challenging. Cribriform area challenging because sometimes, because in any given situation, you have to remove the underlying bone. If it is a cribriform plate, many a times we have removed the cribriform plate. You have to reconstruct the skull base thoroughly without taking any chance, rather than leaving the tumor behind, a minimal tumor behind and coming back. That's a disaster. That is never going to give cure, and it is going to go intracranial further. So the challenging areas are frontal sinus, skull base, and the sphenoid sinus. One of the cases we demonstrated in our webinar was involving the sphenoid sinus attached to the posterolateral wall, attached to the carotid canal, attached to the optic canal, and ultimately we had to drill those canals completely to leave the bare optic and carotid, optic nerve and carotid arteries absolutely free, but bare. Because the tumor removal was must, and drilling on that carotid and optic canal, you have to be little more conscious as not to damage these vital structures, but that is challenging.
Sir, it can invade the lacrimal sac also, no, sometimes?
Yeah, you can remove that. Yeah, that is all removable. The problem is the area is difficult to remove. Lacrimal sac is not a big problem.
Let's go to endoscopy.
So let's go to endoscopy now.
Yes, sir.
So let's see what exactly it is, though we don't have a frozen section here.
We were hoping for a draft demonstration.
किधर है? उधर? उस वाली में?
नहीं, इसमें नहीं ना। No, but that was when we were discussing, we were hoping to show the इसमें।
Yeah.
ये अभी कर रहा है।
और है क्या? कुछ बचा है और है क्या? Right. So Ashish.
Yeah, Satish.
Yeah, the case is being prepared. It may take 5-7 minutes.
Okay. So go ahead and describe. Yeah.
Meantime, we can discuss whatever you.
नहीं, go ahead with the scan जो भी बताना है.
So, yeah. So, can we take 4 or 5 questions of autosclerosis surgery?
Yeah, okay. You can if people have asked.
Yeah, we got online, and is Ashim in the auditorium?
Yeah.
So,
yes, brother, I'm right here.
Yes. Just a minute. Ashim. Question regarding incus dislocation.
Yes.
That's an online question. People are asking, you're operating and if accidentally get incus dislocated.
During Stapes surgery?
What would you do intraoperatively?
During Stapes surgery, during a fixed or any place?
Stapes surgery.
So during Stapes surgery, there are 2 situations. One is where the superstructure is intact. The second situation where the superstructure is already fractured. If you have a superstructure intact and your incus is partly subluxated, you can continue with, if it is subluxated, not dislocated, you can continue with the surgery with the caveat that you should use a vein interposition because you will need that much leeway for protection for the oval window. One. The second part is assuming that the superstructure is completely intact, but you unfortunately during curettage or something really dislocated the incus, then the ideal thing is to put it back in its anatomic position, put the silastic above and below it, wait for 6 months and go in again. And I would prefer to do that.
Same stage or later?
No, 6 months.
Oh.
No, because I don't like to do a malleus tapedotomy if I can help it. Of course, if I have removed the complete superstructure, I have then dislocated the incus, I would do a Malleus tapedotomy.
So in case suprastructures are already removed, you would go for Malleus tapedotomy.
Yeah, if the incus is totally dislocated. If it's subluxated, I'll still go ahead and do the incus tapedotomy.
Now it's a different physiology. The piston attached to the malleus.
Yeah.
And directly transmitting to the vestibule as compared to the incus to the vestibule assembly.
Correct.
Do you find any difference in the post-operative results or any?
Absolutely. 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 High frequencies don't pick up as much. It's very clear. I'll tell you why.
And in long run?
No, long run, nothing happens because remember one thing, that you are working from the neck of the malleus. You are not doing it from the handle of the malleus as proposed by Fish, because the handle of the malleus moves too much.
Has more movements.
Has too much movement, yeah.
See, the range of the movements of the malleus is much more than the range of the movements of the long process of the incus.
Correct.
Long process of the incus moves by a fraction of millimeter.
Yes.
The malleus can move by 1 to 2 millimeter.
Yes, and that also it moves excessively during static displacement, as in
attaching to the handle is now, I think it is everywhere. Nobody is doing.
Yeah, nobody is doing. But now I have another technique of mine which I learned from Robert Vincent, and that is the malleus relocation technique, in which I will detach the malleus completely from the tympanic membrane, cut the tensor, stretch the anterior mallear ligament so that the
bringing it behind.
Bringing the handle behind, and instead of using a hydroxyapatite, I use a Y-shaped cartilage strut. And what I do is I measure the cartilage strut before I perforate the foot plate.
How stable is that?
Fabulous. Priyank is working with me for 5 years. He's seen 5-year results are absolutely fabulous.
We have seen Robert a couple of times. And for ossiculoplasty, it works as an assembly from malleus to the Stapes head. It works good. For the Stapes surgery,
Guru, it works. Trust me.
Then how will you change your fenestra when you put a cartilage?
It has to be a much larger fenestra, either a partial platinectomy, posterior partial platinectomy, or at least a 0.9 millimeter hole.
Okay.
And a vein. And a vein 3 times. And a vein.
Okay. In a
The
case of
incus
regular
can be
malleus,
fashioned like a Y then? Can the incus be fashioned
No,
like a Y?
incus, no. I use a cartilage because again, remember that the static displacement is more, and when you have a cartilage, the cartilage is flexible and pliable, so the chances of fenestrating into the vestibule are much less than when you use a rigid assembly directly from the tympanic membrane to the oval window.
okay. Do you use the latest Coach MVP piston for that malleus tapedotomy?
You know what? I used to use it. And I tell you what happened in about 30%, that is out of 10 cases, 3 cases, what happened was that there was initially intraoperative and post-operative for a year or two, the fabulous results. And in the end of the 3rd year, I found that again you had a conductive loss. So when I re-explored, I found that the movements of the malleus had caused the angulation at the joint to actually pull away. So it's no longer in the oval window, it's just pushed out, just out. Then when you extend it again, it goes back in, but then again it comes out. So it just, because of the hinge, it just hinges on itself. So it did not work very well in 3 out of 10 cases for me. The other 7 are doing well.
But in rest it works well.
In rest it works well. But this one, each and every patient that I've done, trust my judgment, I wouldn't lie to my brother, is that Y-shaped cartilage with the malleus relocation works like a dream.
Yes.
Less than 50 dB airborne gap, even at all.
Superb. So for everyone, while doing malleus vestibulotomy, vestibulopexy, maliovestibulopexy, always use a vein graft, because the range of the malleus motion is more than the range of the incus. So those excursion can lead to SN loss very often, much faster than the regular incudostepidotomy. So vein graft is always used while doing a maliovestibulopexy.
Absolutely. Absolutely. Perfect.
Now the other question, Ashim.
Yeah.
when you explore rather than an autosclerosis, you come across the tympanosclerosis. The patient with a full conductive hearing loss, intact tympanic membrane, you explore for considering as a autosclerosis and turns out to be a tympanosclerotic pathology. How would you tackle? Would it change your approach or anything?
Okay, now again in this situation, often tympanosclerotic fixation is coupled with sometimes malleus erosion. All right? I mean incus erosion, I'm sorry, correction. So if the incus is completely intact, the ossicular chain is completely intact, and you have gross fixation of the malleus incus and stapes, there are two options open to you. One is to mobilize everything, put silastic around everything, and go in for a second stage stapedotomy after 6 months. The second option is to do the malleus relocation, which I just described earlier. And typically, when the incus is what I describe as moth-eaten, then the best option is there's no point in doing a two-stage procedure. The best
Ashim,
yeah.
Simplify. To simplify, if it turns out to be tympanosclerosis, if the lateral ossicles are fixed, how would you handle? If the medial stapes is fixed, how would you handle?
Okay, if the lateral ossicles are fixed, I would bypass the lateral ossicles, I would cut the neck of the malleus, and I would do a cartilage to the stapes. Okay?
That's it. Okay.
Very easy.
Yes.
Simplest of your simplification. If the medial ossicle, that is stapes, is also fixed, you have the option of doing a two-stage procedure if the incus is completely intact, because the incus stapedotomy at the second stage will give you a better result. And if the incus is moth-eaten, then you do it at the first stage, you remove the incus, you mobilize the malleus, bring it posteriorly, and do that Y-shaped cartilage on vein.
In any case, platinectomy is required.
Not
accidentally, you, while removing tympanosclerosis from the stapes, foot plate, if the foot plate gets mobilized.
In that scenario, if it is mobilized, put something on top of the foot plate. If it is subluxated, stroke, dislocated, you have to put a vein and you still use a cartilage. The cartilage is still the most reliable.
Okay.
If there is a fracture, then I would want to put a vein on top of it, and then you can put whatever you like. Yeah.
But in any given situation, you will not stage the procedure.
No. If the tympanic membrane is intact, you don't need to stage the procedure. Well, there's one question. Tell me. Yeah, of course. It is not heavy. You put it, you try once. Take my word for it, try it. The trick is that perfect measurement. I believe, no. See, the trick is that once, before you fenestrate the foot plate, you need to do the measurement of the Y-shaped cartilage. The way to do it is when you make that Y, the crotch of the Y should be the measure, you use the stapes measuring gauge and make sure that that is exactly halfway down that vertical slot. अरे सब कर सकते हैं.
Hashim.
Yeah.
In case you happen to do a total platinectomy, how would you handle?
What is the condition of the lateral ossicular chain?
Well, all incus malleus intact.
Intact mobile, then I will do a cartilage on, once there's total platinectomy, I'll put a little perichondrium. A perichondrium is thicker than vein, and do a cartilage on perichondrium. That is called the Pfalz technique by Professor C.R. Pfalz of Basel, 1968.
So you will use the Y cartilage again?
Yes, my friend. I'm very happy with Y cartilage.
Yeah, because after total platinectomy, if somebody uses the piston directly on a graft, since the inner ear pressure is more.
Boss, if you have a total platinectomy, you will have a late perilimb fistula.
Yes, because the membrane is going to bulge because of the high inner ear pressure as compared to the middle ear pressure.
100% right. 100% correct.
So we must use this cartilage. The cartilage is never going to perforate the vein. And Ashim, in any given situation, when you use the cartilage over the foot plate, like you mentioned, always make the fenestra bigger.
Yes.
And always use a graft over it.
Yes, absolutely.
Never on the directly on the vestibule.
Never directly on the vestibule. Yeah.
So
what is the size of the lower end of your cartilage strut? Is it almost the entire surface of the foot plate?
You're looking at about 0.6 millimeter or so, 0.6 to 0.8 millimeters, and you can use the measuring disc for that.
लगे
No, but the moment you say cover with perichondrium, we have platinectomy.
कमर लगा दी
Stage because the speaker said the perichondrium will have bulged out by the pressure of the perilimbs. So it is in fact counterproductive. Keep it down.
Hello, madam.
Keep it. हस्बैंड हमारे क्रिकेट प्लेयर हैं, हम खुद आएंगे मिलेंगे, फिर मेरे पास 4-5 दिन थे।
Yeah, please.
कौन से आते हैं?
अच्छा
आएंगे तो यहाँ पर
जरूर
वो और उसको बस
उसका
Is the foot plate fit? So then put the Y-shaped cartilage direct on the foot plate. Yeah. That's the easiest thing. I have a YouTube video on that. You can look at So when no, he said no incus, because necrotic or eroded, yeah. There's nothing there. On the foot, my eye works better than both for the hearing. The hearing is too good, most of them. Less than cap. Relocate. Anchored on the. It's a very niche.
Hello. Hello.
Hello. Yeah, Satish.
Yes, last couple of minutes. So, a few more questions if Ashim is there.
Ashim is always there, right? He's dying to see your surgery.
So Ashim, there is another question was not, I am taking only those which were not discussed. When would you, when patient asks you, when would you consider him to be fit to fly and how?
With a vein interposition, 2 weeks, I routinely do overseas patients and they are fit to fly in 2 weeks. I always do a tympanometry before I let the patient fly.
Tympanometry?
Yes.
If the patient asks or you yourself?
No, I do tympanometry at the end of 3 weeks in every single patient.
Oh.
See, I want to know if at all there's any vertigo while bringing up the pressure minus 400 to plus 2.
That's
How much pressure would you increase?
That's yeah, I would say the brave move from the Ashish to get tympanometry done from his own side. The reason being, see, this is very important to understand. What does tympanometry do? Tympanometry, by means of tympanometry, you create pressure, gradient in the extraoratory canal.
Yeah.
By means of a manometer by say 400 millimeter plus positive or 400 millimeter negative. Now what happens? This tympanometry is a great test, what Ashim said. So what happens once you raise the pressure in the extraoratory canal? To prevent that pressure being transmitted to the inner ear, God has given us, several mechanisms into the middle ear to prevent that. And the biggest one, the first one, the most lateral one to handle is the tympanic membrane. So, tympanic membrane, if you look at the architecture, is composed of radial and crucial fibers. The moment the pressure rises, the tympanic membrane fibers become taut. The more the pressure rises, the fibers become more taut, and at certain point of time, the fibers become like a wall. It doesn't go further taut. So like tympanometry, if you raise the pressure by 400 millimeter or so, this tympanic membrane becomes like a rock solid structure to prevent further pressure transmitting into it. Now what happens in a post-Stapes situation? A lot of, the defense mechanism is lost. What are the other defense mechanisms behind the tympanic membrane? One is the tympanic membrane. Behind, once the pressure rises, the malleus moves inside. The malleoinguinal joint transmits the pressure to the incus. And that joint dampens the pressure. So intact malleoinguinal joint is must to further dampen the pressure being transmitted to the inner ear. Then it goes to the incus, and from the incus, the incudostapedial joint again is a ball and socket joint, again dampens the pressure being transmitted to the foot plate. And at the foot plate again, with the high pressure, this stapedius tendon contracts, the annular ligament becomes taut, and it dampens further the further pressure inside the going into the inner ear. This is a normal defense mechanism God has given us. Now, what happens after the Stapes surgery? The inner defense mechanism is lost. The moment the pressure rises, the piston goes in. But after certain extent, the tympanic membrane becomes taut. Now, if your piston, which is going in for up to 0.5 millimeter or so by the highest tympanometry pressure, if it doesn't touch the inner ear vestibular structures, vestibular end organs, the vestibule and saccule, it is not going to give vertigo. And if it is not giving vertigo, means patient is fit to fly, fit to tolerate the, pressure excursions, you can say, the negative or positive pressure. So, Ashim, you are positively recommending tympanometry test.
Absolutely, because
and in case patient develops vertigo,
then you know that your piston is too long. You go in and re-explore before he gets SN loss.
You will re-explore. The patient is having good hearing.
Yes,
they have come to you to know whether they can fly or not.
And if
you have got a
do
tympanometry test, and tympanometry test is positive, showing vertigo,
I would definitely go in and shorten this piston, because remember that a lot of people live in 60th, 70th floor in Mumbai. So the kind of pressure changes in a high-speed elevator, if they end up getting vertigo and all, it's horrible. So first of all, the vein.
But my question is, patient coming to you asymptomatic, asking for fit to fly, and then develops vertigo with tympanometry.
If he gets vertigo with tympanometry, I will again do tympanometry using a Frenzel glass and look for the nystagmus. If there is a fistula sign positive, I will shorten the piston 100%. I mean, I've never had that, but if I did, this is what I would do for sure. Samir is here. Samir is saying hi to you.
Hi Satish, how are you? Satish.
Hello.
Samir Bhargav here. Hi, how are you?
Hi Samir, how are you?
I'm very good. So I've just walked in, so I am not very aware of the conversation before that. But to this question, whether one should do any intervention. So just like Ashim just now said that there are 60 and 70 story buildings. So we can ask the patient to take a flight up to the 60th or 70th floor. And if that patient does not have any problem, then maybe do nothing rather than intervene. Since you mentioned the patient is asymptomatic.
Ashim, just for our knowledge,
Yeah.
you said about this in 3 weeks. How would it be to wait for 6 weeks rather than do it for 3 weeks?
No.
Okay, your patient has a problem. Why not wait for 6 weeks?
What is going to change? This is your endosteal membrane is going to form in 72 to 96 hours, right? That's what your prayer is when you do a direct piston. And your prayers are usually answered over a period of years. You've been doing that, no issues. So what is going to happen between 3 weeks and 6 weeks? Only one thing you can do, which I have done for a very senior consultant's patient who had come to me, and with this vertigo, it was referred by the senior consultant. And what I did was I dehydrated the labyrinth. I gave them Diamox for 3 weeks.
Ashim, would your approach change? Ashim,
yeah,
would your approach change if you have done a direct piston patient or with a vein graft?
See, boss, you know I've done thousands, and with the vein graft, I've never seen this problem.
But you have done direct piston also.
If I've done direct piston and I see this problem, I will shorten the piston. You can ask me this question 200 times, my answer will not change.
But we can learn from you this fact.
So I know, brother.
Those patients.
A person who has vertigo with a direct piston, the endosteal membrane has not formed.
That means there is a fistula.
The
Most likely there is a fistula.
Exactly. That means the piston is too long.
Satish, I have seen the Fish Explorer case. He used, I think it was a gold piston, that in many years back it had come. And this particular patient, he had to, for every day, he had to go across the mountain in Switzerland. So when he would drive fast up, he would get that little sense of imbalance. And I've been in the OT, there was a granuloma on the undersurface of the piston. So he had
See,
explored it, yeah. But it was a gold piston.
if you have vertigo episodes, either there is a granuloma or there is a
But
fistula.
these were symptomatic patients.
Fistula remains asymptomatic. It may give in between vertigo. And a settled patient of, Stapes, after Stapes surgery, if in between vertigo, there is definitely a fistula. It
But
cannot be.
I would suggest the patient गोवा जाके आओ जरा देख के आओ क्या होता है फ्लाइट में या बैंगलोर जाके आओ. So if they get vertigo, they can. Package included, yeah.
See, what we can learn from this, at least to those patients who are challenging, who are more demanding in terms of, pressure excursions,
Yeah.
like frequent
Like pilot
flyers,
or crew, yeah.
frequent flyers, divers, the crew members, all those should be done with a vein interposition, just to stay on the safer side. At least.
I don't think I agree with that, but yeah, okay. I agree.
But at least.
I don't think that vein is just a...
No. The biggest advantage, I believe, see, the endosteal membrane forms even without using the vein if you don't use an overlong piston.
Yes, I think it's all about the
It is
length.
the overlong piston which is a disaster.
Yeah.
Now, in a direct piston technique, your piston measurement should be absolutely perfect, not to use an overlong piston, and the endosteal membrane is bound to form underneath.
Correct. But so
That's
even with the
natural
vein,
mechanism.
if the piston is long, it's going to give you trouble.
Yeah, then it's a problem.
That is 100% correct. I mean, with all due respect, length does matter.
Now, the biggest advantage of vein is it doesn't allow you to use an overlong piston.
No, ऐसा कुछ नहीं है यार. You can fucking shove the vein. It doesn't allow you means what?
And
You
means
can put a long-
if you try to
can
use
put
an
a long
overlong piston, the vein will invaginate.
Let it crumple, but it will crumple, it can go down. No, it doesn't mean it is going to prevent the overlong.
No,
It will give you a
prevent
visual
means
clue.
it wants you. It wants you.
Give you a visual clue.
Yes.
It would give you
That's
a
what-
visual clue, but believe me, if you're doing an endoscopic stapes, you're not going to be able to see that visual cue. Trust me. With an endoscope, that visualization of that invagination is not perfect. I've put the
ये volume चला दो. कहाँ है इसका? Volume चलाओ.
Is it not the crumpling of the vein that is the visual clue? Yeah.
Again, that is why I say that do the hanging and
Camera मत लाना.
test before you put the vein in.
Ashish.
Yeah, Satish.
So we are all set now. Patient with a right-sided nasal mass, no stopath, has some tumor.
Now Arvind and Amol are going to conduct this. And giving the mic to Amol.
They are free to conduct surgery as well. They have done many such cases in Jaipur, and we have done together.
अमोल बोलता है ऐसा चिल्लर बात नहीं करता है सर्जरी करने को बोलो ऐसा बोल रहे हैं.
They are both fantastic surgeons.
Super surgeons, yeah.
So, on करना light. Light on. Picture. Yes. Are you getting the picture now?
Yes.
So let me first. This is the primary picture without.
So Binny and Tanu, please take the lead.
This is without decongestion. See the angry-looking mucosa.
It is looking so vascularized.
Yeah. Then,
So at this stage, is your goal to map the tumor completely, or would you prefer early debunking
No, no, completely, completely. We have seen the limits.
Okay.
It is completely excisable whatsoever. It is not invading. It is unlikely to be malignant.
Right.
Even if it is, we'll follow all the principles and remove it wherever it is attached to.
Right.
So in one go would be a final cure. But yes, in general, we always take the advantage of frozen section.
Right.
That makes our life much easier.
Right.
इधर ध्यान देना यार. Right down.
So Satish, are you planning a modified denker in this?
Pardon?
Are you planning a modified denker?
Planning, your voice is.
Are you planning
Denker?
approach?
Modified denker being
Denker.
planned.
Let's see. May need a denker
Hmm.
because it is involving the medial wall completely.
Hmm.
Let's see how it is destroyed. How much it is involved. How much it is destroyed.
That benign, no, to touch.
I think he's done it.
Huh?
See, it bleeds on touch. It is.
No.
It was. I mentioned it was angry on surface because of the vessels.
Right.
Later. Section रखना पकड़ section में. So let's see.
Biopsy नहीं किया है क्या? Where are you going?
Sir, we do not have a histopath for this patient.
Pardon?
We do not have the histopath report of this patient.
No, 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 we don't have. Now see, the first thing what I'm going to do is, क्या कर रहे हो यार? Is surface decongestion.
Yes.
See the vascularity on surface which was bleeding on touch. And see the man of the match tool.
Coblator.
Coblator is the key.
Oh, it was anti.
Huh?
Because it was there. No, no. She may remember the time when you used to be against the coblator, but that was for adenoids, which he still maintains. Yeah.
It's
Sir, do
attached
you
to the
still
inferior
remove the
cabinet.
titanium wire in order to prevent blocking of the coblation wand?
Why no coblation for adeno?
Sorry, I don't think your question was clear. You were cracking a bit. Satish.
Yes, please.
Yeah, Tanu is asking you a question.
Sir, do you still remove the titanium wire?
Which?
कहाँ से?
So the coblator
In
wand.
the coblator wand to prevent the blocking.
Yeah. I remove the titanium wire that in between the. To widen the.
So this is the inferior turbinate, Satish, or the tumor?
Yeah, it looks like inferior turbinate.
This is a mass lesion which is the entire lateral wall is ballooning. Mass is there inside, it is ballooning. And see, it bleeds like anything wherever you touch. So that's the mass. And see, this is the turbinate. Everything is ballooning. So, suction रखना है यार. I'm just cutting the edge of the turbinate to see better. This is all mass inside. करना सर. See the mass.
10 minutes. Vivek, you want it out in 10 minutes.
Yeah. See the mass inside.
इसके लिए मैं इतना स्कैन देखता नहीं है.
See the mass inside.
That goes
See
for
the mass
biopsy?
inside.
Yeah.
Yes.
Yeah.
Take a biopsy यार ले ना यार. निकालो.
Yes.
निकालो ना.
Prasad is worried. It looks like something different he's saying.
See this? The biopsy I have taken.
कैन में bone erosion नहीं है क्या?
But उधर frozen नहीं होगा ना.
Sir, when will you suspect malignant transformation intraoperatively? Like in
Intraoperatively by frozen section only. See,
सतीश
you
बॉस थोड़ा
cannot
वाइट बैलेंस करेगा क्या? There's some
white balance.
जरा एक
अरे
बार
दो
करते
ना,
हैं, एक सेकंड में.
करता हूँ
Little
करता हूँ.
bit of focus. It's a little
क्या
blurred.
पैक करके रख, दबा के रख,
The
दबा के
blood
रख.
is blurred.
Okay. The bride ready? See now, the bride. पैक कर.
टेबल पे निकला तो मेरा पल्स रेट है.
है?
ऐसा ब्लीडिंग होने लगा टेबल पे तो माय पल्स रेट इज गोइंग टू गो हाई.
See now, you have to deal it effectively by removing it fast.
Yes. So you're creating space so that
Yes. See, this is the shell of the lesion. It is unlikely to be a papilloma.
Yeah, like, is it an olfactory neuroblastoma kind?
No, that
No.
arises from the olfactory
Yeah,
epithelium.
but that area looked clear, the ethmoid side.
Inferior turbinate.
Adenocarcinoma is one of the differentials coming up. Looking at the
Adenocarcinoma is little softer. It is not so vascular.
And the imaging would have shown us some erosions.
Or a
I
fibrosis
told you it
tumor.
was not convincing for the papilloma.
Yes, that you said.
Yeah, it looked like a smooth tumor, like a fibrosis tumor. You said it has a shell.
The way he was describing it on the scan, it looked like a.
It has a very, very solid, see this sort of ossifying element.
Yeah. And inverted papilloma will not bleed this much also, right?
Yeah, definitely. And inverted papilloma, they are cribriform
Yes, the
convolutions
look is
wherein
only very different.
in between is the tumor, in between is the mucosa. Convolutions of mucosa and tumor, laminar convolutions. This is a solid mass, nothing in between. And accordingly, you have to deal with it. The faster you remove it, better it is. See, this is the shell, outside shell.
Maybe an ossifying fibroma kind.
And see, we had seen it was not invading anywhere around.
Yeah.
See, the shell separates from the septum. See this?
yes.
He showed that good cleavage, no, on the images. राजीव ने ऐसे ही नहीं रखा सतीश के लिए केस. बायोप्सी नहीं लिया है. नहीं, आई डोंट थिंक ही प्लान. राजीव ने बायोप्सी का कोशिश किया था क्या? नहीं.
He says now the biopsy was inconclusive.
Clever. Very clever.
Wash. Now, it will come out in peak right up to the nasopharynx.
Folks, I'll give you one tip. If you all want Satish Jain to visit your center, all you have to do is arrange a cricket match. He will leave everything and come. And of course, you have to lose. You cannot win. Then you won't come again.
Oh, it's gushing.
नहीं कर रहा है, बातें कर रहा है. The debulking, this is just luminal clearance, nothing else. Imagine how solid it is.
Yes.
Here the cobbletter would not work. Only way is a good section and cobblation. Yes, the debrider. See, the maxillary sinus is compressed laterally by this tumor. We have seen on scan.
So the secretions were collected in the sinus, is it?
Yes, sir. That is behind the tumor,
Yes,
laterally.
okay.
Beyond the tumor. So we will go across the tumor and find the maxillary sinus. This is just luminal clearance.
So will it make sense to go transcentral and do an IMA ligation, reduce the bleeder, or just go ahead as you're doing right now?
Yeah, this bleeding will stop. IMA, first of all, you cannot find IMA unless you
Transcentral?
go through the tumor.
Yeah. No, the other way, like sublabial and
This bleeding is going to come to an end soon.
Is reducing. The picture is looking better.
Yeah, it will come under control. Non-stop debrider, your debrider suction should be strong.
Yes. And once the nasopharynx is cleared, like suddenly
See, now you can see the nasopharynx better.
Yes.
Yeah. I was
Coming in the
appreciating
picture.
the fact that the debrider never got blocked.
See, the nasopharynx has come in picture.
Yeah.
Yes.
Very, very solid mass. I'm just doing this debulking as fast as possible. Only way.
So there is always a concern about tumor seeding with aggressive debulking. Is it like clinically significant or just theoretical?
What?
About tumor seeding with aggressive debulking. Is it clinically
No. Tumor
significant?
seedling?
Yeah, that's what she's asking.
No tumor seedling can happen here. Once I debulk this, my rest of the job will be much, much easier. See how much
it's
we have
wise,
debulked this tumor.
Satish, do you think it's wise to take a deeper biopsy from there also as a second biopsy?
Yeah, I will take from the deep. Yes, right. Definitely, boss.
Suggestion by Samir.
Yeah. This deeper is more representative. Always. See this deeper one.
So this is somebody else is doing the suction, or
Pardon?
somebody else is doing the suction?
Yes.
Technique.
Yes.
Okay.
I have 4 hands.
Okay.
See now? Everything under control?
Yeah.
Yes.
For the debulking to reach to the level of the...
It was the surface which was bleeding more, not the core.
Yeah, the tumor itself will fall out. As we debulk it, separate from the maxillary sinus, I will remove that wall. Now,
That's a maxillary sinus, right?
see, hardly any bleeding now.
Yes.
Biopsy.
Now, give me a pack. Pack for a while. वो दे pack.
Sir, given the CT scan picture and the intraoperative picture currently, what will be your approach selection?
What will be the
approach for this case?
Yeah, this was clear cut, not extending beyond the limits. हाँ, पहले करता ही काम. So this was within the, your region of access. It was not crossing the limits of sinuses anywhere, but not crossing the orbital or the skull base limits. Very much endoscopically approachable, so nothing much was required. See now, just leave for a while. Now we'll come from here, because Denker is must now to go to the lateral limit. See the wall?
Yes.
See the way lateral wall is involved. See the turbinate.
Yes.
So now what I am doing, ये बंद है क्या? Section का है? See now I am
Have you sent for
following
a
this.
frozen? Probably being a Sunday may not work out, right?
Pardon?
Have you sent for a frozen? No, no?
Yeah, ideally.
Yeah.
See now, I am exposing the lateral wall beyond the tumor attachment. See this?
Yes.
Coming anterior to the coming anterior to this inferior turbinate, anterior to the tumor. See this?
Yes.
That is your limit. See, that is the level of the pyriform aperture you can see. ऊपर कर section. Yes. See the pyriform aperture.
Yeah, seen well.
See this bone which is affected. See this?
Yes.
We are above this bone. बंद हो गया क्या? Section. इसका. बोलना. See this? I will go lateral to this tumor into the maxilla head on. Periosteum. Periosteum. though. See this periosteum?
Yeah.
Now I am on the anterolateral wall. I want to come lateral to this tumor. See this wall? This tumor is attached to this wall. See this? So I will remove absolutely radical this wall.
Okay.
देना यार कॉबलेटर आधा घंटा हो गया ओके यार
You would be keeping a strut in front, right?
Pardon?
A strut of bone won't be kept, like for the internal nasal valve area? No.
No, he'll blast it all.
Okay.
Now this is the medially is the beyond the tumor in the floor. See this entire medial wall along with the tumor. This medial wall. पकड़ सिर पकड़.
Can I make a comment, please?
Yeah, please.
So this extended Denker's approach was so very helpful during COVID time when we were operating on mucormycosis. After seeing your live surgery videos,
नहीं वो दे पहले.
we were very confident in clearing the mucormycosis cases. It is amazing. It really works so well, and the disease clearance was
Or
excellent.
any paramedian pathology.
Yes.
It works like a amazing gateway. I am removing this anterior thin bone. My aim is here to enter into the maxilla beyond the tumor. See, I would like to enter beyond the tumor into the maxilla and remove this wall absolutely radical. Section kar idhar. See this?
Yeah, Satish, watching.
I hope it is
Yeah,
oriented.
very clear, all going well. So now the secret here is the retraction that the suction is doing.
Pani bada yaar. Now I am in the anterior wall of the maxilla. पानी क्यों नहीं चल रहा है? पानी डाल दो.
Yeah, now into them, yeah.
पानी नहीं आ रहा ना यार, क्या बातें कर रहा है?
छोटू क्या नाम है उसका?
क्या कर रहे हो यार? पानी डाल सेक्शन कर. See, I have made this opening in the anterior wall of the maxilla. This is my favorite stylus drill. To enter into the maxilla. See this?
Yeah.
Yes.
Now, दिखाओ.
So Bini, instead of sublabial, he's gone this way.
Yeah.
उधर. उधर.
Only Bini I know.
See, this is my maxillary sinus.
Yes.
What you had seen beyond the on the MRI.
MRI, yeah.
See this? The tumor is this side and the normal sinus on this side. Could you see?
Yes.
That's the normal sinus. See this? Absolutely clear?
Even the mucosa is unharmed, yeah.
No. Now I will remove this from upper kar. Retract. We have seen the tumor limit laterally. Yes. Okay. The beauty is this burr. This is transnasal burr, 4.5 mm. This is coarse diamond.
Yeah.
It has a 15-degree angulation, so my shaft is not coming in the way. And the speed is right now 60,000, go up to 75.
This is the stylus tip of legend, is it?
See how it cuts like butter.
Yes.
Okay.
And very safe. It is not cutting one.
What is this? It's a stylus of legend, is it? Or
Stylus.
$30,000, no?
In 5 minutes, I will mobilize it. See, my tumor is medial.
You're going up to the floor, no?
See what a drill it is.
Yeah.
especially for Denkers, this is good. Otherwise, the regular drills will damage the nostril.
Yes, because the shaft will touch the vestibule, yeah. This is the equivalent of a skeeter, actually.
Yeah. I was thinking the same, actually.
See now, the tumor is in our limits now.
Yeah.
See, that's the tumor.
Now you have to pluck it.
I will debulk it further.
No sign of the nasolacrimal duct there, like.
Debulk, keep debulking. Just keep an eye on the limits. See my limits?
Yeah.
See, why debulking? But mobilizing a bigger one tumor is difficult, unnecessarily inviting complications. Wash.
And it will be blind, the posterior wall.
The moment you debulk it, the mobilization becomes much easier. This is a solid tumor.
Yeah.
Yeah, solid one.
I had one. These were two different. Otherwise, how would I know? Implant tube, Paris.
For
the same tumor.
Different.
Crazy vascular.
See now the separation of the tumor from the surroundings. That's the most important thing.
Sir,
क्या
is there a risk of dental
सही
anesthesia
हुआ
or
क्या?
columnar retraction, talar retraction later?
Really?
Sir, I wanted to ask, is there a risk of dental anesthesia or talar retraction later?
Of course.
Tube सही है ना?
He
अब
avoids that.
सही है? So just wait for a while. Some anesthetic is changing the tube. दो. उसको भी. So we'll just wait for anesthetist. वो है. So meantime we can discuss.
See, there was a question by Ashima, Satish.
Yes.
Dental nerves, dental neuralgia. What about
Paresthesia.
paresthesia? Cosmetic deformity after big dentures like this. What about the nasolacrimal duct? Did you see it now?
Yes, it may happen if you are not cautious. See what happens. You have seen the pyriform aperture just now.
Yes.
A centimeter anterior to the pyriform aperture is the lower alar cartilage. Centimeter anterior to that is the lower alar cartilage. So if you are not careful and come more anterior, you may damage the lower alar cartilage and can lead to the deformity.
No, but even otherwise, if you remove such a bulk of the pyriform aperture bone, you have to warn the patient that there could be a scarring and retraction in that area.
So you have to prevent damage to the lower alar cartilage.
Mm.
But yes, if it happens, if you are not aware, not careful, if that happens at all, what ultimately you need to do is to reinforce with some cartilage later on, like any other lower lateral cartilage deformity. So that's not a major thing to tackle with, but yes, you have to be aware. You can certainly, almost certainly prevent. There are two major complications one can give while doing modified dentures. One is this lower alar cartilage deformity. Another is the nasolacrimal duct damage. So you have to deal with the nasolacrimal duct carefully in terms of preventing, in order to prevent fibrosis, you have to expose it thoroughly, go to the level of the base of the orbit from where it comes out to the level of the floor of the orbit. You have to come, and at that level you have to cut it sharp.
So would you
So
just
that it doesn't overhang below to get fibros. These are the two things you have to be careful while doing a modified dankers.
So will you marsupialize it or just cut it sharp and leave it as it is?
Cut it sharp. If, like in this case, it looks like this duct is involved in the tumor, then beyond the tumor, go up, drill the bone further,
okay,
open the duct or upper part of the sac, whatever, and then marsupialize it.
Okay.
It depends. Most of the time, when the duct is not involved in the pathology, you're cutting it sharp is good enough.
Okay.
So this is just to prevent epiphora later on. See, overall, you have to prevent fibrosis. And in our long series, rarely we get some patients getting this epiphora.
Yes.
And post-operatively also, when you cut it sharp and leave it open, ask your patient to keep massaging this lacrimal region from outside.
Yes.
The medial canthus of the eye, to keep pushing the, preventing the scar formation. So that is a good strategy.
Yes.
So most of the time you don't get that problem, but it depends upon the experience. Sometimes you can get, but the best way to prevent is to cut it sharp, flush with the orbital floor.
Yeah.
Flush means flushed.
Okay.
And it could be the blood clots inside also, which causes the fibrosis later. So like the flushing helps, like every third day for a week, it will be good.
Wash kar pehle. So let's get back. Yeah, telescope 0 degree. 0 degree wash. Yeah, wash कर. क्या? फटाफट कर रहा हूँ. Wash. ये लो, wash. Hello.
Yes.
Hello.
Yeah, we are with you.
Yeah, Satish, yeah, we are there with you.
Yeah. Are you there with the endoscopic picture now?
Yes,
Yes.
we can see.
So we stopped because of the anesthetic changing the tube and all that. Cobbletter first. हो गया अचानक. Cobbletter चाहिए पहले. Cobbletter का section. क्या करें यहाँ? देखो. Yeah. So we packed for a while because of see, just to reorient you. एक दोनों निकालने को. ऊपर पड़ा गया.
Yes,
This is the maxillary sinus, and this is the tumor which we intend to mobilize.
The mucosa is looking quite good in the maxillary sinus.
Drill.
Yeah, no good
This is a
observation.
hypertensive patient. The BP was, earlier also it is an elderly patient. So we stopped for a while for the
He's not elderly, he's
parameters
60-year-old.
come under control.
How old is he? 50.
Wait. अच्छा सुना नहीं.
Still the BP is very high.
रुको कॉफी तो पी के जाओ. मैं आ रहा हूँ. Welcome out.
उधर ध्यान दे.
See, Bini, this is what he does now. He'll follow the NLD.
पानी डालना है यार, बातें कर रहा है. But see, this is all tumor invading this bone, frontal process of maxilla. See this bone.
अभी सतीश मेरे को बोल इतना सारा तो एमआरआई बोला डिड यू एक्सपेक्ट द ट्यूमर टू बिहेव लाइक दिस फैट सप्रेस्ड ये सप्रेस्ड ऑपरेस्ड एवरीथिंग
But he did say like it did not show the
What did you expect?
features of papilloma.
Did you expect the tumor to behave this way?
Vascularity.
Ah.
Yeah, it was enhancing on contrast, but I told you in the beginning, it is not looking like a papilloma, classical papilloma.
That agreed, yeah.
Bleeding is because he is a hypertensive patient. Anesthetic doesn't want to lower down the pressure too much.
And elderly. And elderly, 60-year-old. Okay. So Narayan जा रहा है. He has a
living.
Okay. Thanks, Narayan. Thanks.
See now the plane behind. What I wanted to show. Why this? I didn't see this.
Satish.
Yeah, very clean.
Satish.
Yes, Narayan.
It was nice to see your surgeries. I have to go because I have to go back to the hospitals for a couple of small things.
Oh,
Okay.
Narayan, see you.
Chalo.
Thank you.
See, catch up with you sometime. Bye bye.
See this plane, everybody.
Yes.
Yeah.
That is the plane of the tumor. And see the maxillary sinus behind. That's the normal maxillary sinus.
Yes.
See this? This is how this tumor was. We could make out on scanning. See this? Yeah. See this tumor?
What is your gut saying? Generally, you have a histopath diagnosis.
No, difficult. This is funny.
Funny.
See this? Nasolacrimal duct.
Oh, that's an LD.
I will cut it sharp above. Later on, I will define it. Cut the scissor. See the frontal process of the maxilla above is bad. Not looking good. Here I am cutting here. Later on, I will cut it
Further.
flush. Right now, separating from the tumors. See this tumor is coming out. This tumor is free now. Yes. The tumor is free now.
Yes.
See this? Packing. Mm. 1 minute, boss. See the whole tumor.
Yeah.
Boss. This will pack for a while. Boss, मेरे को दे.
This is all because of the lady moderators. Turned out to be a very unusual opinion.
See the maxilla? Hello?
Hey,
Yeah.
but such a bleeding mass who took out in no time. 20 minutes?
See the entire tumor out.
Yeah.
The brother.
वो क्या है? Posterior to the maxillary?
हो गया. See the entire tumor out.
Yeah.
That's the wall of the maxilla, and that's the maxillary sinus.
Yeah.
Was it attached to the posterior wall of the maxilla?
See, the all ethmoids and everything all good behind. See this? Only thing is this, yeah. This is the nasolacrimal duct, which I will cut flush after drilling this part of the maxilla, which is bad. So just pack for a while.
Guys, at the end of this
Again, the PP is
surgery,
shifting. See, this is an
outside in
anesthesia
that lounge,
challenging
we'll do some little
patient.
cleaning, okay, before you
So we
disperse.
have to pack it again for a while. Jano jaldi.
Okay.
Yeah. So just we'll pack for a while until the anesthetist permits. See, now the last part would be, if time permits, will show this drilling this bone a little bit and cutting the maxilla at the level of the roof. Do you see there?
Yes, yes.
That's the last part. Let's see, we have to pack because this patient is not stable, has hypertension, getting arrhythmias. Anesthesia challenge, so we have to wait for a while.
Thoda sa we'll wait.
But by and large, you have seen.
Yeah.
Rest of the tumor has been removed. See this?
We could go off air also.
Surface all around, not involved. Only this medial wall which was affected.
The floor looks clean. The floor.
Hello?
It's free of tumor. Yeah. This is the. She's asking, is the floor looking clean?
Hello.
Yeah.
Hello.
Hello. Yeah.
Just will come back after a while when the anesthetist permits.
Yeah.
Hello.
So we have. Yeah. Hello.
Yeah, Ashish.
Yeah, Satish. Yeah.
We have to wait back for a while until the
wait
anesthesia.
for a while. Yeah.
But you got the idea. The tumor has been removed.
Absolutely.
We went behind the tumor in the maxillary sinus from laterally.
Yeah.
And removed and block. Now the only thing which is, it is on the frontal process of maxilla. So we have to drill that bad bone which is under vision.
Under vision, yeah.
And then cut the NLD flush to the floor.
Yeah.
That's
Flush
it.
to
The tumor
bone,
part
yeah.
has been removed. Tumor part is already removed.
Already gone, yeah. What we'll do, Satish, we have our dear friend Hirak Bose. They are actually from Lupin. He is in Bangkok right now.
Yeah.
Ganguly, okay. So Raja Ganguly will be there. He's already online. Okay. Ashim, Raja is going to wish you a very happy birthday. He's going to come. He's in Bangkok actually with their marketing team. And they'll say hi to us. So jab tak we are waiting, chalo lao Raja ko.
Yeah.
Hi Raja, hi. You are in Bangkok?
Hi sir. Yeah sir, we are in Thailand.
So thoda baju ka dikhao, show us the girls.
I can show you the sunset.
That is why the background is blurred.
I can show you the sunset. Can you see?
Show us the action after the sunset.
Sir, happy birthday.
Thank you, Raja. Thank you so much for organizing all of this. I really appreciate all that you've done. And you know very well, we've been collaborating for a long time. And Ashish has such, and me have such high regard for you and Lupin. Really want to place on air my sincere appreciation for all the support that you've given us over the years. And it's been a joy. And I do wish you were here so that we could felicitate you in person. But I think you have better company out there.
Yeah, we are in an annual budget meeting, sir. So, we really missed the show. But I mean, it's a long-term process. It's a long journey which we are going to have. So, Lupin will always be there with you. So, my heartiest congratulations to AY Thane, Dr. Sunil Budlani, who has really worked hard in organizing the thing. And of course, Dr. Ashish Bhumkar, Dr. Asim Desai, Dr. Satish Jain, of course, and they were very instrumental. And of course, the entire format of the program was such, which we have discussed before the program is really very exciting and interesting. We would love to be a part of such programs in future also. So my heartiest congratulations and best wishes to the entire organization as well as to all of you.
Thank you, Raja. Next week, should we do one next week?
Yeah, I'm there, sir. I'm there. I'm always there. As when it comes
Raja
to
Ganguly
disseminating.
is the Rajesh Khanna of the pharma industry.
Oh
The
my
handsome
God.
man, and his wife is like a movie actress.
Oh
Great
my
couple.
God.
Yeah. Thank you, Raja.
So thank you so much, sir. Thank you so
We
much.
had a great flawless things. Thank you so much.
Yeah.
I really wish you were here present,
Yes.
and thank you so much. Yeah. And
Same here, sir. Same here.
anybody interested in allergies, Lupin is
Yeah.
there to support. They have a big initiative. Catch them young and take them to the old. Whatever. So very big, strong on allergies. Safina, raise your hand. She's your next star from Bangalore for allergy, Raja.
Okay.
Tell your
Yeah,
Bangalore
yeah.
team, yeah. She's going in a very big way
Absolutely.
in allergy. Yeah.
Absolutely, sir.
It
We'll
is
be in
my
touch. And
It is my pleasure and privilege to also say that Lupin works very closely for allergy with Evexia. And so what Lupin does is organize camps, allergy camps, and Evexia comes and helps. And Lupin has been instrumental in that. And again, I place on record my sincere gratitude to you, Raja, for spearheading and Hirak for spearheading this
thank you.
progress. Thank you so much indeed. And people who are interested in allergy, I do believe, as Ashish correctly said, that Lupin is happy to handhold you through your steps. And Made in India is by Deshbandhu Gupta, the chief of the late chief of Lupin, the man who made it all happen. And I think he has certain ideas by which all corporate bodies should learn and follow in his footsteps. Thank you.
Thank you so much, sir. Thank you very much. And thanks for reading the book
Yes.
because, you know,
Yes, sir.
so I'm sure in future also, sir, we
Yeah.
will have a very long associations. And whenever there is a, you know, knowledge, dissemination of knowledge, Lupin will always be your partner, sir.
Thank you.
That's
Thank
a
you,
promise
Raja.
from our end.
Thank you. Thank
Thanks
you
a
so
lot.
much.
Thanks a
Thank
lot.
you.
Okay. Bye, sir. Bye. And Hirak sir has also conveyed his regards and congratulations to all of you. He's actually taking a session right now. He said, "Ki either of us have to take." So I said, "Ki, okay." Oh, we made a toss and then it was decided you go and you know, attend.
Wonderful,
So
wonderful.
thanks a
Thank you
lot.
so much. Much obliged.
Thanks a
And
lot.
I need to catch up with you soon. Take care.
Sure, 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 sir. Thank you. Thank you, sir. Bye. Bye. Bye.
I think, yeah, thank you. I think, we'll have to call it off because we have 10 more minutes left. We have to vacate the auditorium and we have to do the cake cutting thing. Satish, I'm sorry. We will say bye to you now because 5 o'clock, this is a bit of a.
Okay, 10 minutes to 5 now.
It is 10 minutes to 5 and we have to get out because there's some other event at 7 o'clock.
Otherwise, we'll continue telecast. Actually, we'll take 10-15 minutes for the patient to stabilize again.
Yeah.
Some
No, that's okay. I think
hypertension.
we saw the tumor removal. Now you're just going to drill away the
I would
bone,
show
right?
that nasolacrimal duct cutting otherwise. And
Yeah.
most of the part is done.
So Benny, I think you understood. He's going to
Yeah.
just cook it up to the bone, but first he'll drill away the bad bone and
I
flush
said,
it.
like,
So
do we get time to thank Satish? Like, he has been
you
operating
please
like
go ahead and do now.
wonderfully from the afternoon. It's like so many take-home points.
Yeah.
Like any surgery you watch from Satish, like there'll be at least 5 to 10 take-home points. Wonderful. Thank you so much.
Yeah.
Thank you,
Satish.
everyone.
Tanu, where are you? You're
I'm
not on the screen.
yeah, sorry, I am here.
You're with your baby. Okay, hi.
No,
She's a
yeah.
young mom of 1 month, 2 months, 6 months. How many old?
3 months.
3 months. She's
Yeah.
just had a first baby, 3 month old. Good.
Yeah.
Nice to see you.
Yes, same. Likewise, sir. It was a pleasure being here.
Good, good. We are
Yes.
looking forward to you come back into mainstream.
Yes, me too. Me
Yeah.
too.
Great.
Bye.
And Ashesh, like, may your friendship grow stronger. Like, I was feeling very jealous, like seeing the three of you, like, may it grow stronger day by day.
Thank you. Thank you, Vinny. Thank you. Yeah.
Lovely program, sir.
Yeah. Thanks, Tanu.
Yes.
Thanks. So we're going to go out and now, unfortunately, the camera is not there. So you'll miss the
Oh,
cake cutting.
no
And
problem.
they won't allow the cake to come into this room.
Okay.
No problem, sir.
And
Bye
thank you,
then
to
from us.
audiovisual
Yeah.
team, Dinesh.
All of you.
Thank you. Thank you, everybody.
Yeah. Bye.
Bye.
Thank you so much, Dr.
Thank you.
Ashish.
Thank you. And everybody online who's been watching, thank you for being there. And happy birthday, Ashim, one more time.